having this feeling of grand feeling of standing on the stage itself.
Usually it's even our pressing 45 to 40. But yesterday, maybe it will happen anything on that. But anyway, remember that you watched. Yeah, there is a virtual audience.
Yeah. Shall we start? Good morning, dear friends. Today we are having an important workshop section on hypertension. We all know that hypertension is one of the important topics since it has a lot of cardiovascular risk and other risk also. So for this, the great workshop, we have the three eminent speakers and moderators, Professor Muruganathan sir and Dr. Balamurugan sir and Rajiv Govil sir. I'm now happy to introduce Muruganathan sir. Can you upload the Dr. Muruganathan slide? Yeah. So Dr. Muruganathan sir is the awardee of Dr. B.C. Roy Award 2005 as the Governor of American College of Physicians and Indian Chapter Dean, Indian College of Physicians, ICP 2016-2017. Is the president of this Hypertension Society of India and is the president of our API 2013 and 2015. Welcome you, sir, for this days. Welcome you, sir. And I want to introduce the next speaker. Balamurugan sir is the Chief Diabetologist, Kobe Diabetes Specialty Center and Hospital, Coimbatore. Welcome you, sir, Dice. And happy to introduce my close friend, Dr. Rajiv Govil. Dr. Rajiv Govil is a consultant of the Dr. Kobe's Diabetes Care Centers. He is having 2 branches in Mumbai. He's a great diabetologist and is having Holy Spirit and Arogya Nidhi and BSS hospitals. He's a founder member of United Diabetes Forum. Welcome him, sir.
Thank you.
Good morning, my dear brothers and sisters. I'm very happy to be here in the debate to start the first workshop on Sunday. At the outset, I thank Dr. Krishna Sheshadri, Dr. Aravind, Dr. Sanjay, and all the dynamic organizing committee. And also, I have great pleasure in welcoming 1,000 and odd viewers in the online. Today, we are going to talk about an interesting topic, difficult to treat hypertension. Every day, every practitioner definitely gets 1 or 2 cases in his practice of hypertension. Many a times, the hypertension control is not there in the patient, in the clinic, in the hospital. So what are the reasons? That's what we are going to discuss. It's going to be an interactive session. With me, I have my brother, Dr. Balamurugan and Dr. Rajiv Govil. We'll try to make it more lively and interesting. So let me start with one case. A recently married 30-year-old male executive of an IT company, a non-smoker, no comorbidities, Complaints of severe mental stress at work and fatigue. Presently, BP is 170, 110. Routine blood investigations, ECG, echo are normal. What will you do? You reassure, anxiolytics, start on antihypertensives, or ask him to resign the job. This is what we are starting with the first case. Any takers?
Start on antihypertensive. So what do you say?
Yes, that is very good, because many times when you say patient is anxious, they say anxiolytic. Not necessarily you should do that, because when the blood pressure is more than 160, you definitely must start. I'll come to the next question. Before you say 160, 110, make sure they have taken the BP accurately, because accurate reading is the key. If you ask me how many percent of the people they take accurate reading, it's only 1%. 99% the accurate reading is not there. That is why first you must take good accurate reading. And then once the BP is more than 160, 110 or 100, you should start drugs. And that too, if there's 160, 110, you must start. You should not leave only with the lifestyle. You should start drugs. I mean, these are the conditions. I mean, precautions. What you do, especially when you do a home blood pressure monitoring or checking the blood pressure. All of you know that take all clothing of the upper arm and put cuff. Then sit on a chair, back supported, on a table at heart level, feel flat on the floor, wait for 5 minutes. I think all of you know about this, because every guideline spends at least 5-6 pages on how to do an accurate blood pressure measurement. So every practitioner should know, and every practitioner should teach the patients as well as the paramedical as how to check the blood pressure. Okay, in that case, how will you manage? Will you give beta blocker, calcium blocker, ARB or ARB and calcium blocker? Which one you prefer? Yes, that's good, correct. So it is beta blocker and calcium blocker. Very good. Now, the plan of this workshop is, we are going to talk about what is difficult to control hypertension, why does it occur, how to evaluate, how to manage it, and some takeaways. See, the recent guideline, international hypertension guideline says, target BP reduction for 65 years, less than 65 years, 130/80, and above 165, or above 65, it's less than 140/90. And you should achieve the target at least within 3 months. If not, at least, you have to reduce from the baseline 20 systolic and 10 diastolic. If you cannot achieve this, this is called difficult to control hypertension. So this is the causes of difficulty. If you see, the non-adherence and drug-related causes contribute 74%. So non-adherence and then drug-related causes you will have to rule out before you do before you say this patient has got difficulty in treating hypertension. Then secondary hypertension forms 5%, and then the interference substances 1%. What do you mean by uncontrolled hypertension? See, that this is a terminology maze. Any blood pressure which is out of target with 1, 2, or 3 drugs, this is called uncontrolled hypertension. You are giving somebody 1 drug or 2 drugs, still you are not able to achieve the target. This is called uncontrolled hypertension. What is apparent resistant hypertension? Apparent hypertension, the resistant hypertension is blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive drugs. One of these agents should be a diuretic, and all agents should be prescribed at maximum tolerated dose. Then among with patients with apparent hypertension, apparent resistance, there is again true resistance and pseudo resistance. Patients whose blood pressure is controlled with 4 drugs, it is called controlled resistant hypertension. I'll give you all that on one slide. If you see the first patient on 1 to 2, 3 drugs, not controlled, that is uncontrolled hypertension. And then if the patient is given 3 drugs, as I said, one of which is diuretic, then it's a resistant hypertension. This is apparent resistant hypertension. You rule out pseudo resistant, and then 2 resistant hypertension control with 4 drugs. Suppose if the patient is not able to be controlled with 5 drugs, this is called refractory hypertension. So the terminology maze. So all these things come under difficult hypertension. So refractory hypertension, I already told you, 5 drugs, and one of them may be chlorthalidone or spironolactone. The patient with refractory hypertension, sometimes even with 5 drugs or 6 drugs, the blood pressure is 178 and 103. Based upon the persistently higher heart rates, the lack of response to intensive diuretic therapy among patients with refractory hypertension, the authors suggested that treatment failure in such patients may be due to neurological mechanisms. Whereas resistant hypertension is more of a sodium and volume. This is neurological, especially sympathetic overactivity. This contrasts with conventional thinking that resistant hypertension is largely due to persistent hypervolemia. So this is the understanding, slides. Now, the resistant hypertension prevalence is 21%, and then out of which uncontrolled resistant hypertension is 32%, controlled resistant hypertension is 65%, and 3% is refractory hypertension. So with this, I will talk about pseudo-resistant causes, and then I'll ask my colleague, Dr. Balamurugan, to describe about the pseudo-resistant cases and the physician's inertia, etc. The first cause is the physician inertia, because many doctors think they are satisfied with the current BP, especially 150, they say, okay. And use of soft reasons, they time constraint and competing priorities, and reluctance to use combination therapy, and lack of knowledge. And the patient has got comorbid, they are worried whether to reduce at the target. And this is the physician inertia. If you see, only 10%, 10 to 13%. Oh, this is if you see 10 to 13%, they are happy if the patient has got 140 or 150. They say it's okay. So more than 23%, they are not aggressively targeting the required goal. So this is the physician's inertia. And if you see 1 year, how many patients take drugs? Somebody takes only 38% diuretic. If you prescribe diuretic, if you see the statistics, only 1 year they take 38%. Even the well-tolerated ARB, they are taking only 64%. That means at the end of the year, many people, they don't continue the treatment. And the drug-related causes, you remember 7 I's: improper selection, inadequate doses, improper combination, inadequate absorption, inability to give 24 hours protection, intolerable side effects. And then, of course, all of you know weight coat hypertension. The BP in the office or the clinic is more when they compare to home BP. So now the international guideline says if somebody comes with 140/90 in the clinic, don't judge immediately as they are hypertensive. At least you should take one outside BP, either in the home BP or ambulatory blood pressure monitoring, before you label them as hypertension. And this is, of course, the pseudo hypertension oscillus maneuver. This is very important. This is pseudo systolic hypertension. Many times in elderly patient, because of the vessel change and the vascular stiffness, when you raise the blood pressure over the systolic blood pressure, is it working? How do I can't? It's working, but yeah, can I
Do it here.
Huh? Well, I think we should do that. Yes, correct. Okay. Before that, see, when the systolic hypertension is more, you must always think, especially elderly patient, because of the arterial stiffening, what happens was, even if you raise the systolic blood pressure more than the pressure, the arteries do not get collapsed because of the thickened cord. So when even if you are raising the systolic pressure more than the pressure what the patient has, even then it is not collapsed. So you feel like a thickened cord. So this is called oscillus maneuver, and that's especially in elderly patient, you get pseudo pseudo-systolic hypertension. So you must rule out by Osler's maneuver. So these are the causes of pseudo-resistant. I already told you improper blood pressure measurement, heavily calcified atherosclerotic arteries that are difficult to compress in elderly patient, white coat effect. These are the poor patients. So these are the doctors and these are the patients, like the memory loss, psychiatric problems, cost of medication, and then inadequate dose, and physician's inertia, that is failure to increase the dose regime. So before I go to the case 2, I think I request Dr. Balamurugan to present his case. Okay. All right. Okay. So
You can take up the next case also. Time is there. I can come.
okay.
Yeah.
So case number 2, 56-year-old diabetic obese postmenopausal lady, also on treatment for high blood pressure since 4 years with atenolol and thiazide with uncontrolled blood pressure. I told you what is uncontrolled hypertension. When you give 2 drugs, even there the blood pressure is not under control. So we are giving atenolol and thiazide. So now what is the problem in this case? What do you say, my friends? What are the options? Whether you increase the atenolol, thiazide, or change atenolol, thiazide, continue the same drugs with strict lifestyle modification, or you would like to refer to somebody whom you don't like.
Option B, sir.
Yeah, you should change. Very good. Atenolol and thiazide. Because beta blockers and diuretics, as the initial combination diabetics, has both increased insulin resistance. So beta blockers and the diuretics is not a good combination in diabetic. Of course, if you have to use beta blocker, you should use newer beta blocker, not atenolol. They can use ACE or ARB. With the ACE and ARB, they can be used. Which is the correct approach? Change to ACE ARB, change to carvedilol, try carvedilol and ACE and ARB, or carvedilol and diuretics. Any takers? Yes, very good. C. You must try carvedilol and ACE and ARB, because carvedilol is supposed to be insulin sensitive. Most of the beta blockers are insulin resistant. So ideal beta blocker, especially if they have compelling indication, carvedilol is the drug of choice. If BP is still not controlled, what do you add? If you want to add some diuretic in a diabetic hypertension, which diuretic you prefer?
Indapamide.
Indapamide, very good. So indapamide is the drug of choice in especially elderly hypertension, and it is proved that indapamide is very good, especially is lipid neutral also. So third drug always diuretic, if not used already. Indapamide is preferred diuretic in diabetes as it has got least metabolic disadvantages. If diuretic used already, it should be a calcium blocker. If already you have used diuretic, then you add the third drug as a calcium blocker. Don't combine ACE and ARB and aldosterone inhibitors like aliskiren. So which diuretic? Isolated systolic hypertension, thiazide, LVH, indapamide, edema, renal failure, torsemide or furosemide, refractive failure, metolazone, better tolerability in chronic renal failure, torsemide, chronic heart failure, sleep apnea, spironolactone, acute MI, heart failure, if there is a gynecomastia, eplerenone, resistant hypertension, spironolactone or eplerenone, sleep apnea with high blood pressure, spironolactone or eplerenone. These are the diuretics which you use in various conditions. So I request my colleague Balamurugan to continue his case. Then Dr. Kovil will discuss. Then we'll come again. And if you have any questions, interactions, you can put it in your chat box also. We'll be able to answer all your questions. Now I request my brother Balamurugan to continue.
Here or here?
Pointer.
Okay. Can you put my slides? Not required. I think you can.
Not that is mine.
Yeah.
Okay. Good morning, everyone. At the outset, I would like to thank Dr. Krishna and the Primer team for asking us to travel after 1 year experience with COVID and trying to have a trial run of challenging the COVID and trying to conduct a physical meeting. I really appreciate the courage of the Krishna and team, and also thanks for the opportunity. And thank you, my brother Muruganathan sir, for nicely setting up a context for this workshop on difficult to treat hypertension. We generally, when you think that very complicated hypertension, very, very rare to diagnose hypertension, people think they know. We think about a lot of syndromes generally. There is so many syndromes which we have fancied, and our professors were fancied, and they ask in the examination. So a lot of syndromes only come to our mind when rare cases of hypertension. But our discussion, or scope of discussion, we are going to mainly concentrate. What are the practical difficulties where a clinician or a person involved in managing hypertension should know? And what are the common errors? What are where is the lacuna and the barriers in controlling the hypertension? Is there any specific situations? So we are going to have one case scenario like this. Here is a 74-year-old male, hypertension for 10 years, and type 2 diabetes 5 years, and recently recovering from a cold. Lives alone and occasional drinker and no smoking. Very important thing is not compliant with the diet, as most of the patient do. And as he's 74 years, he's also has got I think, osteoarthritis of the knee joint, most likely, taking medications for that. Why we are giving a history on a medication? And because Dr. already, Dr. Muruganathan sir has put a set a prelude that
I think it's very good that you have elicited a history of the drugs, what they're taking, because many a time, as I said, the interfering substances also can produce resistant hypertension.
Exactly. So there is a very purpose of this first case is one such a points, and many a time our patients take not only our allopathic drugs, okay, for hypertension and for arthritis and all the other things. Our country, we have various systems of alternative medicines also. So people will be taking multiple alternative system of medicines, homeopathy, or Ayurveda. Sir, I am taking that. Sometimes people will say, or people may not say, and they say many a time there's a very strong belief in everyone, including educated, uneducated, everyone, that only the allopathic medications.
I think your point is very correct, because especially the COVID times, many people, even educated people, they are taking some homeopathic medicine which contains arsenic and all that. So hypertension becomes resistant, not because of their drug, their disease, even with the drug what they take.
Exactly, sir. And people strongly believe that taking allopathic medication causes complications, and none of the other alternative system of medications do harm. That's a very, very staying thing. And in diabetes also something same case comes, and people come and ask us, sir, does this medication cause a kidney damage, this medicine for diabetes, blood pressure? So on the contrary, we have seen many a time people coming with the alternative system of medication, and sometimes not to discourage or not to complain about someone. Many a time the alternative systems, they do not come with the prescriptions also. Many a time, the patients are given some medication, put in the bottle, and so it's such a very risky thing. So history of the medication, not only allopathic medication, same time other system like herbal, Ayurvedic, Siddha, and homeopathy, Unani medicines. Because recently we also had a patient who had some alternate system of medication for a few years, thinking that harmless. He came with the renal issues.
Yeah, in fact, any hypertensive patient, history taking is very important. You should not forget the clinical medicine. So history, when you take history, many times you get the clue. 50 to 60% of secondary hypertension, by history alone, you can find out this patient has got secondary hypertension. So history taking is very, very important, especially in hypertension.
Many times when when we were students in medicine, from third year morning, early morning, 7 a.m., we used to go to the OP, all the chiefs, and we used to fight for the places to listen to the classes and examine the cases very enthusiastically, history taking. Until today, I used to tell all our friends and younger colleagues, still definitely the history taking, even the advent of so many investigations to diagnose, a very, very, very carefully elicited history is very, very important in making any diagnosis. Credit to you, sir. And this patient, continuing with the case, this patient has got a very limited physical activity. Obviously, you might ask me a question, he's a 74-year-old man, and what sort of physical activity he can do? But there are different exercises which are prescribed based on your comorbidities, irrespective of the age. There are different exercises which physical activity we can do. It all depends on the mindset and the complication, and you should take the advice of your healthcare professional on it. And he has got a less social support. Mind you that India is a country we are very proud of, that one of the countries still to a reasonable extent, the family support and social support is extended to the elderly population, unlike the other countries, but this is slowly coming down. So this is individual, you can, I said, no, elderly individual with hypertension and diabetes. Why we know about the diabetes also? Because you might be taking number of drugs for diabetes also, and not complying with the diet and not doing exercise, and the treatment history.
One point of interest, patients with diabetes and hypertension, the adherence is better than a non-diabetic hypertension. So we have found out in a study, 8,000 people we have surveyed. People with diabetes, they take sincerely the hypertensive medicine than a non-diabetic hypertension. Yes, please proceed.
By and large, we find the compliance level and the treatment, general health care is far better in diabetic patients compared to other. Because unlike hypertension, other schedules, most of the diabetic clinics and they have a set of follow-up guidelines. And when a patient comes with diabetes, not only we check the blood sugar and send, most often we check the weight, most often we check the waist to hip ratio and blood pressure, a simple eye examination, clinical examination, and an ECG. Such things are routinely done, okay? And a lipid and a urea creatinine. Even when a patient comes for the first time, at most of the clinicians, they do. So basically, we will get an idea that do we have any other complication, and a well-educated diabetic patient lives long. There's some data.
Go on.
And so these patients with a treatment history, hydrochlorothiazide, carvedilol 12.5 milligram, and Mucinex D tablet, and naproxen tablet, 8th early, and metformin 500 milligram BID. This is the drug history and clinical and biochemical. The blood pressure is according to the definition on a higher side, 162/90, reasonably normal heart rate for his age. Weight is on a higher side with a little higher BMI 26.8, and sodium is also on a higher side, and almost the lipid has got a reasonably, LDL is 99, but creatinine is 2.2, and uric acid is 6.7. So what are the problems with this case in this patient? Definitely the BP is not on a target, and he has got comorbidities like diabetes as well as the renal involvement. And because he's a diabetic, his goal should be less, and considering his age, there's an allowance. Despite the triple antihypertensive therapy, the BP is not optimal. And how do we approach it? And what ideal agent to choose for this patient? Poor compliance with the lifestyle modification, mainly diet. Why I wanted to put this case is because many a time people think, the drugs do wonder, but we have seen in diabetes and hypertension, the lifestyle modification does wonders. Even though it's the compliance level of lifestyle modification is very, almost in a well-educated patient, it's only 50%. So if you're able to follow at least 50% of the lifestyle modification in terms of diet and exercise, and if you're able to reduce your weight and reduce the salt intake is a very common issues. And many a time many people think, we are all taking normal salt, okay, quantity of salt, but we take in excess, and normally we take more than 15 grams to 20 grams of salt per day is a survey. And the salt intake is very important issue with the hypertension management. So patient have to be educated on that. So when a patient is not, a blood pressure is not a control, one of the histories you should take salt intake, then family members, and properly guide them on it, and try to encourage a physical activity from the based on the comorbidities and the conditions. Probably if
You are right. In salt intake, they think only table salt on which they are taking during diet. There are a lot of diet, they take processed food outside that contains fast food, more salts. So we are allowed only 2,300 milligram as average. But only in hot summer, in an elderly patient, when they are on diuretic, you can be a little bit relaxed. Otherwise, you should be very strict, 1 tablespoon, which is 2,300 milligram salt. And the best history, ask them about processed food which they are taking outside, like pickles, uppets, and puppets like that. Yes, please.
So the simple thing advice I give it to all my patients is avoid adding salt on the table. If you avoid taking adding salt like pickle, puppet, some people take dry fish or such a thing. If you avoid that itself, to a reasonable extent, extra salt is avoided. Avoiding taking salt to curd or buttermilk. These are the things that they need to avoid. If you do that, definitely to a reasonable extent, the salt intake can be reduced. And again, what is an ideal agent to choose for a diabetic patient? Already Sir has also said various guidelines. We are all, as a lot of diabetologists and endocrinologists have come here, as well as they joined virtually, and all of my colleagues will know that the ACE or ARBs will be the first choice in this patient. On the contrary, you can see what the patient is on here. You can see he's on carvedilol hydrochlorothiazide. Why hydrochlorothiazide may not be much glycemic friendly. So such a patient, can we use a clothalidone or if required, indapamide? Okay, indapamide comparatively less interference with glycemia also, and reasonably well tolerated drug. But one of the problems with these diuretics is the hyponatremia. It's also one of the issues, and indapamide can also cause that. Just keep in mind. And why I'm talking about the hyponatremia in this case is even though this sodium in this person is normal, and elderly patients are at the risk of assessed diabetic per se, on long term they can have dilutional hyponatremia, and they can come with altered sensorium. When a patient comes, and any diabetic patient comes with an altered sensorium, first we know that it's hypoglycemia to be ruled out. Second one, hyponatremia is to be considered. So hyponatremia need not be treatment related. As such, there might be loss of thirst mechanism and food intake, all the things. Hyponatremia is there. So
coming back to your ideal drug, the ideal drug in hypertension, if they have proteinuria, the best drug is ACE or ARB, the first line drug. And then second, you add calcium channel blocker. And if they have got compelling indications like cardiac problem and angina, then you will have to start beta blocker. Mostly that carvedilol will be better.
If you want to choose a diuretic, indapamide is better.
Yes.
Because sometimes when an elderly patient, isolated systolic hypertension, we are left out with much clue, and to do that. And so here, one of the important factors, as Sir was telling, the interfering substances. I was telling about the alternative system of medicine. It's allopathic, many of the allopathic medication, and many a time people take steroids. Sometimes a doctor would have prescribed steroid for a particular condition for a short while, okay, for a knee joint pain. But the patient continues to buy in the medical pharmacy. In our country, I think still the over the table purchase of all the drugs are happening. The steroids are also given freely, and every time he will go and buy tablets, and this can increase the blood pressure, and the other concomitant medications. Here you can see there's a decongestants, the patients which are commonly available, because being the COVID season, many people have in the family, entire family is taking that Montelukast with levocetirizine and other all antihistaminics on a long term. Okay, they can be taken for a short while, and so as I already discussed, the non-compliance. So we need to address the compliance with the less sodium diet, and how to important practical point, how to give a salt prescription. Many a time people think they want to go for a different salt. No, that is not required. Normal salt itself, probably if you have an educator in your hospital, you can just ask them to pack. Suppose you want to reduce the quantity of the salt and measure, and just show them this much of the salt to be taken for throughout the day. Suppose the patient, so we can give it to them and tell them they can add to any of the food which item they would like to have. So the measuring and showing is very, very important. Otherwise, if we just tell them, you take 8 grams of salt, 4 grams of salt, so the patient will say, sir, I am taking very less only, sir. I am taking less number. And we think everyone said that.
And one more important thing about salt, people think salt means only sodium and volume. There is one more aspect of the salt. It also produces T cell abnormalities and produces inflammation, and then vascular endothelial constriction, and then produces hypertension. So other pathway where salt produces hypertension is through the inflammatory or the T cell pathway. So that also you should remember about the salt.
Yeah, probably all the diseases today we are talking about inflammation, not only COVID, diabetes, hypertension, and coronary artery disease. Everywhere we are inflammatory. So, and that's why anti-inflammatory drugs are tried in many of the into research also in the management of diabetes, hypertension, and drugs like naproxen, the drug should be avoided on a longer run. And so the non-pharmacological lifestyle measures shown beneficial in elderly hypertensive patients, very, very important. So this is regular physical activity to a reasonable extent possible, and sodium restriction, weight control. They're able to reduce weight, smoking cessation, and avoidance of excessive alcohol intake. These all the lifestyle changes to a reasonable extent can bring down the blood pressure, not only depending upon the medication. So if you are able to enforce these things, definitely, practically, these things can have a good control over hypertension. And
thank you, Dr. Balamurugan, for nice work.
Yeah, I'll just finish in a couple of
Okay.
slides. And the antihypertensive related side effects, the high prevalence of both cardiovascular and non-cardiovascular comorbidities among the elderly diabetes, need of great vigilance to avoid treatment-related effects like electrolyte disturbances, which I already discussed, hyponatremia and hypokalemia. Sometimes when you start on an ACE, there might be increase in potassium also. And you have to be very careful to rule out a patient with a unilateral or bilateral renal artery stenosis when you are prescribing these drugs, and kindly closely monitor the potassium and creatinine. And renal dysfunction is also very, very important in an elderly patient. So choose a drug, probably, in that case, ARBs can be used. Then you can go for, as I said, calcium channel blockers. And one of the important things is that blood pressure being artificially high because of the thickening of the increased vascular resistance and increased atherosclerosis and arteriosclerosis of the brachial arteries, blood pressure can be there can be pseudo hypertension or measurement errors. We have to keep careful. And one of the important things, they can more prone to develop an orthostatic BP decline is very important elderly, especially when they have autonomic neuropathy due to diabetes. They can have a postural and orthostatic hypertension, and kindly adjust the dosage accordingly, and kindly tell the patient when they have such symptoms not to just get up from the bed or and immediately start walking. Ask them to stand for a minute or two for a slow adjustment of the blood pressure, and if also not tolerate, try to alter the drugs. And so definitely there is the age we live. Okay, average lifespan is increased, so there's a dramatic increase in hypertension. In older adults, hypertension is characterized by an elevated systolic blood pressure and normal or low diastolic blood pressure. Why we are talking the diastolic blood pressure should not be brought very low, because the coronary filling takes place during the diastole. and also due to the age-associated stiffening of large arteries. And definitely it's a cardiovascular risk factors. And although increases in the treatment and control of blood pressure in older hypertensive adults have occurred over the past 2 decades, BP controls remain suboptimal. It's already said non-pharmacological intervention, and many a time ACA, ARBs, calcium channel blockers and beta blockers and diuretics are useful. I think I will stop here, sir. And this case mainly I wanted to bring 2-3 points. One, how to address a patient, an elderly patient comes with, and how the role of the salt intake is very, very important at not only at this age and every age to control the hypertension. Third one, minimum lifestyle modification is required, and the role of concomitant medications and role of the alternative medications also in causing uncontrolled hypertension as well as causing a renal damage. Probably we will take the further things when time permits. Thank you, sir.
Thank you. Thank you. Now I request Dr. Rajiv Govil to present his case. Friends, please give your questions. Let it be an interactive session. It's not like a didactic lecture. So I want everyone to ask questions, answer, involved in the workshop. Now, Rajiv.
Thank you, Dr. Muruganathan. Thank you, Dr. Bala Murugan. Humble submission first that I'm not a hypertension specialist. Both my seniors are hypertension specialists. And thank you for the organizing committee of Primer for having me here, especially Dr. Krishna Shishadri. So I have 2 published cases in international journals of hypertension, difficult to treat hypertension, and I'm going to discuss this. I'm going to go fast. You're nobody to teach anybody what should be done, but at least teach the steps that need to be taken in order to correct or in order to treat the patient adequately. So my first case is a 51-year-old diabetic for 5 years, blood pressure, known history of no target organ damage, no family history, examination 156/90. He's on a 5-drug therapy, as you can see, 5-drug plus statin plus metformin. So he qualifies as having very high blood pressure, 158/90. So what would we call resistant hypertension or difficult to treat hypertension is that, as Dr. Muruganathan said, that first we'd use an ACE-ARB, then we use a CCB, and then we use a we use a thiazide diuretic or any other diuretic, and still continues to remain higher. Then we could say that the patient may have resistant hypertension. If you look at the various societies which look at guidelines for diagnosis of resistant hypertension, whether the ESH, AHA, or ACC, most believe that if you have 3 drugs and you have a CCB, you are an ARB, ACE or ARB plus a thiazide diuretic or any other diuretic, and a systolic blood pressure is more than 140/90, that's what the ESH believe, and the ACC believe 130/80, and then you could diagnose as such. So this and treatment, if you look at globally, you have almost 14% patients who are uncontrolled on 3 medications and 20% patients who are uncontrolled on 4 medications. So there's a lot of time that patients are uncontrolled. Causes of resistance, Dr. Muruganathan very nicely alluded to what are the causes of resistant hypertension. Comorbidities in resistant hypertension, as you can see, diabetes obviously is much higher and is a comorbidity in hypertension in India, followed by stroke, CHD, CKD. Why should we treat this kind of hypertension? There are these long-term issues, whether it's related to the heart, related to the kidney, or related to all-cause mortality and stroke. We should be treating them. What should be our algorithm be? The algorithm should be like this. We should have a long-term algorithm where, one, we should first try to completely remove white coat hypertension, pseudo-resistant hypertension, make sure that as Dr. Muruganathan has said, the ways that we have to actually check blood pressure and then label the patient as having high hypertension. So for this patient, we had 7 steps at a glance: confirm treatment resistance, exclude pseudo-resistance, identify lifestyle factors, which Dr. Bala Murugan also alluded to, discontinue interfering substance, NSAIDs, pseudoephedrine, he said, then screen for secondary hypertension, pharmacological treatment, and sometimes we have to refer to a specialist as well. So again, confirm treatment of resistant hypertension, correct office and home blood pressure measurement technique, evaluate for white coat hypertension. Sometimes you may require a 24-hour ABPM. Assess, educate about adherence, cost, frequency of dosing, side effects, identify and address contributing factors. Now, diagnosis to confirm resistant hypertension. How do you say that the patient has uncontrolled resistant hypertension? That the office blood pressure is 130/80 on 3 medications, then you can say that patient has uncontrolled resistant hypertension. How do you separate true from pseudo-resistant hypertension? Again, go through the guidelines which Dr. Muruganathan said. Majority of us are checking blood pressure in the supine position. We need to first reassure, let the patient be calm at least for 5 minutes. Again, patient should not have smoked or had a coffee half an hour, an hour back. The cuff should be at the same level of the heart. The feet should be on the ground. There should be a back support, as sir said. There should be a back support. And if all this is there and the patient's blood pressure is higher, then only label him. And again, let him have home blood pressure measurement. So how do you exclude pseudo-resistance, white coat hypertension, measurement error? The cuff has to cover at least 80%. You know, you have these very obese ladies with obese hands, and then you may require a better cuff. Again, non-adherence. Dr. Balamurugan spoke about medications. There are a lot of these medications. Steroids he spoke of. There's non-labeled use, NSAIDs, antidepressants, all of them, and a lot of homeopathic Patanjali products, so many of them keep coming in. And what are the patient characteristics you look at? Again, obesity, chronic kidney disease. We all know metabolic syndrome and so many metabolic abnormalities drive the epidemic of cardiovascular disease, hypertension, cardiovascular disease in our country. And hypertension prevalence is double of that of diabetes. It's a real silent killer. And that is something that we have not been right now been able to address. Evaluate for secondary hypertension. I'm just putting down the clock, though they form a very small percentage, 5 to 10%, but sleep apnea, very, very common. Sleep disordered breathing, especially in diabetics, 25 to 40% would have sleep disordered breathing, and at least 10% may have obstructive sleep apnea. So that's something one needs to keep in context. Chronic kidney disease, 30 to 40% of people with diabetes would have chronic kidney disease. Thyroid, parathyroid, renovascular disease. If you have a young hypertensive, you should look at renovascular disease. Primary aldosterone is not that uncommon, 3 to 5%. Again, important secondary causes of resistant hypertension, all of them elicited there, but most importantly, white coat hypertension and suboptimal medications, most important, and sleep apnea as well. Now, what do you do if you get these kind of patients? How do you do, what are the diagnostic tests to be done, and what are the treatment in a nutshell? So, lot of evidence to say that if a patient uses a CPAP machine, a good Spanish study looked at a randomized control trial of CPAP versus no CPAP in patients with OSA with resistant hypertension. Just using a CPAP machine was able to get down their systolic blood pressure by 10 millimeters. So there is a strong role of, yes, sir. So you want to add something?
No. The CPAP in elderly women, especially, it's not very good compared to men. So CPAP is better, giving results for male, not the female. So that's one point.
So that's from the hypertension expert. So again, primary aldosteronism, which sir is going to speak, and I'm going to speak a little bit on that. Drug-induced and heavy alcohol intake, again, can cause a lot of change. So discontinuation of agents, sometimes you may have CPAP support, renal revascularization, all this may be required if you get kinds of secondary hypertension. Sometimes we may have to do an aldosterone-renin ratio. I'm not going into deep of this. This is CPAP in OSA and resistant hypertension. Studies showing that CPAP can reduce hypertension in resistant hypertension patients. Many of the other investigations which you may look at, you may do a 24-hour ABPM, and you may see that in a diabetic, you don't have the nocturnal dip which should actually occur. You may have the blood pressure going up. You may have a lot of time postural hypertension and nocturnal high blood pressure. So you may have supine hypertension and daytime hypertension. So you may have to change therapy like a short-acting agent at night and probably a milder agent during the day.
That is a nightmare for a physician. Absolutely. When you have a supine hypertension and then orthostatic hypertension when you stand. So it's very difficult to, that's a nightmare for a physician to treat.
Absolutely, sir. And when that patient is ambulatory and comes to your clinic, his blood pressure would be normal, and you go back home, blood pressure is high, and you do an echo, you'll have a large heart, you'll have your 24-hour ABPM will pick a lot of that. Echo may be high. Your eye examination pick a lot of hypertension retinopathy. So how do we manage resistant hypertension? I'm going a little fast so that we have enough time for discussion also. Again, after the 3-drug therapy, the 4th drug one would look at could be an MRA, could be spironolactone or eplerenone. A lot of evidence, as Dr. Balamurugan and Dr. Muruganathan suggested, that if you have a thiazide diuretic, better to use chlorthalidone or indapamide. As you can see, chlorthalidone has a superior BP reduction versus hydrochlorothiazide, and indapamide has a long-term BP control similar to hydrochlorothiazide. But again, recommended for patients with treatment for resistant hypertension, chlorthalidone. It's indapamide, again, suitable for elderly and those with renal insufficiency. So if you have hydrochlorothiazide, which I think is a much weaker antihypertensive, we should move on to chlorthalidone and indapamide, give the patient lifestyle measures, and then again, kind of come back and look at how things can change as such. Step 4, as you can say, you may check the heart rate and look at beta blockers. Step 5, we may not actually reach when you have to use a direct vasodilator like hydralazine or anything. So in this particular treatment, after discussing the pros and cons for this patient who was on a 5-drug therapy, eplerenone was added. The patient's low, the renin activity was very low.
Especially eplerenone is added when the spironolactone produces gynecomastia. So one of the side effects of spironolactone is gynecomastia. There we use eplerenone. Of course, cost factor is comparatively it is little costlier, but still we should use that.
So again, on follow-up, the effect of aldosterone and antagonist was not evident in the first few weeks. A mild increase in azotemia, no changes in potassium, no changes in blood sugar control. The course of BP got better, and thus the patient on a 5-drug therapy, by evaluating him, making sure his lifestyle was better, we were able to get him down to control over the next few weeks. This is a published case in an international journal, so I thought I should share it in a workshop so that we can have a lot of live discussion. Over to you, Dr. Muruganathan, to take it forward.
My slides. That was a very good case by Dr. Kovil. Please help me there. Yeah. Now I'll go to the case number 3. We have discussed about the pseudo-resistant, resistant hypertension with 3 drugs and 5 drugs. Now I go to the 3rd case. Yeah. 54, very simple. I'm going to run fast. The case, I want to discuss more cases. 56-year-old lady teacher, vegetarian, BP was 170/100, not controlled with 3 drugs. So history taking is very important. What history you will take in this patient? Pardon? Very good. Then, yeah, daytime sleepiness, you must ask the patient, and you, when the spouse comes, ask him whether he's doing snoring. So that is very important history, because the life partner will give that history. Yeah. Then what are the history?
Then if both partners have snoring and sleeping, they may not know. This is also a tricky situation. And
maybe the child or children will do.
Family members have to be inquired that the snoring is there.
Okay. And then any other history? Of course, Balamurugan case, they said salt intake. So you'll have to ask him the history
pattern of diet intake and maybe how many times she.
Yeah.
Basically, vegetarian people say.
Yeah.
I know everyone, most of the vegetarian people, they are fond of taking Thaishadam and Urgai.
So this is exactly, this lady is a college lecturer. She takes every day curd rice with pickle. Pickle means she loves pickle. So she keeps everything. So everybody went, everybody treated with the 3 drugs. They did not ask the history. Then when she came, we asked her what is the diet you like. Then she said she likes puppet, she likes all these things. And then on the top of it, she also has chronic sinusitis. And all educated persons, they follow not Dr. Muruganathan or Dr. Rajiv Kovil or Balamurugan. They follow Dr. Google. So they go to Google and they take antihistamines, national decongestants on their own, especially educated people. So that is why this lady has got uncontrolled hypertension. And we did this. We asked them to stop all that. The BP was under control. So simply the history taking is the lesson, what you have to do in a hypertensive patient. No, I told you about high salt intake. If you see the high salt intake, this is the thing which I want to say. Immune system, modulation of T cell activity. T helper cells and regulatory T helper cells regulation. So systemic inflammation, anti-inflammatory, that leads to endothelial dysfunction. And this is one more cause of hypertension. So all along we thought about hemodynamic effects. Never forget about T cell. Now T cell is the order of the day, especially after COVID. So case number 4, a 50-year-old hypertensive diabetic lady with severe OA knee presents to OPD with facial puffiness, fetal edema, and BP of 210, 150. What do you do? Start on telmisartan, start on amlodipine, evaluate for secondary cause, or start on aldactone. Very good. Evaluation for secondary cause. So already Rajiv Kovil have shown what are the causes of secondary cause of hypertension. We give the mnemonics CROPED, CROPED. So remember that mnemonics, or you remember ABCD: A for accuracy, A for apnea, A for aldosteronism, B for bruit, renal bruit, and bad kidney. Then C for catecholamines, coarctation, Cushing syndrome, D for drugs and diet, E for erythropoietin, like that. We can go on. So these are the mnemonics for a secondary cause of hypertension. And then what is the likely cause of hypertension, pedal edema, in this patient, which I described? Is it renal failure, NSAID therapy, fluid overload, or all of the above? Very good, all of the above. So then how do you proceed now? The mechanism of resistant hypertension is because of the retention of salt and water, renal vasoconstriction, and then blocking of the renal prostaglandins, blocking ACE1. So common cause of accelerated hypertension and heart failure is NSAID. So please ask the patient, if they're taking NSAID, try to avoid. Suppose if the patient has got rheumatoid arthritis, what do you do? You can avoid NSAID and then you can give biological drugs are available, so which you can try and change. Suppose if the patient has got NSAID, which drug is good? Is it beta blocker, ACE, or diuretic? Somebody has to take NSAID. So he is hypertensive. What antihypertensive is good? Mohan? Calcium channel blocker is better. So whenever somebody has got any osteoarthritis, try to avoid the NSAID. If you have to give NSAID, definitely, then you give them only calcium channel blocker. How chronic kidney disease produces hypertension? 2 ways. One is chronic uremia. Yeah. Yeah, see, CCBs, there are good CCBs which can prevent pedal edema. There are like benedipine, then sildapine. When you give those CCBs, the pedal edema is less. But in this case, especially when you give with diuretic, with calcium channel blocker, you need not worry about pedal edema. And then, as you rightly asked me, amlodipine produces pedal edema more compared to benedipine and sildapine. Sildapine is the 2-channel blocker. Pridapine is 3-channel blocker. Amlodipine is only 1-channel blocker. Yes, Mohan.
The latest, the latest calcium channel blockers like L and N channel, dual channel and triple channel drugs, they do not cause
no, that's what. See,
no, they reduce the blood pressure also. So when you want to address particular issue, probably,
So Dr. Muruganathan, one question from which was always on my mind also, the newer CCBs, like the cilnidipine, the benidipine, how potent are they compared to amlodipine? I tell you,
in any pharmacology, any drug has got good effect will have side effect. Drug which has got less side effect, the effect is bad. So like, what you asked me, the best potent CCB for BP reduction is amlodipine. Cilnidipine is a weak antihypertensive, but nephrologists, use that cilnidipine because they say it is very good for proteinuria and it is also reduces edema. But in my experience, even cilnidipine, the dose what you give, amlodipine 5 milligram is equal to cilnidipine 20 milligram. So when you give that 20 milligram cilnidipine, that also produces edema. So I prefer amlodipine only. Now recently, benidipine has come back into the market. That has got 3 channels. It shows some promise. And now there is also asalnidipine has come. They claim that is very good for proteinuria, and studies are not there. So studies for reducing cardiac events is not there. So, but people are now promoting asalnidipine also. Yes, madam.
You can give the mic.
I didn't get you the last
Yeah,
point.
what she wants to
So
know is,
what I
okay,
wanted to say was,
Yeah.
Patient to accept the pedal edema and move on if they develop a pedal edema.
see, if they're already difficult to control, you've already got them on 3 classes of drugs. You
Okay.
have to add in something. It's going to produce a bit of ankle edema, but it will control your blood pressure. Acceptable compromise. Can you live with it?
Yeah, so that is a very good point. This is more of a cosmetic. The pot pedal edema, what you get is not due to renal failure or not due to any problem. It is only physiological. So this is only cosmetic. So you can convince them. If you cannot convince them, try the other CCB. Otherwise, you try. Now we have got other drugs also. We can change and see whether the pedal edema reduces with other CCB. Otherwise, you can put them on other CCBs.
now
That's
the
all.
other complications is probably we want to compare the newer generation and the older generation of the CCBs. The reflex tachycardia is also one of the things which is
Yeah.
far less with that.
Yeah.
As Dr. Usha asked your question, probably hypertension is well controlled. The pedal edema is alone there. Probably heart rate is also to a reasonable extent. That's one of the important things, especially in elderly people. Probably you had a history of for coronary artery disease. We don't want to increase the heart rate further. So we do not want to add one more drug for controlling the heart rate for that.
But,
So
but they don't agree also, sir. Whatever reassurance you give, that is okay to have pedal edema, it is okay.
Yeah, that is
You
why.
can have that.
That is
But
why.
always it goes in the patient. Means unless for them pedal edema means it is either heart or liver.
Nobody accepts when
accepts,
there is a pedal edema. They say the doctor has produced this because of that, and he'll change the doctor. So tell them this is only cosmetic. They won't agree, and you won't get convinced. So try to change the drug. Try and see sildenafil or try and see benadryl. If not, you change the class of drug. Don't give calcium channel blocker. We got other drugs also. So we can try the other drugs and see whether it is under control. But very important point, you should some or other reduce the BP, bring to the target. That is the very important. Yes,
Sir, some nephrologists also have opinion that
yes.
NSAIDs also act on the renals. Patients with a normal, absolute normal renal function have less amount of edema. So they say ACE could be helpful if your creatinine doesn't rise. You can still use ACE because it will be more helpful in those patients.
Yeah.
That's
Okay.
We are already assuming that this is a difficult to control patient who's on double or triple therapy. So I'm assuming ACE ARB is already on board by now.
Right. Yeah.
So
Yeah. So that's why. See, we have got only 5 or 6 group of drugs. So we will have to see if the CCB is not working. We try under the other drug. If it is not, BP is not under control, tell them controlling BP is more important than, seeing the edema. But you have to satisfy, give them satisfaction by saying, change the drug and see and observe. And the new drugs they are claiming, asalnidipine and benadryl, we'll have to try and see. Don't say it will be okay, because they will not come to you again. So for practice point of view, you will have to tell them to change the drug and see. Yes, any other?
the second probably is the one is the target BP according to the guidelines. Okay, we've been talking about the JNC8 guidelines, all the things, and the lives, the quality of life is very, very important, especially in an elderly patient or younger patient. So we should give a tolerated blood pressure or a targeted blood pressure.
In fact, the recent journal says whether you use any drug or not, bring to the target. That is very important, irrespective of what you use. And then you said about the side effects. When the side effect is more in particular drug, you try to change and convince them. Otherwise, if you don't control the blood pressure, they'll go into a lot of problems. So controlling blood pressure is the key. In 2020, journal has come. Lot of physicians have inertia. They don't aggressively control. So controlling the blood pressure, bringing to the target is very important. Now I'll go to the other case. Patient characteristics associated with resistant hypertension. I already told you: old age, high baseline, obesity, excessive dietary salt, chronic kidney disease, diabetes, LVH, and female sex. So females are more prone to get resistant hypertension.
Females are always resistant.
Yeah,
for
no.
hypertension management.
Okay.
Yes, sir. Did you see in your practice?
So basic testing in resistant hypertension, home blood pressure monitoring. The drive home message for all my viewers: please promote home blood pressure monitoring. So home blood pressure monitoring can identify mask hypertension, identify white coat hypertension. It helps you to control the blood pressure. So ambulatory blood pressure monitoring that you should do in a basic testing. Suppose you do ambulatory blood pressure monitoring in a resistant hypertension, you get nocturnal dip, whether it is present or not, you can find out. So nocturnal hypertension, you can find out only with the ambulatory blood pressure monitoring. So in my message is, anybody who's got hypertensive, at least once a year, at least once in a lifetime, you do ambulatory blood pressure monitoring for that patient, because you'll get a lot of information, dippers, non-dippers, nocturnal hypertension, early morning surge, etc. So ambulatory blood pressure monitoring is the must for a hypertensive patient. Yes, madam.
On your previous slide, you mentioned LV hypertrophy. Is the LV hypertrophy a consequence of the difficult to treat or resistant hypertension, or is it causally related?
Yeah, it's like wind producing tree leaves or tree leaves, like so vice versa. LVH is a consequence of first hypertension, and then LVH itself can produce more hypertension by way of atrial fibrillation, heart failure, and producing problem. The key point in LVH, don't give any direct vasodilators like minoxidil, because that will cause LVH more. So the ideal drug for LVH is ARB, especially losartan, because we have life study which says losartan is good. And indapamide is also, if you want to use a diuretic, indapamide is a good drug for LVH. That's a good question, but LVH always is a problem. If you don't treat LVH, it goes to problem like heart failure, atrial fibrillation, angina, etc. Yes. So
24 hours blood pressure monitoring. Will
Okay.
you ask between 24 hours blood pressure, ambulatory blood pressure monitoring or home blood pressure monitor? Which one you will prefer, sir?
So ideally, home blood pressure, ambulatory blood pressure monitoring is good, but it is inconvenient. You know, many people, they don't go for ambulatory blood pressure. You have to pay. Now, a lot of pharma industries give free complimentary ambulatory blood pressure monitoring, but still, it is inconvenient. So, who will like to have overnight, every half an hour, this will inflate, deflate, inflate, deflate. They cannot turn this side. Because of that pressure itself, they'll have more pressure. So ideally, now the recent.
I have a different opinions on that.
I'll complete it. I'll complete. The very good ambulatory blood pressure is coming to the market, where there is only a very non-invasive ambulatory blood pressure. It doesn't cause disturbance for sleep also. So that is one. Number two, the home blood pressure monitoring itself has come out very nicely with a distance home BP. It has not come to the market here in India, where you take 2 a.m., 3 a.m. and 4 a.m. BP. So whatever reading you want, home blood pressure monitoring gives 2 a.m., 3 a.m. and 4 a.m. And also the newer ambulatory blood pressure monitoring is very good. That is going to be the order of the day, because every hypertensive patient should have an ambulatory BP monitor at least once to stay. But as you rightly asked me, ambulatory blood pressure monitoring is cumbersome. It's got a lot of problems apart from cost. But you know, nevertheless, it is very important, but we have to use. That is why I always say home blood pressure monitoring is a poor man's ambulatory blood pressure monitoring. Home blood pressure monitoring is a poor man's ambulatory blood pressure monitoring. Yes,
Can I just add?
Yeah.
Gauri, your question is well taken and well answered by sir, because hypertension is a disease you're going to live with, okay? And it's a lifelong disease. And first, when you want to diagnose hypertension unambiguously and tell them you are definitely hypertension, and a lot of data, sir, we are getting from the what is that, ambulatory blood pressure. Definitely, you are able to convince a patient and tell them this will give you an information whether to confirm or what sort of a drug you will require. And as Sir said, yearly once at least all hypertensive patients
actually,
can go
ambulatory
and-
blood pressure monitoring in a diabetic hypertension, it gives not only the dippers, it also gives BP variability also. Yes, Usha.
So I have a question. I know that the traditional ambulatory blood pressure monitors are cumbersome.
Yeah.
People can't
Yeah.
sleep with them.
Yeah.
But now with the IoT, you have so many connected devices that will do the same job. How reliable are they? And should we be, and if you think they're reliable, should this be the direction in which we're moving?
Yeah, this is going to be future direction. Not a lot of studies have come, but it is not proved. So we are waiting. But in Singapore and other places, this ambulatory blood pressure monitoring is available. Sooner it will come to India. If it comes in the large number, it will be cheaper also. So I think that will be the order of the day. But ambulatory blood pressure monitoring and home blood pressure monitoring should be the order of the day, because home BP also, I told you, upgraded, which we can state early morning and then midnight also. Yes.
She wanted probably not regarding the cost of that, the validation of the
Okay.
So how
technology.
reliable are they? Because now you can
validation.
wear a
Actually-
watch that gives you your ECG, your
Watch,
heart rate, your blood pressure.
the watch and all you get is not validated. The validated one is coming in the pipeline. It is going to come in another 3 to 4 months here in India. Other countries they are using. And then the home BP, which I said, Omron has got one model 5231, I think. which has got 2 AM, 3 AM, 4 AM. It is well validated. It is well approved internationally also. So that can be used. Once validated BP monitors and validated ambulatory blood pressure monitor comes, that will be the future direction. So whatever in the market, like watch and ring and all that, it's not going to be
Because
useful.
there are so many companies now doing these gimmicks saying,
yes, yeah.
Lots of internet companies, lots of internet medical
They
teams
also say app.
who are,
So with the
who are
app, you can
doing
so
app and this and that.
no, it
I
is not.
always wonder about where is the clinical data? 2, how valid and reliable is it? And 3, can we really base clinical decisions
Or based on the reading? No,
based on the
definitely.
exactly?
So now the validated BP monitors, ambulatory BP monitors, and home BP monitors are coming, and really it is going to be change the pattern of hypertension treatment.
Sir, how much do you use this 24 hours ambulatory BP monitoring for diagnosis, sir?
Actually, according to the Canadian guidelines and American guidelines, nobody should be diagnosed hypertensive without doing outside BP measurement, either by home BP or ambulatory BP. That is the definition. One cannot say you have, by seeing only the office BP, you cannot diagnose hypertension. You should do at least one outside BP, either ambulatory or home BP. Only then you can diagnose. So ambulatory is useful for diagnosis one. It is useful for follow-up. It is useful whether your drugs are acting. You can find out nocturnal dip, and especially hypertension. You can find out whether they have systemic hypertension, and then also BP variability. All those findings you can get only in the ambulatory. Only caveat is if somebody has got atrial fibrillation and some arrhythmias, you'll have to be a little more careful. Otherwise, the ambulatory blood pressure monitoring is the gold standard in diagnosis as well as follow-up.
So, but I will share my experience, sir. Others also can add if it is how their experience is about. Whenever there is a mismatch between the blood pressure measurements, office blood pressure measurements, say 150 or 150 more than that, I put them on ambulatory blood pressure monitors, sir. So invariably it was all coming less than 135/80. I reassured the patient also accepted. But 20 patients I used, out of it 19 patients somehow or the other, within the next 6 months they were on antihypertensives. Not by me, but by some others, nephrologists, cardiologists, they start. So what is the utility of ambulatory blood pressure monitoring in spite of it reassuring, but it is not getting transformed into practice?
The problem again, the ambulatory blood pressure monitoring available in the market, sometimes some monitors are not validated. Even in the India heart study, that is the largest study that we did in India heart study, they use a particular model of ambulatory blood pressure monitoring. There the results are very good. They found out Indians, especially Indians in the night time.
I used the same monitors.
Okay.
I used the same equipment.
Okay. They said in the night time, the Indians, especially normally Western people, the heart rate is less. Whereas in India, in the India heart study, they've said the heart rate is more for the night time compared to daytime. Surprising. And also they said more of diastolic hypotension in the night. So these are the findings in India heart study. But it depends, as you said, ambulatory blood pressure monitoring. Now I'll give you one more clue. Now recently everybody in the whole world is using automatic BP monitor, AOP. That is very good. That is what they used in sprint trial, where they found out that there's no error, no problem. But for every patient to buy automated BP monitor is not going to be easy. But sooner or later this will come. So in every clinic, if they use automated BP monitor, it will be very good. So I'll go to the case. I think what's the time now? We have some more time.
12. How many minutes?
Huh?
7 minutes.
Okay.
So probably only one thing, sir. You're talking about the resistant hypertension. You said females are more resistant hypertensive, and but I feel the resistance is, and the barrier is more with the healthcare professional rather than the patient themselves.
No. What I said, general compared to male, females are more. So I'll finish this case. 28-year-old class 2 obesity, 4 years consultation, 3 agents on hypertension, BP 180, 110. Orlistat also prescribed. What is the diagnosis? How do you confirm? Any takers on this case? Mohan, any guess of this case? Okay, we have done 1 milligram dexamethasone suppressant test, 24 hours urine-free cortisol, basal ACTH, elevated basal ACTH, non-suppressing DST, elevated urine 24 hours pre-cortisol, MRI pituitary shows 8 millimeter pituitary microadenoma, TSS, dramatic improvement in blood pressure. Final diagnosis ACTH dependent Cushing's disease. This is a ACTH dependent Cushing's disease. The sixth case is sudden fall and uncontrolled BP. 45-year-old male, sudden onset of paralysis, fall, hypertensive, difficult to control. 3 agents. Potassium is 1.8. Potassium A has got hypokalemia, and this is the ECG shows U wave because of hypokalemia. So what is the diagnosis? The same patient, the same specimen. This is a hypokalemic hypertension, not on thiazides, but grossly elevated PAC and PRA ratio. CT abdomen shows a left adrenal adenoma. Left adrenalectomy was done. Confirms Cohen syndrome. Dramatic reduction in blood pressure post-operatively. Final diagnosis, hypokalemic hypertension due to Cohen syndrome. As Rajiv Koil said, Cohen syndrome also is now, coming more and more. So always think about Cohen syndrome when there is a hypokalemic hypertension.
Probably can you say that the take-home message from this case is kindly always do an electrolytes for all patients when you're diagnosing hypertension, and at least once in 6 months you do electrolytes to follow up and to rule out. Sir, do
Yes.
you agree with this point?
Yeah. So,
Electrolytes is a compulsory investigation
Yeah.
at diagnosis and follow up.
any patient who's on ARB and ACE inhibitor, you have to do serum creatinine also to start with, even before starting treatment. Yes, Usha. Gautam, you want to say something? No, Usha, yes. Pardon?
We can hear you. We can hear
No, no problem. You can hear.
Female, 29 years old.
Yeah.
Can I just make the case that from an endocrinologist point of view,
Yeah.
that most people under the age of 40 and certainly under the age of 30, if they're diagnosed with hypertension, please look for secondary causes.
Sure.
Don't just write them off, even with obesity as bog standard hypertension.
Yeah. Any extreme cases, less than 30 or above 70, and extreme BP, suddenly BP is more. So always think about secondary hypertension. That is why I said history taking is very important to rule out secondary hypertension. By history itself, you can come to a conclusion. This is another case, any diagnosis, you can give. A 32-year-old lady, BP 230, 120, in spite of 3 agents, secondary amenorrhea, hirsutism, hypokalemic hypertension, grossly elevated ACTH, non-suppressed DST, MRI, pituitary normal. But unfortunately, PET CT shows 3 centimeter nodule in the left lung, and lobectomy done for a lung carcinoid, dramatic reduction in BP post-operatively. Final diagnosis is resistant hypertension due to ectopic ACTH secreting lung tumor. Just for an interesting case I've done. And this is, again, examination is very important. 42-year-old, recurrent headaches for 2 years, evaluation, 5 different hospitals, neuro input, CT, MRI, normal, BP recorded between 160 and 100, and ECG is the LVH. And the problem is they have never removed the shirt. When you remove the shirt, you can see this, the clue is there. It is obviously a neurofibroma, and this patient has got paroxysmal headache and palpitation, is again pheochromocytoma. That this is very important. The same patient, this is the scan. Usha, can you throw some light on this scan? You are endocrinologist.
What is it a scan of?
Yeah, I'm asking you what it is. What do you do in a pheochromocytoma?
I mean, I would either, to be honest, if I have a biochemical diagnosis, I don't go beyond basic imaging, including CT or an MRI. Pheochromocytoma has a very typical appearance on MRI when you drop phase and it goes like the light bulb.
This is a MIBG
You do
scan.
not routinely necessary to confirm diagnosis.
Yeah.
When you do an MIBG scan, then it does show a pickup.
I want to come to that point. MIBG scan only when you do post-operatively to find out whether there is any periphery or any other place where this tumor is lying. So that is why
MIBG
scan.
scan we use for either picking up secondaries or in malignant pheochromocytomas to look for recurrence. Primary, an MRI or a CT scan with biochemical proof is more than enough.
Yeah, so more than enough, but still, I just want to show.
Rajiv will back.
I agree.
Yes.
I completely agree.
Yeah, so the idea is proper history, clinical examination, and you must remove the shirt and see the patient. The last patient, which is not last patient, this is another interesting case. Yeah, stroke, hemorrhage, quadriplegia, potassium is 2.2, creatinine is 1.1, started on diuretic, hypokalemia, all siblings, children, hypertensive, refractory hypertension. This case I brought you because this patient also has got hypokalemia, but aldosterone level is normal compared to the Cone syndrome. This is Liddle syndrome, where PA is low, PRA is low, and PA-PRO ratio is low. Liddle syndrome, it is a ENaC channel problem. It is also hypokalemia, but aldactone is normal. The important thing is in the Liddle syndrome, you cannot give aldactone, you should give amlodipine. So that is the only thing. This is another interesting case. A case came with tinnitus, with depression. So the patient had referred as a thyrotoxicosis with headache and strong sounds. He had a goiter. Came alone, 2 years family, and people thought he's a mad, complaining, sounds in the ear. And yeah, so with this case, I will finish it. This case is a tinnitus persist, and when I did MRI, it was MRI angiogram, paraganglioma of glomus tumor, which produces, some sounds in the 1 ear. So sometimes, the hypertension also mimics and gives a clue. And then when you do MRI, then this was a glomus tumor. Ladies and gentlemen, I think it was a very good interaction. I think now, if there are no questions, then we can wind up. I request panel Rajiv Kovil for a final message and Bala Murugan final message, and we'll conclude. One message from you.
I think that home blood pressure monitoring should be encouraged.
Super.
And I would take I'll take
I'll go there.
note from Dr. Usha also, that young hypertensives always look for secondary causes.
Yes, Bala Murugan, one message, only one message.
Only one message. I said the lifestyle changes are very important, especially the salt intake, and the history taking is very important, and concurrent medication and interfering substances are the very practical tips we need to look into when you see a patient with a difficult to control hypertension.
Yeah, my message is, hypertension is a very, very big problem. Please, start more hypertension clinics and also have a validated BP monitor. And in your clinic, you should have 3 different cuff sizes, not one size, 3 different cuff sizes. Promote home blood pressure monitoring, promote hypertension specialists, hypertensionologists. Thank you very much.
Thank you, our chairperson, Dr. Muruganathan sir, for an excellently moderating and taking it. Good, sir. Thank you.
Now we are moving to the next topic. The interesting cases on this one, endocrinopathies. The topic is on endocrine googlies. For we are having the eminent chairpersons. I am happy to call upon the chairpersons, Professor P.G. Sundaraman sir and Professor S. Sridhar sir. Welcome, sir. It's my pleasure and pride to introduce our eminent speaker, Professor S. Sridhar sir. He's a consultant in the Department of Endocrinology and Diabetes, Mayod International, Chennai, and also he received the Best Doctor Award by Dr. MGR Medical University, Chennai in 2012. Welcome you, sir. Excellent. No, P.G. Sundaraman. P.G. Sundaraman sir is a renowned endocrinologist at Apollo Hospitals. Welcome you, sir. The floor is for you, sir.
Dear friends, it's really a pleasure to be here. And in fact, in this ongoing wave of COVID, I think we must congratulate Dr. Krishna for arranging this meet, especially on the debate and interesting topics in endocrinology. In fact, the present session is endocrine googlies, which is going to mainly concentrate on some rarer issues. And in this area of polypharmacy, we have different types of medicines which is acting on the various levels of the feedback, the hormone production, transport, and also the responsivity. And newer drugs, especially the oncological management, all this going to cause various changes in the endocrine system. And for this, we have an eminent speaker, a close friend of mine, Dr. Kumaravel. And he is going to speak on the drug-induced endocrinopathies. And he has been awarded Honorary Professor IMA CGP New Delhi and a course director in FCA organized. And he's got undergone special training in islet cell transplant USA. And he'll be definitely throwing much light in this drug-induced endocrinopathy. So over to you, Doctor.
Thank you, sir. Good morning. Respected Chairperson Sundar Raman sir and Sridhar sir. I have worked very closely with both of them when they were the president of Endocrine Society of Tamil Nadu. And it's a pleasure to have you here, sir. And many thanks to Krishna sir for giving me this opportunity. And the topic for today's discussion is drug-induced endocrinopathies. We all know that endocrine system with its precise interaction through multiple mechanisms, they maintain homeostasis in every system and organ. But in the current overwhelming era of polypharmacy, the balance of the dynamic endocrine system can be disturbed by multiple factors like drugs and medications, which can lead to alteration in endocrine function and the hormonal system. Now, there could be so many reasons why these drugs can interfere with endocrine abnormalities. And the common mechanisms could be these drugs can directly alter the hormone productions, and drugs can change the regulation of the feedback axis, because feedback mechanism is one of the important cardinal features of your endocrine system. And drugs can also affect the hormonal transport. It can affect the binding, signaling, as well as similar changes to counter-regulate hormone systems also could happen. And most importantly, drugs can interfere with the hormonal assays, leading to erroneous laboratory results, which could confuse the clinicians from the right diagnosis. Now, having said this, drugs can pick any endocrine organ, or any organ is possible. As a common, we all know most of the cytotoxic drugs can affect any endocrine organ which is possible. And when you try to look at most common manifestations of these drugs, drugs can cause hypophysitis, drug-induced hyperprolactinemia, drug-induced SIDH is very common. We have also seen diabetes mellitus probably related to various drugs. PCOS, hypogonadism, menstrual irregularities could be a feature of various drugs in our day-to-day practice. Drugs can cause thyroid dysfunction, and GLP-1 analogs have shown to cause medullary thyroid cancers and calcium abnormality. Both hypocalcemia and hypercalcemia is a common features. And drugs can cause Cushing syndrome, especially inadvertent use of steroids or sudden stoppage of steroids can cause adrenal crisis, osteoporosis. Again, multiple drugs could cause all these things. I thought I will choose the common drugs which can cause various endocrine abnormalities, and also the common endocrine abnormalities which could be caused by various other drugs. So I may not be highlighting all these features, but I will choose some important things and I would try to discuss because of the lack of time. The first and foremost, I'll start with the pituitary gland. Hypophysitis. Autoimmune hypophysitis is very common with immune checkpoint inhibitors. And nowadays, ICP inhibitors are a very common drugs which has been used, and they allow the T cell to recognize and attack the tumor cells. And the majority of endocrinopathies that are identified are due to hormonal screening, because most of the endocrine symptoms are usually related to various cancers also. So because many times we don't try to correlate the endocrine symptoms with the drug. We always try to correlate the endocrine system with the basic disease process. But this ICP inhibitors are drugs which are very, very notorious to cause hypophysitis. And at least 9 to 11% of those patients on various ICP inhibitors, like any MAPs, can cause hypophysis is 9 to 11%, thyroid dysfunction is roughly around 15%, and of course, these drugs can cause adrenalitis and diabetes. Hypophysitis, how do you recognize? Hypophysitis by these drugs is basically due to altered immune function, where it flares up your immune mechanism and it can cause inflammation of the pituitary gland. Low cortisol less than 5 microgram per deciliter, or in those patients with ACTH stimulation less than 18 microgram, could be a feature of hypophysitis related hypocortisolism. And many of the patients could be asymptomatic or may have a mild symptoms. In such case, if feasible, we can consider holding the immune checkpoint inhibitor drugs, or these patients would require hydrocortisone roughly around 15 to 20 milligram per day in 2 to 3 divided doses. Another system which is affected by hypophysitis apart from a cortisol axis is your hypothyroidism. If central hypothyroid is present, we have to treat these patients with thyroxine. Remember, central hypothyroidism, the diagnosis is based on your free T4 level, not with your TSH level. And whenever you suspect hypothyroidism and hypoadrenalism in patients with hypophysitis, we should always treat the hypocortisolism first before we treat the hypothyroidism. If hypogonadism is also present, we can consider testosterone in men or estrogen and progesterone in women. Growth hormone replacement is contraindicated, even though these patients would have growth hormone deficiency, because this could flare up any active malignancy for which these drugs have been given. And recovery from these things, recovery from pituitary deficiency is variable. When I say pituitary deficiency, it's a master gland which regulates various other endocrine system. Like it has an impact on your cortisol, it has an impact on your thyroid, it has an impact on your gonadal hormones, growth hormone, various other aspects. And similarly, the recovery from pituitary deficiency is also variable. ACTH deficiency persists in roughly 80% of the patient. Even after stopping these drugs, it could be persisting. And 13 to 36% of patients continue to have TSH deficiency, and roughly around 20 to 50% continue to have gonadotropin deficiency. So morning cortisol should be measured in patients who are receiving immune checkpoint inhibitors, and especially who are unwell, because many times when these patients are unwell, we think they are sick because of the primary malignancy what they have been suffering, but many times it could be an acute cortisol deficiency which could be life-threatening, and early recognition and appropriate management is essential. And hormone deficiencies usually improve except corticotropic functions, and immunotherapy can be continued once the patient is clinically stable, provided appropriate endocrine replacement is given for these patients. And having seen with hypophysitis, the next common drug-induced abnormality which I would like to discuss is a hyperprolactinemia. And pharmacological hyperprolactinemia is a very common problem, and it has an underestimated prevalence. It is very common during antipsychotic treatment, and remember, prolactin can rise up to at least 10 times above the normal levels whenever these patients are on antipsychotic drugs. And of course, many of the patients who are on domperidone, prokinetics, and these drugs are notorious to increase prolactin level. And many of the native preparations like homeopathy, Siddha preparations too can increase your prolactin level. The reason why it is underestimated or underreported is we pay more attention to the original serious disease what the patient has been suffering for. And there's a lack of externally visible symptoms, because hyperprolactinemia in female, at least they have, say, galacturia, they may have irregular periods, but in men, apart from sexual dysfunction, you may not have a very visible clinical features which has been seen. And many of these clinical features which I have said, our patients are very reluctant, or it is very embarrassing for the patients to even discuss to us, and clinicians lack of awareness. So many times these drug-induced hyperprolactinemia is ignored, though they may have subtle clinical features. So now what are the drugs what we commonly use? These are the various drug classes what you see here, and various drugs. And one common drug which can cause hyperprolactinemia, even OC pills can cause hyperprolactinemia. Fluoxetine, amitriptyline, very commonly used, and any tricyclic antidepressant, and most of the antipsychotic drugs, and even first generation antihistamines, antiemetics, and prokinetics, and these are the drugs which are very notorious to produce hyperprolactinemia. Once when you see a hyperprolactinemia due to drug, we have certain questions which are coming in our mind. So whether we should treat this hyperprolactinemia, second, or the real risk if we don't treat these patients, or what are the concerns of these hyperprolactinemia, and can we use dopamine agonists, or it will counteract the effect of the original drug? And these are the various questions what we have. To answer to the first question, do we have to treat high prolactin levels should not usually be a concern unless symptoms develop. But when the symptoms develop, it is definitely a concern. And whenever you have symptoms, reducing the dose of antipsychotics, provided the patient is stable, is one option. But if for some reason psychiatrist feels we cannot reduce the dose, in consultation with the psychiatrist, you can discuss other options, or we can try to look at other drugs, which can other antipsychotic drugs could be considered. If nothing works out, and if the psychiatrist strongly feels these drugs has to be given in the goodwill of the patient, cabergoline at the dose of roughly around 0.25 to 1 milligram per week, it can be given either once or twice a day, or bromocriptine 2.5 milligram per day, and can be used. But remember, all these are associated with side effect that can worsen the psychosis. So many of these drugs, when you give in a patient who is already on antipsychotics, it can worsen the psychosis symptoms. But in general, cabergoline appears to have a greater efficacy and fewer psychiatric adverse effects than bromocriptine. And even if you are planning to choose, this is a better safe drugs to be considered. When the signs of hypogonadism, and one concern with hyperplaquemia is that it can weaken your bones, it can cause osteoporosis, it can cause hypogonadism, it can cause symptomatic galacturia, and sometimes it can cause headache. When the signs of hypogonadism related to the drug-induced hyperplaquemia are evident, it is recommended to add either estrogen or testosterone replacement therapy. The next concern, or the next disease which I would like to highlight, is a SAADH. SAADH, hyponatremia, inappropriately elevated urine osmolality, and decreased serum osmolality in a uremic or a euvolemic patients, provided patient has a normal cardiac, renal, adrenal, hepatic, and thyroid function, in the absence of diuretic therapy, or in the absence of other factors that can stimulate ADH secretion. The common drugs which has been postulated to cause SAADH are chlorpropamide, carbamazepine, cyclophosphamide, methotrexate, vincristine, and of course again SSRIs, MOA inhibitors, opiates, sodium valproates. Iatrogenically, whenever you're using desmopressin for other condition, oxytocin and even vasopressin can cause features with SADH. The most common presentation of SADH is hyponatremia and symptoms, signs pertaining to hyponatremia. The signs and symptoms of acute hyponatremia usually do not correlate with the symptoms, and some patients with profound hyponatremia may be relatively asymptomatic. So whenever you suspect SADH with a particular drug, your treatment depends on correcting hyponatremia, and also, if possible, stopping the offending drug which has been responsible. So moving on from the pituitary, thyroid, there are two drugs which commonly affect the thyroid function. One is the lithium and other is amiodarone. And lithium can cause hypothyroidism most commonly, but the effects of amiodarone is highly variable. So I thought I will choose only amiodarone for this discussion. And the effects of amiodarone on thyroid hormone profile in euthyroid patients could vary, provided the duration of treatment is less than 3 months or more than 3 months. The most common or evident abnormality in those patients amiodarone is that they can have a decreased T3 level. So that is very, very evident. The T4 could be normal, your TSH could be increased, your thyroid binding globulin could be normal, but your free T3 and total T3 are decreased in these patients. Amiodarone can cause two abnormalities. It can cause amiodarone-induced hypothyroidism, and it can cause amiodarone-induced thyrotoxicosis. The mechanism of amiodarone-induced hypothyroidism is that it blocks the intrathyroidal iodine organization, and the treatment is very simple. And these patients, the predisposition is high iodine intake and thyroid autoimmunity, and the treatment is you consider withdrawing amiodarone or you give thyroxine substitution for these patients. On contrary, amiodarone-induced thyrotoxicosis, again, the course is highly variable. We can have two types of amiodarone-induced thyrotoxicosis. One, type 1, where iodine-induced excessive thyroid hormone synthesis, and type 2, you have destructive thyroiditis. And of course, your biochemical features would be in favor of your thyrotoxicosis, where your TSH is suppressed, T3, T4 is increased. The treatment of amiodarone-induced thyrotoxicosis, again, it is variable. The medical management of amiodarone-induced thyrotoxicosis in mild forms, you can give carbimazole or methimazole, but remember, these patients should generally require high doses, and commonly we use for a hyperthyroidism or a Graves' disease. If you are using propylthiouracil, again, the dose could be roughly around 100 to 150 milligram at least 4 times a day. In moderate or severe cases, if possible, discontinue amiodarone in discussion with your cardiologist, and addition of potassium perchlorate or even lithium has been used, and titrate the dose provided you don't go for a very high lithium dose. The type 2 amiodarone-induced thyroid toxicosis primarily related to thyroiditis, and these patients would require glucocorticoids roughly in the range of 0.5 to 1 milligram per kilogram body weight. So how do you go about in the patients with amiodarone? Patients on amiodarone treatment perform a baseline thyroid function test, assess for thyroid autoimmunity, always look for a T3, T4 reference value. Patient is clinically euthyroid with stable arrhythmias. Check thyroid function test every 3 months, at least it has to be checked. And whenever your thyroid dysfunction you are suspecting, and depending on that thyroid dysfunction, you see whether this patient has amiodarone-induced hypothyroidism. In such case, these patients would require thyroxine replacement, provided you don't predispose to arrhythmia further. Or if this patient have amiodarone-induced thyrotoxicosis, depending on whether it's a type 1 thyrotoxicosis or type 2 thyrotoxicosis, your treatment would vary. The next organ, what we commonly get affected, or next endocrinopathy, which I would like to discuss, is your diabetes. We all know beta cell secretes insulin, which acts on your liver, muscles, and various factors to maintain your glycemic profile or normal blood sugar or blood glucose in your body. We have various drugs which can affect the blood glucose, like we have drugs which decreases insulin secretion like pentamidine, streptozotocin, thiazide, diazides, and somatostatin. The drugs which increase or decrease the insulin action, we have glucocorticoids, estradiol, glucagon, growth hormone, and thiazide. The drug list is very big. You have various other drugs which has been there, but the common drug which has been implicated to predispose to diabetes or which causes hyperglycemia is your steroids. And glucocorticoid induced hyperglycemia, you check your random blood glucose. If it is less than 12 millimoles, roughly around 210 milligram per deciliter, you maintain with diet alone. If the fasting blood glucose is less than 8 millimoles, you continue the diet. If suppose your initial blood glucose is 12 to 17 millimoles, or if it is not getting with the diet control, you can add sulfonylurea. And if it's maintained, you monitor. Still, if it is not getting under control, you can add these patients on insulin and see to that the blood sugar is maintained to less than 8 for these patients. It is not only the steroids which causes alteration in your glycemic profile. We have various antipsychotic drugs which can cause variation in your hemoglobin A1C and which can cause also changes in your weight. So moving on from this thing, and we have other drugs which can affect your bone system, especially hormones and drugs action on the endocrine system. We have various glucocorticoids, thyroid hormone, especially inadvertent use of thyroxine for obesity, or using thyroxine without proper monitoring, or having the patient on iatrogenic thyroid toxicosis, and various other sex hormone lowering agents like aromatase inhibitors, GnRH agonists, and even glitazones which are used for diabetes, and various other antidepressant, anticonvulsant. All these drugs can cause osteoporosis, but the most common is corticosteroid induced osteoporosis, because steroids are the one drug which is very commonly used and abused in your day-to-day clinical practice. And the most common form of drug-related osteoporosis is steroids. It is due to imbalance in the bone formation and resorption. That's a resultant bone loss and fracture. And BMD measurement T-score is very important to see whether these patients are having osteopenia or osteoporosis. The fracture risk is the one which is what we are more concerned in osteoporosis, and the fracture risk increases as the dose of corticosteroid increases. And even with 2.5 milligram per day, there is substantial hip and vertebral fracture risk, which increases exponentially as the dose of steroid increases in a day-to-day practice. So corticosteroid-induced osteoporosis, primary treatment would be to reduce your fracture risk and maintain your bone mass. Vitamin D and calcium is very important for all these patients. Bisphosphonates could be considered because it inhibits the bone resorption. It maintains and increases the bone mass. Of course, we have data for teriparatide also, and advanced generation bisphosphonates can also be used. Having said about corticosteroid-induced osteoporosis, another common abnormality which is seen with steroids is that suppression of HPA axis with long-standing steroid use can cause relative adrenal insufficiency. Any patient who is taking exogenous corticosteroid, either oral or parenteral, can affect your feedback axis. Thereby, it can cause a relative adrenal insufficiency. So these patients, when you suddenly withdraw steroid for various other reasons, are more prone for adrenal crisis, and HPA suppression is more, you use a more potent steroid. For dexamethasone, the adrenal suppression is very high compared to cortisol. That's the reason many times for a replacement corticosteroid, we always tend to use hydrocortisone rather than using dexamethasone or a potent steroid. Another important gonadal abnormality, which could be drug induced, could be a polycystic ovarian syndrome. We see more and more cases of polycystic ovarian syndrome, and we attribute everything to obesity. But of course, there are various drugs which can also contribute to polycystic ovarian syndrome, like anti-epileptics, anabolic steroids, and these can act on various levels from pituitary to your pancreas to your fat cells, and they can also affect your ovarian dysfunction. The most common notorious drugs which predisposes to polycystic ovarian syndrome is a valproate treatment. It can start from metabolic component to androgen excess component, and it can also have an effect on hypothalamic pituitary component. And this is my last slide for today. And long-standing or exogenous testosterone, again, which has been very abused, especially for bodybuilders. And whenever you give inadvertent testosterone, can cause azoospermia. And many times when a patient presents for a fertility treatment, along with sexual dysfunction, it's a common practice to treat them with testosterone, which further suppresses your sperm count. So these effects on sperm parameters are generally reversible within 3 to 12 months after stopping the testosterone. And the recurring type again depends on the age, testosterone dose, and the route of administration and the duration of treatment. So just to summarize, polypharmacy, you have various drugs which has been used, and these drugs can affect from your pituitary gland from the top to the gonads in the bottom, and any kind of abnormality is possible. And it is very, very important for us to vigilantly monitor for these endocrinopathies in any clinical practice. And we should be able to see whether the worsening of symptom is due to endocrine abnormality or the disease progression per se. And thank you so much for your attention.
Thank you, Dr. Murugan. It's an excellent overview of drug-induced endocrinopathies, and you've highlighted because of the polypharmacy, we are going into a lot of clinical endocrine problems. And the simple history taking is once again very important, where you will avoid unnecessary investigations and unnecessary treatment. Now, certain times that the drugs which they use, they cannot stop. So you also highlighted that what is the alternative methodology we can adopt in these conditions. But sometimes these drugs are, especially in amiodarone, where the shelf life is going to be very long. And sometimes the present history, they won't highlight the use of amiodarone. And that also is very important, where you go into the details, the past history, and also the use of steroids, especially usage of like alternative medicine, where they use steroids, and that is also causing the problems. Now, with the increasing oncological medicines, now, which is the oncology medicine that is definitely going to change? Okay, sorry, discussion. Next, we'll ask Dr. Sridhar to introduce.
As per the schedule, we will hold the discussion after both the speakers complete their talks. So that was an excellent exposition, as Dr. Sundaraman rightly said, by Dr. Kumaravel on various drug-induced endocrinopathies. The next, we will be talking on the role of the laboratory tests and the various confusions it can cause. Most commonly, we have the prolactin, where there's the concept of big prolactin, where it leads to many a time a wrong approach by many practitioners. Similarly, thyroid disease is also erroneously diagnosed due to various conditions like the sick euthyroid syndrome. To throw more light on this very important, less discussed topic is none other than Dr. Karthik Balachandran. Dr. Karthik is presently the Assistant Professor of Endocrinology at Sri Ramachandra Medical College and Research Institute, and he is the very extremely bright endocrinologist with a thorough knowledge of the subject, and he is a star speaker in most of the big meetings these days. Without further ado, over to Dr. Karthik.
Thank you very much, sir, for that kind introduction. My topic today would be labomas in endocrinology. So you may be wondering what exactly a laboma is. for the sake of this discussion, a laboma is a discordant lab finding that can potentially result in wrong diagnosis and wrong treatment. So whenever the clinical picture and the lab don't agree with each other, we can consider that a laboma. Now, what are the consequences of this? You might wrongly label a patient to have a disease when in fact he doesn't have a disease, or you may miss a disease when in fact the patient is completely normal. So these two most important consequences are there for labomas. Now, labomas are suspected when something unexpected happens, when the clinical picture and the lab picture don't really gel with each other. Now, that being said, the first 2 minutes of the talk would be a little bit about basic biochemistry. Hormones are oftentimes steroids or peptides, and they are usually measured by immunoassays or in some rare reference laboratories with mass spectrometry. For the most common hormones, generally immunoassays are used. These immunoassays work by basically competing with the endogenous hormone or sandwiching the hormone and basically counting the sandwiches. If you can see here, the green one is the hormone, the starred one is the label. We cannot see the hormone by itself unless, but we can see the label. So if we put 5 of these and 5 of these, if the endogenous hormone competes with the labeled one, and if the labeled one is very less, we can say that more endogenous hormone is there. That's a competitive assay. This is a sandwich assay where 2 antibodies are used and the hormone is sandwiched between the 2. This is what is counted. So more the sandwiches, more the hormone. Here, more the signal, less the hormone. So that's how majority of these immunoassays work. These things have become more and more sophisticated with time, with the commonly used electrochemiluminescent immunoassay in our institute. And of course, we even have lab on chip these days, but not very commonly used. So by and large, it is important to know what assay we are having and what platform is being used. So now that we understood how hormones are either peptides or steroids, and they are measured predominantly by immunoassays, and how those immunoassays work by either making sandwiches of the hormone and counting the sandwiches, or competing with the hormone by a labeled analyte, we can understand how errors can occur. Number one is a pre-analytical error. This is the error that happens before the sample reaches the lab. It could be with the collection of the sample, preparation of the sample, processing of the sample, or even storage of the sample. Second would be analytical error. Analytical error is what happens in the lab. This is the more interesting one, but fortunately, it's actually less common in standard laboratories. It can be something to do with antibody specificity, assay buffer, assay design matrix, incubation time, or interference with endogenous substances. Finally, post-analytical errors can be with clerical errors in writing the reports or typing the reports or even interpretation of the report. So the idea behind this slide is to slot these errors into 3 major categories: pre-analytical, analytical, and post-analytical, so that when we see a discrepancy, we can try and put it into one of these boxes so that we can approach them better. So what are we interested in? We are interested in the horses. When you think of labomas and lab errors, lots of things can go wrong in a lab. And we are not interested in zebras, we are interested in the common ones. And nothing is more common than a thyroid abnormality. So the first focus would be on thyroid. The basic thing to understand is that T4 and TSH are inversely related, like each sitting on one side of the seesaw. One goes down, the other goes up. As long as the seesaw is not broken, this relationship is maintained. Whenever the seesaw is broken, where the relationship between the two is altered, then we might think of labomas. Second thing is the measurement difficulty with thyroid hormones. So look at the bottom left corner of this slide here. This would what free T4 be if there are 100 total T4 molecules for every single free T4 molecule. But in reality, this is what we have here. If your eyesight is good, you'll be able to see this. But there are about 10,000 total T4 molecules for every single free T4 molecule, which makes it much harder to measure. And therefore, if you're doing it in a non-standard, rural lab or something, then total T4 is easier to do, whereas free T4 would be slightly more difficult. Now, as we move through this talk, we should look at the pre-analytical part, which is the commonly asked question, whether timing of sampling and food intake matter. In this study by Sriram et al., they have found that time and food interact in a complex manner to reduce TSH. So if somebody gives a sample at 10 a.m. after taking some 4 idlis, that TSH is likely to be lower. That magnitude of lowering can be up to 25%. And that can be a problem in young reproductive age group women where we might miss mild subclinical hypothyroidism. This can be disastrous if the patient is pregnant or planning pregnancy. For men, it probably doesn't matter. But in most cases, if we have to prefer, we prefer a 8 a.m. fasting sample. Now, we sent the sample, we have got the results. The results is where we have expected relationship between T4 and T3. But a variety of things can go wrong with where the expected relationship between T4 and TSH are altered. So one goes down, the other goes up. If that is not happening, a lot of things can go wrong. One of which is assay related or lab related. So let's see a few cases. It's a 30-year-old female, recently married. She came for a pre-conception checkup. She's asymptomatic with the free T4 of 1.4 and a TSH of 8.3. So T4 is normal and TSH is a little elevated. This patient is asymptomatic, so we don't have a clinical suspicion in this case. We have nothing to think hyperthyroid or hypothyroid. The T4 TSH relationship is neither wrong nor right. So we have a situation where the platform is set up for a laboma. So in this situation, we can think of two possibilities where subclinical hypothyroidism could be there or something called a macro TSH could be there. Sir pointed about macro prolactin. Macro TSH is similar in that it's a big TSH. Some people are born with it, and 0.6% of lab findings like this could be due to macro TSH. We can confirm it by polyethylene glycol precipitation, or if the lab has a facility, gas chromatography, tandem mass spectrometry. But again, most of the labs don't have that facility. So we are left to our own with distinguishing between subclinical hypothyroidism and macro TSH. So in this situation, if you are forced to make a decision, you would go with subclinical hypothyroidism because you err on the side of caution. So the take-home message from this case is that this is a case where false hypothyroidism is diagnosed when in fact the patient does not have hypothyroidism. But it's not really wrong to give a small dose of thyroxine given that she's married and planning pregnancy. So always we err on the side of caution. Lab pitfalls aren't always easy to diagnose. Let's see the case number 2. 36-year-old male, recently married. He's worried about hair fall like many men. He's asymptomatic. Now his T4 is on the higher side and TSH is suppressed. So again, we have the same question. Do we have the clinical suspicion? No. He is neither hyperthyroid nor hypothyroid. The T4 TSH relationship seems to be maintained. T4 is high and TSH is low. Given our dictates, there is a discrepancy between clinical findings and lab findings, but the lab findings are internally consistent. So how do we go about managing this? We basically go back and ask the patient about what drugs he's taking. A commonly used drug for hair growth contains biotin supplements, and these biotin supplements can mess up the T3, T4, and TSH assays. Depending on the platform that we use, they can result in a wide variety of results. We don't need to know all of this. We just need to know the kind of assay that's there we have access to. So in our lab or in our hospital. The interference can occur in an immunoassay in various steps in the way, this is a busy slide. It can be an anti-streptovid antibody, biotin, macro TSH, or one of the labeled antibodies like anti-ruthenium antibodies and so on. We don't need to know everything. We just need to know what lab machine that we use and what assay specific interference we can expect. Now, commonly people think biotin is found in eggs. Does eating more eggs cause this kind of interference? Of course not. That's because eggs contain only 10 micrograms of biotin for one full boiled egg, whereas interference requires 5 milligrams of biotin. That's only possible with supplementation of exogenous biotin. So in this case, the patient was not hyperthyroid, but was falsely thought of as hyperthyroid because of the lab interference. Case number 3, 30-year-old female. She's 3 months pregnant, referred by gynecologist for hyperthyroidism, very common feature, where free T4 is 1.5 nanogram per deciliter within the normal range, whereas TSH is suppressed. Do we have a clinical suspicion? In pregnancy, it's very hard to have a clinical suspicion because the symptoms are so non-specific. So, but we don't have a suspicion to suggest any hyperthyroid because there is no goiter or any eye signs. The T4 TSH relationship also doesn't seem to be maintained here. So the labs are internally inconsistent and there is a clinical discrepancy with the labs. Now, the reason for this is that TSH suppression is quite common and physiological during first trimester. That's because HCG is the one which is causing the issue. And it's a post-analytical error in interpretation. The previous ones we saw analytical and pre-analytical error. This is basically a post-analytical error. The patient is just fine. Now, hormone physiology varies during pregnancy, and a basic idea of the hormone physiology would help in avoiding these kind of labomas. Case number 4, 60-year-old female admitted in ICU with stroke, referred for abnormal TFT. T3 is low, T4 is low, TSH is low. There is no clinical suspicion, and the labs are not internally consistent. So the first question when you find a ICU report with the TFT is, was the test really indicated or not? In this case, there was no clinical suspicion. There was no reason to send a test. And that's why we have this laboma. Oftentimes, we started off the talk with things that can be false positive or false negative. There are two kinds of people, those who think in dichotomy and where those who don't think in dichotomy. This is the false dichotomy. Things can be false positive or false negative, but can also be in between. So this was the case here. It was a CQ thyroid syndrome. So it's a non-thyroidal illness. Coming to the second major group of problems, diabetes. 40-year-old female from Kolkata, one of our cases, recently diagnosed to have diabetes with a blood sugar check of 240 milligrams per deciliter. But she came with a HbA1c of 5.3%. A wide variety of things can affect HbA1c, and we're not going to go into all of this. Majority of these have a very tiny impact on the HbA1c, maybe 0.3 here or there or something like that. But the one thing that can definitely make you stop in your track and get surprised is the effect of hemoglobin variants. As a woman from Kolkata, from the belt where hemoglobin variants are really common, we find that this patient required hemoglobin variant and assay interference from the hemoglobin variant. So the idea that she had come from Kolkata, the place where this hemoglobin variants are common, gave us the clue, and that's how we diagnosed this condition. Now, the last part of the talk would be about other hormones. We saw thyroid, we saw diabetes. There are other things. This is a 35-year-old male, presents with erectile dysfunction, soft testis, 12 cc bilateral small gynecomastia is there. Testosterone is low, LH, FSH appear to be okay, and a streatum prolactin is on the higher side. Now, on probing, the patient complains of headache, and his prolactin in dilution came out to be 35,000 nanograms per deciliter, and an MRI pituitary showed a macroadenoma of 4 centimeter. Here, we have clinical suspicion in this case, but the lab findings were abnormal because the prolactin was only slightly raised. This is because of a false low or hook effect, where huge excess of the analyte basically saturates the both capture and the signal antibodies, leading to falsely low detection of there are just not enough sandwiches formed. So when we count the sandwiches, we get a low value. Case number 7, 35-year-old female, obese, noted to have irregular periods, no galactorrhea. She's anxious to conceive. Prolactin is on the higher side, 75 nanogram per ml, LH 12, and an FSH 5. So in this case, we have a clinical suspicion that something could be wrong with the prolactin. She seems to have irregular periods and a prolactin is raised. The lab finding also corroborates that clinical suspicion, but is something else going on here is the question. So here there is no discrepancy between the clinical suspicion and the lab findings. Everything seems to tally with each other. But we went ahead because she was obese and she has been having these irregular periods for a long time, whereas prolactinomas tend to happen quite it's a short history. We did a PEG precipitation and that came out to have 63% polyethylene glycol precipitable prolactin. That is, the big prolactin basically precipitates down. What is left in the supernatant is the light prolactin or the monomeric prolactin. Both were high in this case. In her case, the diagnosis was polycystic ovary plus macroprolactinemia. A lab issue can coexist even when the clinical history and the lab findings occur and seem to agree with each other. So case number 8, 50-year-old female, non-diabetic, admitted to ICU with severe hypoglycemia. He also has hypotension, fever, sepsis. We were called for very high serum cortisol. Cortisol was above the detectable limit. So in this case, there is no clinical suspicion of Cushing's, but the problem was that the patient visited ER before ICU and he was inadvertently given hydrocortisone. This is a reasonably common issue. We have faced it some 7-8 times in the last 2 years. So anytime our cortisol level is high, we need to ensure that the patient was not given some interfering substance. This could be another steroid like hydrocortisone, which directly interferes with the assay, or other steroids that indirectly interfere with the assay, either by assay interference or by direct action on the HPA axis. Sometimes we might also get interference from native medications like Ayurveda, Siddha, etc. So it is very important to go back and see the history. Case number 9, a pediatric case, 4-year-old child, ambiguous genitalia, premature puberty, and Tanner stage of B1, P2. She has normal BP. Cortisol is elevated, but ACTH is also elevated, and plasma renin activity is elevated. This looked like a CAH, except that the cortisol is elevated. Again, the clinical suspicion and the assay details don't match with each other. So the child was not given hydrocortisone. So that was not the cause of raised serum cortisol. Then we checked the same thing in another machine, Roche, Cobas, and Siemens Immune 8000, and that came out to be normal. So the bottom line is, this was a spuriously high cortisol due to an analytical error. This would be the hardest to pick up for a non-endocrinologist because of the experience needed with whatever assay that we have. So it is very important to know the assay that we have in order to get the right answers. Last case is a 30-year-old male. He is changing jobs and his pre-employment checkup was found to have low vitamin D and low PTH in this case. So this is a common finding. Low vitamin D is extremely common. Nearly 70% of our population is vitamin D deficient. But the issue is PTH was low. So he was referred like, what's going on? Is it some hypoparathyroidism or something? Now, many hormones, this is a pre-analytical problem. Many hormones are easily degraded. All of these are, thankfully, unless you are an endocrinologist working in a high-end institute, you will not have to deal with most of these. ACTH and PTH are extremely important. Know that they have to be collected properly in a chilled EDTA tube and processed immediately. Otherwise, we'll get a falsely low value. Similarly, certain hormones they are degraded by proteases. So some kind of anti-protease has to be added to the collection tube. Otherwise, we'll get a wrong value. So in this case, it was basically secondary hyperparathyroidism. We repeated the PTH. It jumped from 6 to 80. The patient actually had hyperparathyroidism and it was wrongly diagnosed as hypoparathyroidism because of a lab error. PTH and ACTH require special care while sending the samples. So with these 10 cases, I've illustrated some of the common issues with lab measurement of hormones and the things that can go wrong. And this is not an exhaustive list. Obviously, certain other things are there which are less common. For example, young boys going to gym, trying out oxandrolone or various designer testosterone regimens to bulk up and all that. But these are the common ones. The troubleshooting, the idea is to slot whenever there is a discrepancy between the clinical finding and the lab finding, slot it into one of the three things: pre-analytical, analytical, or post-analytical. Pre-analytical test, the most important question to ask is, was the test really necessary? Oftentimes we find that the test is not necessary. Analytical thing, you don't need to know everything about the lab, but at least know if the lab's quality is great. One of the ways to know whether the quality is great is to have a constant communication with the lab. Again, lab quality will matter a lot. So to prevent these issues, checklists, lab audits, quality control, internal and external quality controls are important. Identification is by history and knowledge of common lab issues, and correction is on a case-by-case basis, and sometimes even upgradation of the test to a better platform. The most important message that I want to give in this talk is to have constant communication with the lab so that we understand the issues that are happening, especially when the clinical features and the lab features don't match. With that message, I complete my talk. Thank you so much for listening.
Thank you, Dr. Karthik, for an excellent talk. Please remain there. We invite Dr. Kumarvel to the podium. We'll have a short discussion session. I'll set the ball rolling with a basic question to Dr. Karthik. So what is your recommendation for collection of thyroid function tests? Fasting required or not? Which part of the day it should be taken, etc. I think most common test done for endocrinology. So please enlighten the audience.
So young reproductive age group females, because we may stand to misdiagnose a young mild subclinical hypothyroidism, it should be collected at 8 a.m. fasting sample. For other cohorts, it probably doesn't matter that much.
Karthik, you're an excellent overview about the pre-analytical, analytical, and post-analytical thing. It's quite interesting that many times both the drug-induced endocrine diseases and lipomas, where we forget the proper history taking and clinically, because sometimes the lab and the clinical feature does not correlate very well, and we treat the numbers, not the case as such. The only lipomas are quite significant, important, especially in neonatal endocrinology. So it will be very essential that the audience knows, especially in a preterm child that you're doing thyroid function studies. Now, what are the points that you look into it? And especially when you have a mild degree of cryptomegaly which occurs, which may be what I can say a maternal induced. So these are some of the issues where 17-hydroxyprogesterone at what period you're going to do. And in case if you have a doubt, what you'll do. I've seen many times that you don't correlate. Sometimes they give thyroxine treatment, but they are not satisfied. As you said, the macro TSH, which I have faced. See, the T4 is normal, TSH is elevated. If you give thyroxine therapy, they feel uncomfortable. They are all right without the medicines. So these are some of the basic issues. Can you highlight those things?
Yes, sir. Whenever the clinical and the lab findings don't match, one of the things we need to look at is go back to the basics, and as sir pointed out, look at the history. If we are missing something, the history, what we can miss is the interference by other drugs. Those drugs can be prescription drugs or non-prescription drugs like allopathic or Ayurvedic drugs. Then second thing is, if it's an adult patient, we want to know whether the patient is pregnant or not. That can interfere with the hormones. If it's a child, then, or if it's a neonate, then the age of the child and age, gender specific normative data are very important to diagnose this hormone results, because what is normal for an adult may not be normal for a child. So it is very important for us to look at the normative data. Unless we know what is normal, we cannot diagnose what is abnormal. And these issues have to be discussed. If there is a doubt with these issues, there is always a possibility of talking with the biochemist in the lab and confirming that the lab finding is exactly the same and there is no interfering issue. Then we need to look at the theoretical possibilities of what can go wrong with the lab findings and then take a call. And otherwise, sometimes sometimes there can be unknown interfering substances in the lab. In such a situation, the diagnosis can be very challenging. We must not start any treatment as a reflex or some kind of just to send the patient away. That is one of the most important things to remember.
Dr. Kumarvel, thank you for a nice talk. Regarding prolactin, one of the commonest prescribed drugs is drugs like this PAN-D, etc., where you rightly pointed out the role of domperidone, raising the prolactin. What about the PPIs? per se without domperidone or any other glyceride or anything. There are, I feel that they also raise the prolactin to some extent.
Yeah, they usually they don't raise up, but there have been, we have in clinical practice, we see there has been a marginal increase in prolactin, but many times these patients are asymptomatic. So even in hyperprolactinemia, which could be a drug induced, if the patients are asymptomatic, it is not necessary we have to stop the offending drug, or these patients would require treatment.
Dr. Kumar, in a clinical practice, what is the limit of prolactin elevation is caused by the drugs, and in a pathological scene, what is the cutoff you take? There can be a coexisting adenoma in spite of the person is using a drug. How are we going to have a cutoff value? It can be incidentalomas, pituitary incidentalomas.
Yeah, so usually any prolactin more than 100, whether the patient is drug induced or not, we always try to go for MRI pituitary, because these patients could have a coexistent pituitary adenoma, which could have been aggravated by these drugs. Milder form of hyperprolactinemia is seen in patients with even prolactin less than 50. In these patients, routinely, we may not go for MRI pituitary. But in such cases, even after stopping the offending drug, still we feel there's a prolactin is persistently high, we may go for pituitary imaging. Second thing, the patient, more than the prolactin value, if the patient is also symptomatic, suppose even with a prolactin of 70 or 80, patient has a severe symptoms of galacturia, we might also consider it could be a hook effect, and these patients we would always try to look for other causes. And in any patients with hyperprolactinemia, whenever we feel there's a disproportionate headache or visual symptoms, we definitely go for MRI. As even in hook effect, your prolactin, even with the stark effect, your prolactin could be just 60 or 70, but still this patients could have a pituitary tumor.
I think it's now, the time is over. I thank both the speakers for their excellent talks, and the organizers for holding this session. Thank you.
Thank you, sir.
Excellent.
Thank you.
Yeah. The next topic is an interesting topic, and the common garden variety that we face in our daily routine practice, that hyperthyroidism. And for this, we have Dr. Muthukumaran Jaipal, who's a very eminent endocrinologist and a speaker. And many times we are in a jinxed with these medicines, how long we are going to use and how much is important. Because there are various forms of therapy which is available in thyrotoxicosis and hyperthyroidism. Now, how are we going to differentiate, and what are the medicines, and how long, how much is very important to know. For this, we have Dr. Muthukumaran Jaipal, who is a managing director of Arka Center for Hormonal Health Private Limited. And is more than an endocrinologist, and is a multifaceted person. I call upon him.
Thank you, sir. Thank you, Dr. Sridhar. Good morning. Good morning, everyone, friends and colleagues. It's a pleasure to be here. Thank you, Krishna and the Primer team, for the opportunity. Been given a slightly different task for this morning. I've been asked to talk about anti-thyroid drugs and the way we use it in the near future. So I'd like to start with a simple case, which is a common problem which we come across: a 20-year-old woman who presents with typical symptoms of hyperthyroid state. She's got a mild periorbital edema, proptosis, and an enlarged thyroid gland. And obviously you could see that her thyroid hormones are well elevated, and a significantly elevated T3 at 20.5, and a TSH which is appropriately suppressed. And a technetium scan showed a diffuse increased uptake pattern, and various options were discussed, and she decided to opt for anti-thyroid drug therapy. And this is a common course of action, and especially in an endocrine clinic, we see 3 to 4 patients every day, almost like this. But how do we approach as a physician? Why to treat? What drugs are the priority choices? How long she should be treated for an optimal chance of remission? If she wants to continue the drugs, can she continue it indefinitely? This is a big question which is changing. Recent data has shown that people were favoring more of radioactive iodine compared to long-term antithyroid drugs. And the data is changing in such a way that we might be using both as a long-term option. And does the drug dose influence your chances of remission? And what dose should be initially she be treated with to get the disease under control? So this is medical college stuff. And just a reminder, most of our thyroid patients present with hyperthyroid patients present with nervousness, mental disturbances, bulgy eyes, menstrual irregularities, mostly amenorrhea or oligomenorrhea, shakes, tremors, appetite changes, and weight loss with significantly increased appetite. So these are common problems and increased bowel movements. Most of these central nervous system symptoms are very common. Also, they have adrenergic symptoms like palpitations, tachycardia, heat intolerance, fatigue, and shortness of breath on exertion. And then comes the eye symptoms and the GI symptoms, which is hyperdefecation. So 3 to 4 times to the loo, menstrual irregularities, and they're almost always emotionally very, very labile. So if you're treating many hyperthyroid patients, you need a tissue box certainly in your office on the desk to be able to provide one for. So physical signs are tachycardia, goiter, skin changes, bruit over the thyroid. Some people have an irregular heartbeat like atrial fibrillation. So make sure you need to identify whether they are having a regular heart rhythm or irregular heart rhythm. Rarely older people can present with gynecomastia as well. So untreated, prolonged subclinical disease, older patients can sometimes present with gynecomastia. So we generally use a TSH for screening, but if you're suspecting hyperthyroid state, a free T3, free T4, and TSH would be a good profile to start off with. Iodine uptake scans are a norm in the cities. Unfortunately, it's not widely available, but in Chennai, we've got many centers doing it and effectively. This is a mandatory requirement in today's world. We do an uptake scan on almost all our patients in the city. And this clearly differentiates between Graves' disease, thyroiditis, and a toxic multinodular goiter. And in also cases, clearly differentiates a toxic adenoma. If the radioisotope studies are contraindicated, then the options are doing a TSH receptor antibody. You can also do an ultrasound scan, and obviously a whole body radioiodine scan can also be done if it is permitted. Certainly not in pregnancy. So how do we diagnose using a radioiodine scan? So commonly we look at the uptake of the technetium or the radioactive iodine as such. And in Graves' disease or a toxic multinodular goiter, we go by uptake, which is high. In the toxic adenoma group, what we find is an adenoma which is getting absorbing all the technetium or the iodine, whereas the rest of the gland is suppressed. I've got a couple of pictures to explain to you, which will be helpful. And in thyroiditis, we do not see any uptake whatsoever. So there is absent uptake except for the markers. So this is what both present in silent thyroiditis and postpartum thyroiditis. So this is how a normal thyroid scan looks like, and you should be able to basically see both the glands, and some amount of uptake normally happens in your salivary glands as well. So if your thyroid gland is just visible without even measuring any of the uptake through your gamma camera, but your salivary glands are not visible, then that tells us that the thyroid gland has taken all the dyes, which is also hyperfunctioning. So if you don't see the salivary glands at all, then the thyroid gland is probably hyperfunctioning. So we do many angles, and this is how a normal thyroid scan looks like. If you do not see any uptake at all, then it implies thyroiditis, which is a clear-cut differentiating marker. In a toxic adenoma, you see one part of the gland which is specifically showing uptake, rest of the gland remains suppressed because of the overactivity. And these are very, very important initial diagnostic markers in a patient with hypothyroid to start off with treatment. What other alternative explanations where the clinician has to consider in a patient with hypothyroid is any infection causing the tachycardia, any anxiety, depressive disorders undiagnosed, chronic fatigue syndrome, atrial fibrillation, or some patients even present with heart failure. So you need to be careful, and rarely a pheochromocytoma. A full thyroid profile will easily differentiate between all these things and also help you if when differentiating other problems. So when does the clinicians, when do you need the patients to come to an endocrinologist? Significant elevation of free T3 and T4 and a significantly suppressed TSH level, and you're not able to differentiate a cause. If you're able to differentiate a cause easily, then most physicians would prefer to start treatment, which is fair enough. But if there is a suspicion of any other problems contributing to this, then specialist help may be necessary. First, obviously, you need a history and physical exam and a suppressed TSH to make a diagnosis. As I discussed, there are other tests which you can use. What happens if you don't treat? And this is some very old data which has been around the corner for many decades now. And these are old reports. I don't think we'll be able to do prospective studies without treating patients anymore. The old data shows that 1/3 of patients spontaneously improve if you don't treat your thyroid patients at all. This is hyperthyroid patients. 1/3 remain chronically hyperthyroid, and another 1/3 progress to have a thyroid storm or a complication of hyperthyroidism leading to death. But the difficult thing is it's impossible where your patient would land in these three chances. So it would be difficult for our 22-year-old lady to say she's going to improve on its own. So we have to start most of our patients with therapies which are mandatory, and the strategies what we use for medical management of hyperthyroidism is mostly using antithyroid drugs. The other, once you complete a course of medical management, radioactive iodine is another common port of call where it's extensively used in the US, even prior as primary therapy, not even before starting treatment. So if you've got mild or moderate disease in the US, you might straight off be referred for a radioactive iodine treatment, even without starting medical management. Whereas in Europe, you'd be given a trial of 12 to 18 months of antithyroid drugs prior to going for a second line treatment. And this has been the conventional wisdom. So primarily we start antithyroid drugs, which are here carbimazole, methimazole, and propylthiouracil. We start with a titrating regime mostly. Block and replace regimes are prevalent in Europe for mostly with eye problems, severe eye problems, and fluctuating thyroid function. And rarely iodine can be used pre-op. And there is a remission. These are conventional remission rates of about 50% after 12 to 18 months treatment. There are other beta blockers and calcium channel blockers which are used for control of symptoms, for the adrenergic symptoms on the initial stages of hyperthyroid state. There are other options, as I said, are radioactive iodine, and surgery is a less preferred option in medical management, particularly Graves' disease patients. So when do we start antithyroid drugs? Graves' disease, pregnancy, also if you've got hypothyroid state, we start them. A patient non-willing for radioactive iodine as a preparation of thyroidectomy, and a therapy prior to or post radioiodine treatment. And primarily thionamides are the drugs of choice. And we have got, as I said, propylthiouracil, methimazole, and carbimazole. And they primarily act on the iodization pathway. So here you have got your iodination pathway here, where the iodization and coupling are blocked by your thionamides. Most of these propylthiouracil, methimazole, and carbimazole work on this. And the PTU has got a special advantage on the deiodinase mechanism, where it reduces the peripheral conversion of free T4 to T3. So that's just a sign. So inhibits thyroid peroxidase, both carbimazole, methimazole. The additional conversion mechanism is also blocked here. Most of these cross the placental barrier during pregnancy. They're less transported through the milk, so small doses are okay for breastfeeding, and more potent carbimazole and methimazole compared to PTU. The compliance with these medications, we prefer carbimazole as a choice because they are single dose medications per day, rather than PTU, which is given 2 to 3 times a day. So which improves compliance. So methimazole or carbimazole leads to more rapid normalization of thyroid function. Both these drugs, or all these 3 drugs, can cause agranulocytosis, although it is very rare. You need to be aware of this, 0.2 to 0.5%. And you need to inform all patients when you start on ATD therapy to watch out for any severe sore throat or a high temperature, which may be an indicator for agranulocytosis. So you need to document that in your medical notes as well when you start any antithyroid medication therapy, so that the patient comes to you if there are any problems. Drug-induced hepatitis has been a particular problem with propylthiouracil, and there has been instances in the last decade of many cases of fatal liver failure, which has been irreversible with PTU. And that's been the change of guidance, which has led to more favoring of carbimazole and methimazole than PTU. The instances where we favor PTU is mostly in pregnancy and first trimester, or a short pre-pregnancy session where we give PTU at lower doses possible and then shift them to carbimazole after the first trimester. And this is due to the fact that embryopathy is also common with both these antithyroid medications, and PTU has got a slightly lesser intense range of complication and less incidence of complications with embryopathy. So PTU is preferred in pregnancy only, and it is given in the first trimester, and we change over to the second trimester on carbimazole. So, so currently with patients who are non-pregnant, the treatment of choice is carbimazole or methimazole, and you start at the highest dose possible. For somebody with a free T3 of 20, I'd be starting about 30 to 40 milligrams of carbimazole per day, and then doing a repeat test at 6 weeks, and then adjusting their thyroid function. So as I said earlier, you need to warn the patient of probable agranulocytosis, watch out for fever. And if at all your patient, if you're starting a patient on PTU these days, a mandatory liver function is also possible, because there has been instances where patients have had liver dysfunction even prior to treatment with our hypothyroid patients. So lab assessments to be continued every 2 to 3 months, and then you complete a course of 12 to 18 months. There are other ancillary therapies where particularly patients react to PTU, but these are not very potent medications. Lithium can be used, cholestyramine, glucocorticoids occasionally has been used in subacute thyroiditis. The other part of the treatment is radioactive iodine. It has been there since the 1940s, and it's been a preferred initial treatment for greater than 50% of cases in the recent past. So if you've got mild or moderate disease, you'll be just pushed for radioactive iodine because your insurance is a lot more easier to provide that, and patients are eager to finish off their treatment. The problem with that is we end up with patients having hypothyroidism. So this has been primarily the dissatisfaction of patients ending up getting one disease for another disease, and they end up on lifelong thyroxine. Unfortunately, that's been the biggest negative factor for radioactive iodine. There has been comparisons with antithyroid medications and radioactive iodine, which has shown that they have been equally effective with regards to effectiveness and control of hypothyroid state. There has been scares in the past about second cancers in patients using radioactive iodine treatment, but that's been primarily a scare, especially in benign disease. The dosage which we use is very limited, and the fact that it has been currently disproven that benign thyroid disease and secondary cancers are rare. So this dose, what we use for benign thyroid disease, is very, very minimal and does not cause any complications. So when should clinicians consider I-13 treatment as a primary therapy of hyperthyroidism? When your patient wants a quick remission of treatment, and if they're not keen to go on antithyroid medications, avoid multiple visits to the clinic. So the side effects, as I said earlier, hypothyroidism is a predominant problem. 60 to 70% develop it. Sialadenitis is again very rare in the benign thyroid disease dosages. Sialadenitis is common in cancer treatments of thyroid cancers and high dose radioactive iodine therapy. The last problem, but not the least, is worsening of your eye disease patients. So if at all your patients have got moderate eye disease or anything higher than that, you need to be really looking for other options in today's world rather than giving them radioactive iodine, covering it up with steroids. So, so these are the types of patients we are looking at surgical option as well. So the cancer thing is now refuted. The small increase risk of thyroid cancer post I-131 is now totally refuted, and it's not an issue. The primary therapy with radioactive iodine for multinodular goiters and toxic adenomas, you treat as such as same as your Graves' disease initially, but then you can do iodine 131. In toxic adenomas, the primary treatment is very, very easy with radioactive iodine treatment. So here, your primary choice of therapy would be just radioactive iodine, where the patient takes the iodine straight away. The toxic adenoma is blocked by a radioactive iodine, and over a period of time, the thyroid restarts functioning, and the incidence of hypothyroid state is very, very comparatively very less in patients with toxic adenomas. The multinodular goiter incidence of hypothyroidism is fairly similar with the Graves' disease patients. So you need to pre-warn your patients that there is a risk of hypothyroidism of around 50 to 75% in our patients. And it is radioactive iodine is contraindicated in pregnancy. The current fashion for thyroidectomy has gone in most of our Graves' disease patients. Also the primary treatment remains antithyroid drugs followed by radioactive iodine. But there are some instances where we would consider surgery as an option when the patient refuses to take antithyroid drugs. There are instances where our patients have a problem of agranulocytosis or a severe significant drug reaction with any of the antithyroid drugs, then you choose surgery as an option as well. Patients with moderate thyroid eye disease also qualify for surgery, so we need to consider that in these patients. The real challenge has been to decide who to refer and what to. So that's what we are going to look at, and that's the data I'm going to show is really to tell you where the things are changing. So before you start any treatment, at least perform a complete blood count, a liver panel if necessary if you're starting the patient on PTU, and thyroid function has to be monitored if they're on ATD at least every 2 to 3 months. So the current American Thyroid Association guidelines suggest that methimazole or carbimazole should be used in every non-pregnant patient who chooses antithyroid medications for Graves' disease. And that's also seconded by your European Thyroid Association. So you continue therapy for 12 to 18 months. If your thyroid gland relapses and once you stop the ATD, your remission starts, then that's the challenge when you predict, you go for the second option. So the second option currently is being favored as whether to give them a restart of the second regime, which is again ATD for another 12 to 18 months, or a low dose therapy long term, or whether you refer for radioactive iodine treatment. So this is the challenging question why this topic has been given. And the evidence for that primarily has been the previous data suggesting that once you fail a course of treatment of 12 to 18 months, you automatically refer or insist that your patients go for radioactive iodine treatment. The data is changing there. And what is changing is there are a section of people who don't remit, but they will need treatment on very lower doses of antithyroid drugs who do very well or even better than patients who have had radioactive iodine. So this is what we are looking at here. There's been previous predictors suggesting who will remit and who will not. The factors predicting a relapse risk or people who are not going to remit are when they are younger age group, patients have larger goiters, patients who have got significant orbitopathy, smokers, male sex, and high or persistent TSH receptor antibody. This is TBIA as we call it. So these are the predictors where if you find these patients, these are probably people who you should be considering after a single course of ATD, you try to give them a definitive therapy. So how long do we give? 6 months, the remission rates are very, very low. So anywhere between 12 to 18 months or even up to 24 months is the period most trials do suggest to us. So you're comfortable with 12 months and the patient wants to give a trial of stopping. 12 to 18 months is a time period where you continue the antithyroid drugs, and which is important. And you then can stop the treatment and then check if your patient has remitted. What does the TRAB do? This is the TBIA antibody. This is widely available in today's world. It is not, this is slightly different from your TSI, thyroid stimulating antibody. This is only a marker of the condition, but this can predict if you've got a high TRAB, then the patient is unlikely to remit. When I mean high TRAB, the upper limit of normal is around, if it is 2.5, and if somebody has got a TRAB of about 7.5, 3 times upper limit of normal, these patients are not going to remit, and they'll come back to you straight when you stop the ATD. So this offers if somebody wants to be clinical, they want to know where people are going. So TRAB is something which would help us. You do a check when they start, you complete their course, you check your TRAB. If it is less than 2.5 or remains undetectable, and these patients will go off without any problem. So anything more than 7.5 is a high risk marker. So these are the patients you need to advise definitive therapy. So so as advised, we will continue the antithyroid drugs. Long-term methimazole and radioiodine, both for toxic adenomas and multinodular goiters, have been advocated, but the toxic adenoma group is the one which you really need to, it's not going to go away with any of these, and they are the ones who would straight away go for radioactive iodine. But if the patient wants some time with ATD, you can give them that. Multinodular goiters are both equal. The data for radioactive iodine and antithyroid drugs remain the same. So it comes up to patient choice now. And this is where the problem with both, when you compare in a toxic multinodular goiter, if you give antithyroid drugs, 3.8% only experience subclinical hypothyroidism, whereas 41% become hypothyroid just by giving radioactive iodine. So this is just only one study. 96% remained euthyroid on methimazole or carbimazole, 22% had persistence or recurrence of hyperthyroidism. Very minimal side effects. These, although we worry about agranulocytosis as such, they are fairly rare. As long as you warn your patient correctly and ask them to do a blood count, we are okay with it. And the side effect profile is very minimal, and reactions are very, very uncommon when they are on long term. Whereas 37% became euthyroid on a fixed dose of radioactive iodine. So long-term low-dose antithyroid drugs in multinodular goiter is very safe up to 100 months, and it's an effective treatment for toxic multinodular goiter. So if your patient prefers to have a 5 or a 10 milligram and say, doctor, I don't want radioiodine, you don't get upset anymore, just keep going with it, and tell them that you need to be on regular follow-up every 2 or 3 months and do a thyroid function test. So what about Graves' disease? Any evidence? And we are getting that also. So long-term antithyroid drugs as an option is also happening in the Graves' disease market. So there are multiple studies which we have given. I'm just going to go through a few snippets of information in these particular studies which we are getting quoted. This is just a long-term quality of life follow-up study from the Thyroid Journal, and treatment was compared with antithyroid drugs, radioactive iodine, and surgery. No significant differences were observed in the quality of life among all these treatments. But as such, this is a Swedish population, and compared to the normal reference population, the quality of life was diminished in most patients with Graves' disease, but they were all the same on all these treatments. So treatments didn't matter, whether it was radioactive iodine or drugs or surgery. So, but as such, Graves' disease is a problematic area affecting quality of life. should we consider just medications as such of prolonged treatment with antithyroid drugs? And this is a retrospective analysis who have failed 24 months of ATD, 238 patients, 114 in each group, long-term ATD, and the follow-up was around 70 months. And patients with Graves' disease who had relapsed after the first course were subsequently treated with methimazole or RAI, which was followed up for 6 years, around 6 years. The ATD group generally remained euthyroid and the inflammatory activity was much better. Body weight was stable and the feasibility of continuing their lower dosages was possible long-term. So without any further alterations, once they are established on a 5 or a 10 milligram of carbimazole or methimazole, they were able to continue that for long-term without the incidence of hypo or hyperthyroidism. So that's why they went on to suggest that longer lasting ATD treatment may be appropriate for lower dosages of antithyroid medications. So this was putting together all these papers. They did a meta-analysis again. So long-term ATD is effective, safe, especially in adults, indicating that it should be continued as an alternative therapy for treatment. So this is primarily with the reservations which we have already thought of and spoken of. It causes remission in a section of people, but it's no proof that continuing the doses will give lifelong cure. Side effect is a concern, but it's not widely prevalent. Compliance in our population might be an issue with the regular thing with both medications as well as clinic visits. So this is only disadvantage. All their clinical care in Europe is being paid by the government. Here, patients have to come here to visit us. Regular blood tests will cost our patients, whereas the government will be paying them there. Safety only with doses of around 7.5 and not more than that. And there are multiple drug interactions with our antithyroid drugs. So I've given you all the facts. So compared to radioactive iodine, antithyroid drugs are a potential equal choice for long-term management of Graves' disease, multinodular goiter as well. They are safe, viable on patients needing particularly a lower dose of treatment. The second option would be your radioactive iodine. Primarily, this comes to patient preference at the end of the day, provided the risk of hypothyroidism is well explained to the patient prior to therapy. And third, surgery remains always an option in a select group of patients. Thank you so much for listening.
Thank you, Dr. Muthu, for this thought-provoking lecture. And I'm sure there'll be a lot of questions. I'll set the ball rolling by asking, compared to say a decade ago, do you think people are doing, endocrinologists and other treating people are doing much less radioiodine treatment and opting more for long-term medical therapy in thyrotoxicosis or not?
I think certainly yes to that question, sir, because even in our own practice, we used to get upset with patients not going for radioactive iodine before. But in today's world, when patient comes with all the information, yes, if you want to continue. And it's also safe to continue this, and we've not had any issues with patients who are on a 5 milligrams of carbimazole for 3 or 4 years, and they want to avoid radioactive iodine for other societal reasons, or even by the thought. Some people are scared of taking radioactive iodine, however much you want to reassure them. So those are the patients who remain on these doses for a long term. So our practice has certainly changed in the last 5 to 10 years. We are more kind of leaning towards antithyroid drugs as a long-term management as well.
Thanks. That was a lucid presentation. I just want 2 quick answers. How's in your practice that you have seen associated thyroid malignancy in thyrotoxicosis? And is there any way of imaging modality where you can differentiate? And what is your line of management in, especially in the pediatric population with thyrotoxicosis, because they are more resistant? And how do you approach these cases?
The first thing is, as you're probably aware, sir, papillary thyroid cancer is quite common in the population, as well as it is prevalent in autoimmune thyroid disease. That's fairly like 1 in 1,000 we tend to see out of the Graves' disease patients we see. Generally, when we do most of our patients a technetium uptake scan. So if there is a cold nodule, once the thyroid control is established, we tend to organize an ultrasound and do an FNAC on it. The importance of controlling the thyroid function and doing the FNAC matters because your pathology report is going to be dependent on the colloid available. So if somebody is hyperthyroid, then you do an FNAC and it's going to be invariably reported as a follicular neoplasm. So that's one thing of note when you're.
That's because now some of the patients, they're very resistant to the treatment. When they are going to increasing dosage of antithyroid medication, I think that warrants an FNAC also.
Sure, sir. I agree. Second thing is children, we tend to keep on antithyroid drugs as much as possible because of the growing age. Although up to 12 years has been given, unless or until resistant treatments or any other complication, we try to avoid radioactive iodine as a treatment of choice in children. So resistant thyroid disease surgery is also an option, but antithyroid medications are the primary treatment in children.
We have time for just one more question. Or okay.
Thank you, sir.
Thank you, Dr. Murthy.
We'll move on to the next symposia. I call upon the chairpersons, Dr. Mohan and Dr. Kannan, to take over the session.
Thank you, Professor Krishna sir, for giving the great opportunity. Today is very interesting and important session on second generation basal insulin. It is regarding with addressing the time in range, the concept of time in range. We are in the era of precision diabetology. Let us see, it is the time to change from the good old HbA1c era to the new interventional diabetology, precision diabetology era, time in range. Let us see how this second generation basal insulin, especially focusing on the iGlargine 300, which addresses the time and range and glycemic variability, because these are all two important glycemic markers, important markers for to prevent microscopic complications. To discuss and to enlighten more on this topic, we have the eminent and dynamic speaker, Professor G. Vijaykumar sir. Vijaykumar sir is a great mentor, a great teacher, a well-wisher, and more than is a great human being. We are all associated, myself, Salopadan sir, and Mogan sir, Salamari, we are associated with the Professor Vijaykumar sir in a charitable trust work activities and also spiritual activities. Happy to invite you, sir, in this August audience. Welcome, sir. And Dr. Vijaykumar sir is a consultant at Apollo Specialty Hospital, Diabetes Medical Center, Chennai, and is an eminent diabetologist, renowned international also. He presented a lot of papers, both globally and this nationally, internationally. And the floor is for you, sir. Welcome, sir.
Good morning, my dear friends. Both the chairpersons are like my brothers.
Thank you, sir.
As Dr. Kannan was telling that it's not just colleagues in the same profession, but beyond that. Thank you for being with me all along. Thank you, Krishna and team, for giving me this opportunity, and also Sanofi for sponsoring this session. Now I'm given the task of speaking about the time in range, and especially focus on the second generation basal insulins, how they can be very, very useful for improving the timing range. Now, as Dr. Kannan was explaining, I think we are moving towards more and more technologically advanced investigations, where we can look into the time in range, which is a new concept. It's about 7 years old. which is coming into the, I'll tell the history of it even in the next few minutes or so. This is very interesting actually. So let me start with a case presentation and how this time in range can be very useful for improving the quality of life of this particular person. This is what we usually see in our practice. Many such patients, we see them, and then we need to know on which situations they're going to be very useful about the TIR or the time in range, how they can improve the quality of life. This is one thing which we always should understand. Improvement in the quality of life in the short run and in the long run. In the short run, improving the quality of life is reducing the fluctuation of the blood glucoses, the peaks and valleys, what we call peaks and valleys, hypoglycemia and hyperglycemia. So the peaks and valleys should be reduced to the great extent short-term period, and a good glycemic control with a good time in range will improve the quality of life in general. That is number one. Number two is that in a long run, if you improve the time in range of a patient over the time, you can prevent several complications, both micro and macrovascular complications. And that is the reason we need to always aim for a good glycemic control, the least glycemic variability, which is taken as a fourth dimension. Apart from fasting, postprandial, and HbA1c, we have a fourth dimension in the form of glycemic variability, which is shown scientifically. Definitely, that's a very important factor what we need to look into. Here is a case. You can see that is a 45-year-old. He had at the small age, you can see that is a type 2 diabetic for 6 years. And he had a myocardial infarction 3 years ago. And he is currently on oral hypoglycemic drugs as well as 2 premixed insulins. And the most important thing, if you can see that though he's young, he's quite obese, he's a vulnerable person. So you can see here, history of more than 2 episodes of hypoglycemia, especially one at a time, which has simulated something like a myocardial infarction. So especially a vulnerable person like this, the importance is that we should not create a severe hypoglycemia in this particular person. It will be very detrimental for the heart. Already is vulnerable. So, and there has been a noticeable weight gain as well. The moment you get hypoglycemic episode, there's always one thing concept called as defensive snacking. In order to prevent a hypoglycemic episode, you take too much of snacks which are calorie dense, and that's why you put on weight. It may not be just because of the anabolic hormone of anabolic nature of the insulin alone, but it's probably because of the fear of hypoglycemia. To prevent it, you can do such things. Now, if you look into that, he has been tried with the GLP-1 receptor analog, but unfortunately it has been stopped because he had a GI side effects. And then prior to admission for myocardial infarction, he had glibenclamide and metformin combination. At the time of discharge from there, he was provided with linagliptin, and glibenclamide has been stopped. And then he has put on 2 doses of premixed insulin, analog insulin. At present, after that, over the time, you could see that he has been taking metformin about 1,500. That's a half maximal dose. That's a good dose to be given. And also in a combination of empagliflozin with linagliptin. That's the best combination that you can give for one particular person who's got a heart issue as well. He's also on 15 units twice a day of premixed biphasic insulin. And of course, the other products like, anti-lipids and antihypertensives as well. You can see here at HbA1c 7.3, not bad at all. And then fasting blood glucose, because he's young, maybe 7 and less is a good idea, but it is not bad at all, 7.3. Fasting blood glucose is 128 and 164. It's not bad at all again. And of course, cholesterol is elevated and we need to look into that. As you look at the BMI, he's got 31 is a BMI. The most important aspect is that though HbA1c is 7.3, you could see that he has had the fluctuating range of blood glucose from 65 to 220, and then HbA1c is still 7.3. This is the most important thing. In spite of having a fairly good HbA1c, fairly good fasting and postprandial, but you can still have, you can see that the range of blood glucose, you can see that from 65 to 220, and this is not acceptable, and this is not desired for people who want to control it better. And then, of course, symptomatically, he has been once admitted with hypoglycemia, severe hypoglycemia, which is admitted there. Now, with this background, how is this time in range is going to help us in improving the quality of life and improving the glycemic control, reducing the glycemic variability so that we prevent complications. This is the overview of TAR, and we'll concept and what are the clinical implications and what are the recommendations, the global recommendations, and addressing TAR. And if you're unable to do that, basal insulin therapy, how it can address, because TAR is based upon, we need to look into that by doing a CGMS for at least 4 days to 5 days. We need to do CGMS, and then only we can find out the TAR. Now, this is that, the concept is changing from triad, from fasting, PP and HbA1c towards adding, glycemic variability and hexac we call it, and hypoglycemia, especially nocturnal hypoglycemia. In fact, I would rather like to add also weight gain into this. So the concept is changing. So moving towards reduction of glycemic variability, reduction of hyperglycemia, reduction of hypoglycemia as well. This is very important. So we need to look into that. Now, why should we look into the glycemic variability? It's very, very simple. See, there are two things what we need to know. One is intraday glycemic variability and interday glycemic variability. These are the two things, the fluctuation happening in the same day, or some day, one day it may be normal within the time and range, second day it may not be in time and range. So one of the things why such things interday and intraday variability happens is because when you take an insulin, which may be a good one, no doubt about that, but they may be not a predictable action of insulin, that is predictable PK/PD. Pharmacokinetics and pharmacodynamics may not be predictable as you desire. It's not that they are bad, but they are not as desired by you. And so you need to select an insulin which is desirable for you, where you can reduce the glycemic variability so that, PK/PD is more predictable. So like that, now, what do you mean by predictability is that suppose you give an insulin, today it reduces by 100. Tomorrow it should reduce either 90 to 110, but one day it reduces only 40, one day it reduces 200. This is interday variability, which is not desirable, which is not helpful for preventing complications. Now, the more and more glycemic variability, that is peaks and valleys, I'm telling, it is definitely evidence to say that it leads to high oxidative stress and causing endothelial damage, and then also increase the risk of hypoglycemia, which is not desirable, especially like a patient like what we're looking, already got a myocardial infarction. It can be very detrimental. Now, this is what happens. Now, this particular patient, if you can see that HbA1c is 7.3, look at this one particular slide. If you can see, there can be 3 situations where HbA1c is 7 and less. But in spite of having 3 situations, the same HbA1c, you could see that the time spent in time, 58% is in higher blood glucose levels, and it was only 18% time in range, and 24% was in hypoglycemia. Still, it can be HbA1c. Look at the extreme here. It is totally 24 hours is a time in range, but still HbA1c is 7, and in between you can see different one actually. So we can have a different, we can have more and more time in range, less in time in range, low in time in range, and high in time in range. Still, we can still have a high HbA1c of 7. And this is where, because of the peaks and valleys I was talking about, and that is the reason you can still have, you cannot be detected. This thing cannot be detected unless you do TAR. Now, this is how the history goes on actually. It is hardly 8-9 years old. The concept has been started in 2012, but by Hemsley Charitable Trust, the first expert panel. But it is only in 2019, ATTD, that is Advanced Technologies and Treatment for Diabetes, they came out with an international consensus on time in range. That is in 2019. And immediately, if you can see that ADA, ACE, and ACE, everyone has started looking into including this TAR as an important factor for management of diabetes. And you can see that in 2021, this year, if you can see, ADA says that CGM, that is the continuous glucose monitoring, is an important tool for hypoglycemia prevention. Apart from good glycemic control, which they said, advocate the use of CGM in various patient profiles, and then prevention of hypoglycemia is the one which they've indicated as well. Now, what is exactly time in range? Time in range is nothing but, in a simple way to say, is that if you keep between 70 to 180 in the whole day, that means you are in time in range, 70 to 180. And then you got this is actually given by the expert committee from ATTD, where they have given this particular thing. If you keep between 70 to 180 blood glucose, then it is called as time in range. And above 180, if you can see that high range and very high range. High range is when it is between 180 to 250, and very high range is more than 250. These are the two things. Similarly, low range, if you can see, if it is 54 to 69, it is low range. Less than 54, it is very low range. So these are the 4 categories you can see that 1, 2, 3, 4, 5 categories you can see that. But most of the time, we need to aim to keep as much as possible in the time in range. And it is said that it is also recommended that if you can keep the time in range at least 17 hours in a day, 17 hours in a day, and minimize above target, and the below the target should be less than 1 hour. This is for in general population. This is not population specific, in general. So you can see here, this part of it, you can see that, and then if you can do this, it will improve. In fact, the scientific information which is available today, we could see that if you improve the time in range by 10%, the HbA1c improvement is going to be 0.8. And this is the phenomenal result that you can get. Just improving the time in range by 10% will reduce HbA1c by 0.8. And this is how we need to look into that. Now, again, by improving 10% improvement in TIR can reduce the retinopathy, nephropathy, and neuropathy, and which is known to that. And then global recommendations, again, the specific population, as I said that initially what I said is like this, and older high-risk population, we need to keep the range around 50, and 180 to 220 should be not more than 50, and then high range should not be less. And then you can see that a population who are in high risk, the hypoglycemic range should not be more than 1%. If you look into that, here it is 5% in the normal population, here it should be less than 1%. And similarly, you can see that pregnancy and type 1 diabetes and pregnancy and gestation type 2 diabetes, you can see that in diabetes and pregnancy, the time in range is extremely high. So as much as possible, you need to keep that. So the ADA, as I said, that came out in a statement stating that we should, the additionally time below target should be minimized, and then it should be kept most of the time in 17 hours, at least in 70 to 180. And so that we can get no doubt why, if you can see here, even the AAC, AC guidelines shows that CGM is preferred. Lifestyle therapy, ongoing glucose monitoring, CGM is also preferred here. So this particular person, due to erratic SMBG profile and all, he was suggested to, why don't you go for a CGMS so that we can find out the time in range. But most of our patients may refuse to go for CGM. That is number one. The second thing is that it may not be reachable for every person, right? These are the two things. Either it's not reachable for everybody or it's not available. So what we need to do is, like this particular person refused to do that, many of our patients may also do that. I don't want to do it. So in this situation where it's a good one, but is still there an insulin, which can, without doing in CGMS and timing range, you got an evidence to say that one particular insulin is probably a good one to look into the improving TIR. So that's what we have to look into that. So addressing TIR with with a basal insulin, we can see that, as I said, that is seldom done. So if there is any basal insulin, in spite of demonstrated benefit with TIR, as it is seldom used, let us look into insulin which can be useful without even doing TIR, which should be evidence-based. That's what we looked into that. So what happens is that when you give a good basal insulin, which is a predictable, as I said, that predictable PK/PD profile, and then you can prevent the peaks and valleys because predictability is there and easy to monitor and easy to titrate and fix the dose. These are very important. So it prevents hepatic glucose output. And then even basal insulin will reduce the postprandial bad glucose as well. So both the things can be reduced to a great extent so that you prevent hypoglycemia and hyperglycemia. Now, if you can see here, definitely the U300 of glargine, which has been there, has been found to be having a better predictable PK/PD value in what you can see that in this particular study when they did the insulin clamp study. So you can see that difference is there. And furthermore, when they did further studies compared to another second generation degludec, there seems to be U300 seems to be slightly better. That is the 22% lesser, 23% lesser variability has been found with particular insulin. Now, these are all done in type 1 diabetic patients so far. How about type 2 diabetes? Is there any study to say that there is an improvement in type 2 diabetes? In this particular study, if you can see that compared to the two different generation insulins, you can see that both are having a good time in range, both the glutec and as well as the U300. But there seems to be a small edge in reduction in hypoglycemic episodes with U300 compared to insulin. Both are very good insulins, no doubt, and time in range is as expected been there for both. And when we did the flash glucose monitoring, again, nocturnal hypoglycemia seems to be lesser with U300 compared to degludec in this particular study. So, friends, if you can see that the glycemic variability and time in range both are associated with increased risk of associated with increased risk of severe hypoglycemia, diabetic complications, and reduced quality of life. And if you can improve the TIR to greatest extent, then there is a very good possibility of, you can see that there's a very good possibility of improving the quality of life, improving the HbA1c, and in turn, in the long term, we can prevent complications as well. So the second generation basal insulins demonstrate an improved GV, that is the glycemic variability, than other insulin regimens because they got a predictable PK/PD, that is pharmacokinetic and pharmacodynamics. And among the second generation insulins, according to the evidence so far we have in these particular trials, we can see that there seems to be a small edge war in the U300 glargine compared to the other, a very good second generation basal insulin in the form of degludec. Thank you for your patience here.
Very excellent, elegant talk, sir, on glargine 300, alluding all the aspects of time and especially in the intraday glucose fluctuations and also nocturnal hypoglycemia with an evidence-based analysis on bright and addition trials. So, and thank you very much, sir. We have the next speaker. Thank you, sir.
Let me have the pleasant task of introducing already introduced speaker, Dr. Muthukumaran Jayapal. So I would be elucidating on evolution of basal insulin optimization approaches over the past 2 decades. So welcome, sir.
Thank you, Dr. Mohan. I think everybody is gearing up for lunch and a Sunday break. So myself and Dr. Vijay Kumar won't keep you long. Thank you so much again for the opportunity. My task for this afternoon is give you a broad overview of how to go back and look whether we are doing the right thing with our basal insulins. So how glargine and other basal insulins have evolved. And I'm just going to have a look at a small area of how to do use the patient's knowledge to deal with things. So as we are all swamped with our type 2 diabetic patients, we are all ramped up with patients needing insulin as we go along. And I have to remind you that diabetes is a progressive disease, and most of our patients go on to tablets and then multiple drug regimes, and 10 to 15 years later, they'll be ending up on insulin. but the choice has been more better with the start of basal insulins because it gives us just a nice intro for the patient to start off with a basal insulin rather than a premix to start off with, especially with a type 2 patient. And the conventional approach has been like giving them a fixed dose, or whether should we calculate the basal insulin dosage by basically using their weight, or what medications are they on. 4 decades ago, we used to stop all medications and we used to move on to insulin premix as such. That was an old idea, but things have changed in the last decade or two, that we have used to continuing our regular diabetic medicines and then adding on insulin. And this has been a bit of a smoothener, as I would say, in our type 2 patients, especially. It's easier to approach them with a once daily insulin, start them on a very low dose and start working on them. And there has been lots of suggestions from ADA, EASD, and our local experts as well to start your basal insulin at a predetermined dose, especially 10 units a day or 0.1 to 0.2 units per kg per day. And there's been wide varieties of guidelines and expert opinions saying that. And it's always better when you start a basal insulin to start at the lower dose and then start working upon, with the primary aim in the first few weeks of starting insulin is to avoid hypoglycemia. So if you give an episode of hypoglycemia to your patient in the first month after starting insulin, you become a non-starter. So that doesn't work at all. So the primary aim is avoiding hypoglycemia to start off with. So going back to a case, this is a regular patient, probably around 10 years of diabetes, who's on metformin, glimepiride, sitagliptin, and insulin glargine 10 units at bedtime. So a 58-year-old male retail shop owner who has been initiated at insulin glargine at bedtime. He doesn't have major complications. And as most Indian patients, his BMI is on the lower side as well as 22.8, and his blood pressure is normal, and his A1C is 8.5 with a raised fasting sugar of 175 and a postprandial of 230. And his lipid targets are fairly okay. So what should we do? With his fasting sugar is 175 and he's just on 10 units of basal insulin. So most people I'm just going to be a little bit of a local setting. Checking your sugars become very, very important. Not many of our patients after even 10 years of diabetes would have a glucometer. So that's a reality even in a city like Chennai. Most people may not be monitoring, and primarily monitoring becomes an important tool when you're starting insulin. And the second thing is pre-insulin initiation education is also a very, very important part when you start your basal insulin. So checking on their diet one more time. Most of the time they might have been on a diet plan which has been deranged for so many years. And this is a golden opportunity to recheck their diet, recheck their lifestyles, and then put them on insulin. And adding on to that would come as your glucose monitoring. And only when we do these basics, we might be able to titrate our insulin further and bit more effectively. And this graph clearly shows how we can titrate our insulin over a period of time. And just by checking your fasting sugar 2 or 3 times a week, you can bump up your Lantus insulin over a period of time over weeks, whereby your HbA1c will be significantly coming down. The patient which we have just saw is a classical patient who was progressing in the diabetes and has got a high fasting sugar. When the fasting sugar is high, you do not need to majorly worry about hypoglycemia as a problem. So you just need to keep bumping on as long as the patient is following a good diet and lifestyle. What does it have to add in the current scenario with many patients turning us to ask for vaccinations and do what should I do for COVID and things like that? So there is a lot to gain with insulin initiation or even glucose control for severity of COVID. And if you do get an infection at any point of time, and if you're well controlled or poorly controlled, you stand to gain a lot more. And this graph particularly shows this with multiple studies being collated together. And the first study showed that your ARDS risk goes down significantly. You are halving your ARDS risk post-COVID by 50% if your sugar control is good rather than worse off. And the chances of you getting a kidney injury also significantly goes down, and same for heart failure as well. And there's been multiple studies regarding poor outcomes in COVID. So this is probably an important time to bang the knowledge into a patient for insulin up titration. And many a times, there's, as many international bodies have pointed out, achievement of glucose to a decent level of a HbA1c of less than 7% is lacking in most of our patients for many reasons altogether. A titration of medicines is part among it. And most of the studies, when you're looking at glycemic targets, half the population would not have reached their individual glycemic goals as well. Mostly it is due to physician inertia, patient inertia, and lack of titration of insulin also becomes a part of it. So there are multiple factors which are contributing to the titration inertia. Primarily, as a physician, you don't want to, when you want to talk about insulin initiation, you need to spend some time to your patient, and time is a lot of the time a rare commodity in our clinics, busy clinics. So reluctance of the HCP is a big problem, including me as well. So you kind of try to, if you're in a busy clinic, you try to put it to the next time. And the patient obviously has got more than 4 or 5 answers already before you talk to them about insulin initiation. I've got a wedding to go, need to travel. Can I come back? My mother-in-law is not this time here. So many reasons for avoiding insulin comes from the patient. Weight gain is a bit of a problem which patients are really concerned about, but you can really reassure your patient by telling them there is absolutely, if the diet and the lifestyle changes are made correctly, it's very, very rare to gain much weight on insulin. So the problem with weight gain is only an issue once your diet and exercise is not matching up to where it should be. Fear of hypoglycemia is a lot of the times a historical problem, because most patients might have had problems with older insulins in their parents, grandparents, and so that has to be eradicated. And that's why the newer insulins are more advantageous to us. The education about insulin primarily has to be done by the doctor and a dedicated person in your clinic, which could be any healthcare professional, your diabetes educator or a dietitian, and tell them that quality of life will not be affected, and we have got flexible insulins to improve quality of life, and which will not affect. Primarily, we tell all our patients to inject themselves rather than getting somebody in the family to inject. If they are not, if they're able enough and they should be injecting their own insulins, primarily to keep up the flexibility, so that they don't become dependent on somebody. The initiation by a staff nurse nearby or having injections doesn't work for diabetes at all. So we actively discourage patients who walk into the nearby clinic for the insulin initiations. Complex titration regimes are not needed at all for basal insulin initiation. All you have to tell the patient is to monitor 2 fasting readings and maybe a pre-dinner reading, if at all you're going to give your insulin at night. That would help you in titration of insulin. Monitoring is a must. It can happen depending on what the patient is affordable as well. You can reduce it to the lessest need possible, but 0% monitoring is not something which we would recommend if the patient is on insulin. So overall, it's about educating the patient, spending a little bit more time, and you really need to hit when the iron is hot. So really, where your patient should be in a listenable mood and actively listening to you when you're talking about insulin, rather than trying to go out and do things or going to a restaurant the next half an hour. So that doesn't work. So both the doctor and the patient has to be in the mindset of starting insulin effectively for the long term. So how do you address pre-mix insulin? If at all, by any basal insulin is good, as long as you're tackling it with a good diet plan, as well as the patients are regularly injecting it without missing your insulin, the risk of hypoglycemia is low. If you try to, this thing has been put up, but trying to manage a one-shot pre-mix insulin to control your sugars might not work. So each patient has got their suitability for particular insulin. So if they are progressing towards a high fasting sugar, a basal insulin would be sufficient. If they are into their 15, 20 years of insulin therapy, then a basal insulin might not be a choice. So you need to select your right patient to decide the right insulin, and you really can't work with once a day insulin with a twice daily insulin and vice versa. So that's where things tend to go wrong. If you're taking a premix insulin just once a day in the morning, which is sometimes a common practice in a city like Chennai, and trying to bump up the dosage will cause hypoglycemia at the wrong time. So comparing a basal insulin and a co-formulation, you will get obviously low sugars because of the prandial insulin in the mix. But trying to achieve, again, your patient is the primary member in the decision-making process rather than the insulin as such. So what has been happening is we have been having lots of hypoglycemia even with basal insulins in the past. And that has been primarily due to the very tight titration of these insulins for which they are not made for. And all these studies have shown higher risks of hypoglycemia because of the same. And what we have learned in the last few years is you don't really need to aggressively manage by 4 units at a time and go up and get your fasting sugars to below 80. Since nobody's advocating that anymore. So the newer studies that Atlantis and Goal A1C have clearly shown that actively titrating the thing helps, but not too far, too much. And educating the patient also becomes more important. So this would be just one thing, which is a slow go process, but you're effectively doing a titration period. And as long as things fall into place like a block, you will be fine. So if at all you drop your fasting sugar less than 80, then that's the time to cut back. And it also depends on the number of years of diabetes and the age of the patient and their lifestyles to decide upon all these decisions. So just by the insulin and the sugar doesn't matter, but their lifestyles become also important in the finer details when you go too close to the target. So that's very important, and monitoring becomes the key. So as I said earlier, SMBG should be performed at least twice a week. A process of up and down 2 units independently to the patient gives them some independence. They can do that with a fixed good diabetic diet. And then they can ask your advice if at all they need to do any major changes. So that's a helpful way of dealing with adjusting to the fasting sugar rather than making many changes. Certainly this data is interesting and just put me to smiles that probably patients, when they're correctly educated, are better than doctors. So they do their job better at home rather than waiting to come back to see you at the clinic. And once they start seeing the results, they would be taking it further. And education again becomes a key for insulin titration as well. So they are equally as good as the doctor here in this particular study. So what are our local barriers here in approach? Obviously, we understand that we have a select mix of patients, and sometimes we do have very low levels of awareness of insulin necessity in our patients. So that's a big problem. Compliance is a big issue all over the world, and it's also a problem in our country. Patients' time and resources, because patients are spending money out of their own pockets in our country, whereas things are different in Europe and US. Insufficient monitoring due to lack of resources, and also education is also a big issue. And the financial burden, which is burning our patients' pocket, is also a big issue. So simple titration algorithms and education is again the key, which is, there is no more importance to say this again and again. So a patient-centric approach, you have a contract, unwritten contract with the patient, you discuss with them, let them agree, and then you start the insulin initiation. Would work better in most of our type 2 patients. Some form of structured education might also help them, whether it's the doctor or the nurse, which will be helpful. Getting your pre-insulin initiation assessment is also key, so that their diet plans are corrected prior to insulin initiation works better. So the key things from I want to take home from here is titration inertia can be easily managed once you address the fear of hypoglycemia and weight gain. Those are never a big problems according to us, as long as you correctly do the insulin titration and educate the patient. patient-friendly approaches are much, much better, and you give them a little independence, they'll take it forward, reassure them that just by adjusting your insulin by 2 units won't cause hypoglycemia. And the thought of people becoming unconscious by putting 2 units of your basal insulin, being comatose at night doesn't, you need to, basically they go by movies and what they've heard from their friends and families. So we need to particularly reassure that. Keep your regime simple, not too many drugs, clear up the mess and put them on basal insulin, things will work. Thank you so much for listening.
So now the floor is open for discussion, sir.
So let's start the ball rolling with the question.
Please.
Like, we've been talking about the way in which it has unfolded over time. The fasting has always been the most difficult period to control. So the fasting has always been the most difficult period to control. The newer insulins and regimen, have you achieved anything better with it?
Sir, it depends on where your patient is. So most of the time type 2 diabetes progresses as many years go by. You go from a single drug regime to 3 to 4 drugs at the end of 10 years. Provided that the patient has not altered their diet, this is a natural course of progression of the disease. So around the 10 to 15 year mark, you're going to need some kind of insulin going into the system. Maybe now we've got SGLT2s as well. We are probably postponing it for some more time, but we will need that amount of thing. And the high fasting insulin, despite following a fair lifestyle and taking the medications, tells us that the pancreas is probably needing some support. So the newer insulins have taken, if you compare with a good old insulinide for that matter, this clearly has no peaks. The newer basal insulins do not have any peaks, and the incidence of hypoglycemia is very, very low compared to the older insulins or the generics. So these are much, much better insulins. The weight gain is pretty low, and they more or less work for around 18 to 24 hours. So that's where the basic advantage is. And we can combine them easily with our medications on board. So you don't really need to stop anything to put your basal insulin on. You just switch to the next level, tell the patient that you're needing a little bit more, which will give you a lot more flexibility and easy control of fasting sugars. Sometimes we can, if people are having side effects with their very high strength metformin, you can also take it down a little bit to help the patient. So that's where these newer insulins help.
And the flexibility of timing has made a lot of change in people.
Absolutely.
It used to be bedtime insulin to start with, which had its own hypostressor piece. This has made a lot of difference.
Certainly, yes. You can use your glargine any time of the day, depending on what the patients and where they are showing a rise. So we've got patients who are taking it at lunchtime and 4 o'clock and so on. So it all depends on where they are needing it.
I mean, shifting just, do you still use a peaked insulin to cover one big meal? Does it work in some patients still?
I am fairly orthodox in our diabetes management. So when I think the basal insulin is not working, then that's time to move to a premix. Or if the patient is very flexible and wants more flexibility, then you even go for a basal bolus at that point. It all depends on what your patient wants. But trying to do premix job with a basal doesn't work at all. So you've seen prescriptions, people bumping up the morning premix up to control the next day fasting sugar, and you fall apart during midday or evening time. So that's where the things don't work.
So the question is to Vijay Kumar, sir. Yeah. So there is some talk regarding the albumin binding nature, pharmacokinetic nature with the high affinity of Degludec, sir, and comparing with the glargine 300. So this is the main reason with the Degludec, most of the hypoalbuminic patients going for nocturnal hypoglycemia and also some inter-day glucose excursions. What are the comments on this, sir?
I think there might be specific circumstances to individual patients. I really, we do not have enough evidence for commenting on such things. Maybe reps might be tuned to do that, but I do not have a scientific comment on that.
I think
Manjunath responds some.
Thank you for asking that question, Kanan sir. In fact, that has been one of the common questions that is asked about insulin degludec. Since insulin degludec binds to albumin, in cases of patients with lower levels of albumin, does it increase the risk of hypoglycemia? And I think the clear-cut answer, which we have seen in published evidence, is that if we see the ratio of binding of degludec to albumin, it is 1:10 to the power of 6. That means for 10 to the power of 6 molecules of degludec, it is just one albumin that is required. So even if the albumin levels fall drastically down, there'll be absolutely no difference in the pharmacokinetics of degludec. And the proof for that is from both PKPD trials as well as the clinical trials. When we see the Kiss et al. And the Kobuke et al. Studies for degludec, which is conducted in patients with various degrees of renal impairment and various degrees of hepatic impairment. Both these conditions can cause hypoalbuminemia, but we have clearly seen that the degludec pharmacokinetics is clearly unaltered. And also a devote post hoc analysis was conducted specifically in patients with hypoalbuminemia, less than 3 grams per deciliter. And even in those patients, we see that the number of episodes of severe hypoglycemia was 3 with degludec, 7 with glargine U100. So that is the actual evidence that we have.
GVK, sir.
I have one more.
Thank you, sir.
GVK, sir.
Yeah. Dr. Mohan, you can go ahead.
No, I just wanted some other question. I mean, if you have anything to add to his,
No, not for that, but for the question that you asked, and then Dr. Muthukumar and Jepal was asking about that, putting them into a pre-mixed insulin in the morning and then trying to push the dose till then you get a good control of fasting. That's what you've been telling. You know, the problem with us is that, in fact, yesterday talk, day before yesterday, the first talk I was at, taboos of insulin therapy. I was speaking about that. And what we need to understand here is that, various guidelines which are coming basically because of the pharmaceutical industry based guidelines, which have been there influenced by that, are confusing the medical practitioners. What we need to understand is that basal insulin does not bring down only fasting, it also brings down the postprandial blood glucose as well. What we need to understand, the only thing is that fasting blood glucose is maximum contributed by the hepatic glucose output, which is easily managed by a small increment of insulin, such as basal insulin. Now, when you come to postprandial blood glucose, the 45% of the postprandial blood glucose is still contributed by the hepatic glucose output. It is a 55% of the glucose which is contributed in the postprandial blood glucose, postprandial spike is contributed from the carbohydrates that you take in the meal. So if you can, it is easily with even the basal insulin, the hepatic glucose output comes down, and whatever some amount of available insulin is there with endogenous insulin can bring down the postprandial glucose spike. It does not mean that basal insulin cannot control postprandial. It's not true at all. In fact, over the natural, as Dr. Muthu was telling, with the natural course of the disease, when the endogenous insulin reserves come down over the time, only then we need to go for intensification. As of now, we have the evidence from basal insulin alone is that we can have a good HbA1c control for at least 3 to 3.5 years without going for intensification, maybe adjustment of the dose, but not for going for more complex regimens like 2 premixed insulins. What Dr. Muthukumar was telling, I agree with him. Only when we have a basal insulin which fails, probably I would like to go for premixed insulin twice a day. And some people may say that co-formulation maybe once a day also may be useful. I mean, it is all individualized. We can do that as well. So I think we need to understand that basal insulin is a good one to start with for initiation of insulin because of convenience and good quality of life, with especially second generation basal insulins. And that's a good option that we can have.
Sir, I have one question regarding your talk. After with the antioxidant story, we always know that drugs are not the real answer. So between changing of drugs or titrating of different drugs versus using lifestyle to control the time and range, which would have a better answer?
No, again,
it's difficult to stick to.
It is again depend on the how do you get the time in range? See, it is different actually. Say a person who has got only a pre-diabetes and you put them on a lifestyle, you can get into time in range. We can time in range. As the disease progresses, as the more and more multiple pathology physiology factors come into play, then we need to be very selective in the drugs that what we are using. So any drug that can improve the quality of there is time in range with avoiding hypoglycemia is the best thing. Now, apart from second generation basal insulins, the time in range is improving even with SGLT inhibitors. Because SGLT inhibitors are not just good anti-diabetic drug, it improves the metabolic profile as well. So in reducing the resistance and everything, actually visceral obesity comes down. So many things does happen. So I think we need to, it is individualized again, and then we need to go for appropriate medication so that we improve the. But I think we are still in a nascent period of looking into TAR with many drugs. I think in the next 1 or 2 years is going to be exciting, so that more and more medications which will improve the time in range will get more evidence, and then we'll have better use of all these things.
Muthukumaran, what is the take-home message for the delegates? Which basal insulin is superior after analyzing this BRIGHT trial as well as EDITION trial? Your comments on this, please.
Don't embarrass him.
I'm not being embarrassed here because I'm not being paid by anything of that matter. But the thing is, it all depends on who your patient is. So if your patient has got a big pocket, you go for the newest insulin, which is the expensive one. And if you can afford it, that's fine. But in a nutshell, you as a doctor has to be taking care of your patient's pocket as well, so that they're taking the correct medicine for a longer period of time. So I think the newer insulins work. The thought of degrading one insulin over another insulin is not good at all, in my personal opinion. They all work fine. Compared to our older generation insulins, we have got newer insulins in the market, which are much, much better than that. One insulin may have an advantage and another insulin may have another advantage. And people have done things to do marketing, but that's not our job. That is the company's job to do in different ways. So they increase their pool. But in our suggestion, I think we have to use as a doctor to finish what is the right choice for the patient, with putting that on that equation, their pockets also into the equation. So that's where it happens. So
it is like asking for which DPP friend is better. They used to have question about 10 years ago,
Krishna has got something to say because he has got a bigger pocket.
Nothing, it depends on, where in the learning and maturity spectrum of a doctor that you are, right? When you come out, you have some arrows in your this thing, and you think that arrow needs to be used for everything. As you mature as a physician, you become Arjuna, and you know that this is the target and this is the insulin I need to use. For this person, this is the arrow I need to use, and for this person, that this is the arrow you need to use. So there are nuances that you learn that this kind of patient, this insulin works better. Ultimately, it is not just a cost. It's not just the VMI. It's not just which company is friendly to you, but also, there are nuances to this. I'll give you one example. In most patients, I don't think there's a difference between U100 and U300 or U100 and let us say Degludec. But let us say there's someone who has a BMI of around 22, 23, and the A1C is 7.2 and 7.3, right? There, a longer acting insulin, basal insulin, makes all the difference to get it down to 6.5. Because there, the glycemic variability is huge. On the other hand, in someone who's got 9, a BMI of 25, 26, it really doesn't, 8.5, 9, it really doesn't matter what kind of basal insulin is added there.
But can I play devil's advocate?
Once again, let me finish. If you have 12 and your A1C is 12 and your sugars are all about the place, then you can get a basal insulin to start, but with the knowledge that you need a prandial immediately through. So the important thing is that we start learning instead of lumping is basal better, is prandial better, is this better or that better? The answer is, as you started, and I just picked up on that, is that it's important to start learning what kind of patients will these nuances matter. For the broad middle, it probably won't. but there are on both ends of the spectrum where it probably does. And let me hear the devil now.
I think the devil's advocate is in diabetes management per se, there is no indication that we need to get levels below 7 at all in anybody currently. Exceptional things are different. So most of the insulins, what we have talked about, will be more suitable for most 95% of our individuals used in an appropriate fashion. So the talk of getting below 7 doesn't arise in most cases at all. And in fact, I advocate around 7.5 in my patients. So there we keep the risk of hypoglycemia low, we keep the risk of weight gain low, and we move on to a longer term plan rather than a short term, just achieving a HbA1c reduction, and the patient ends up being bloated out in the next 6 months.
Absolutely. So the important point is this, that at some point of time, this is an art, a nuance, not just individualizing it for the patient, but also working with the doctor's heuristics. So your 7 is not just a matter of evidence or just a matter of guideline, but it's a matter of your personal experience with your bunch of patients gathered over a period of many, many years. It brings it back to the same point. You're a consummate archer. You know how far this arrow is going to go. You know how this man's head is going to turn, and you will use exactly that arrow for that person. Comes with time, with experience, with this thing. So as I said, knowledge itself is not credibility. Credibility knowledge itself is not expertise. Expertise is not just credibility. And expertise certainly does not mean it's wisdom. So a person like you who's a master, who's a Zen master, can you feel the cold from here?
You have made my day. Thank you so much.
It brings in, and the reason that you're speaking in this meeting is for the young doctors who are listening to you to understand that expertise, no, he's an old master. That the expertise that you bring is exactly what we need them to learn, that over a period of time, you learn to start matching insulins with patients. So every insulin that comes in the market, there's no revolution in it. It's only an evolution. It brings something more that the previous didn't have. It doesn't nullify that the previous is bad. It doesn't also say that the good should not be used. The wise person like Muthukumaran will use all of them in the right proportion.
Thank you so much for that.
Pandit, please welcome.
So just one case, sir. One
Yes,
of
ma'am.
my good friend, male, 70 years old, 63 kg weight, and he doesn't have any complaint. But his fasting sugar is always between 180 to 200 or 220, and postprandial is 220 to 240, and his HbA1c is between 7.5 to 8 or 8.2, and he had been with sulfonylureas and gliptins all the time, and I don't know who is this diabetologist, but I don't know why they didn't start insulin for him. I know, because I always insist him to start insulin, but I don't know.
I think there might be, assuming that he has been seen by a physician, there might be other reasons why he might have not optimized his diet or lifestyle. Still, that might be one option.
He is following a very good diet, and he walks, does all the exercise. He walks with me 6 kilometers per day.
If he
is very fit.
If he's very fit, then we would, I think age is again another
70
number.
years.
Age is just another number. He's biologically fit. We would like to get his sugars to less than, at least fasting, to less than 110 at least, and his HbA1c around 7.5 at least. So that's what we should be working on, and he should meet his physician again and escalate his medication.
My question is to start insulin or not for him.
No, we should
but
look
his,
at.
always his fasting sugar is between 180 to.
It's not the only factor. If he's just on a sulfonylurea and metformin, he has got other
And
options
gliptins.
on gliptins as well. So he might be a good choice for a basal insulin because his fasting is a big problem. So he needs to talk to his physician about it and then take it forward.
So he has to take insulin.
Yes.
So to chair the next session, Dr. Sallo Pandian, I invite Sallo Pandian.
Yeah. So that's, thank you.
For want of time, thank you for the excellent Q&A session. We enjoyed it. Hope the audience did too. Please. Call upon Dr. Selva Pandit.
So we'll move on to the next symposium, and I would call the first speaker Rajiv Kovil. Yeah. Rajiv. Dr. He runs a Dr. Kovil's Diabetes Care Center at 2 branches in Mumbai, already introduced, and is a diabetologist, Holy Spirit, Arogyinity, and BSS Hospital, founder member in United Diabetes Forum.
Thank you so much. Thank you, organizers, especially Dr. Krishna, for getting out of that. Dr. Suresh Damoran, please be attentive while I talk. So I'm going to talk on linagliptin, role of DPP-4 inhibitors. And we all know that obviously diabetes has become a pandemic. Now the pandemic word itself has become dangerous, and it actually challenged mankind. But we know that a lot of abnormalities in patients with diabetes drives the abnormality that's cardiovascular and chronic kidney disease in patients with diabetes across. And we have actually looked upon a tagline as becoming the diabetes care capital in India. We have the prevalence of diabetes in India and the US is approximately the same, but the complication rates are much higher. So what are the treatment selections and what are the factors which complicate it? The most important rate limiting step seems to be hypoglycemia, because once the patient goes into hypoglycemia, the patient refuses intensive therapy. So whatever is an insunotropic agent helps patients. Cost, weight, a lot of, like we were discussing HbA1c of 7.5 or 8 in the previous, but whatever can affect the long-term complications and quality of life of the patient needs to be considered, making sure that durable therapy by itself improves compliance, and that itself will improve HbA1c. So there's a need for glucose-lowering medications which actually simplify. So it's diabetes treatment is doing simple things right. And owing to busy clinical practice of us, where we have a race against time, we have so many deadlines to meet, whether it's clinical research work and so many other things, there's a huge need for us to give therapy right at the go, that which is compliant and which the patient can be durable with over a long period of time. So paradoxical hyperglucagonemia has been a defect in patients with type 2 diabetes. That is why this incretin-based therapy came in, and out of which you have the GLP-1 and the DPP-4 inhibitors. What makes DPP-4 inhibitors so patient-friendly and doctor-friendly is one, insunotropic, so low risk of hypoglycemia, weight neutral, established cardiovascular safety on most of them, safety profile similar to placebo, no adverse drug-to-drug reaction, no timing or dosing issues with linagliptin, and good compliance. So when I read this slide, it took me back to the Hero Honda ad probably 2 decades back, which said, fill it, shut it, forget it. So if you have a therapy which you can just give, which can be given once a day, any time of the day, insunotropic, weight neutral, no drug-to-drug interactions, no changing in dosage based on chronic kidney or chronic liver, it makes the job much easier for all of us. But we need evidence for safety and efficacy. That's what we come down to. This is a meta-analysis of 83 randomized controlled trial, which looked at the efficacy of DPP-4 inhibitors in patients with type 2 diabetes. Again, this is not a head-to-head, but if you look at the efficacy of all of them, seems to be similar whether in monotherapy or in the background of metformin. Now, if you look at the efficacy of linagliptin as monotherapy and in combination with metformin, these are in newly diagnosed patients. This is an open label study. If you look at the baseline HbA1c is 11.8 and 12.1. These are patients who, according to guidelines, should be on insulin. So again, if you have patients in this particular bracket with osmotic symptoms, newly diagnosed, weight loss, ketosis, they need to be on insulin. But here you have data in this class of patients where you have monotherapy and combination therapy with combination therapy with linagliptin and metformin in naive patients, getting their HbA1c by 5.4% over a period of 26 weeks. So it is possible. And verified study with vildagliptin metformin again confirmed that putting an FDC combination or putting DPP4 plus MET very early on in diabetes makes a lot of sense, not only in control and durability of control, but also a pathophysiological approach where it showed adding 2 drugs at a time makes better sense rather than sequential add-on, which most of our guidelines tell us. If you look at this long-term glycemic efficacy with Lina versus an active comparator, which is glimepiride here on the background of metformin, glimepiride at 1 to 4 milligram dosage, linagliptin at a fixed dose of 5 milligram, you can say the efficacy of Lina is very, very similar to an SU, which is glimepiride in there. And this is a long 2-year, 104-week data. If you look at this data from Carolina, which was a cardiovascular outcome trial, Lina has 2 cardiovascular outcome trials, one versus placebo, one versus an active comparator. And this is the active comparator cardiovascular outcome trial, Carolina, which looks at there's a 77% lower risk of hypoglycemia with Lina versus glimepiride. So the efficacy is similar. Hypoglycemia is 70 to 80% less. And another important factor is weight. So here you have multiple benefits. So again, data from Carolina, which says that there is a difference of 1.5 kilograms over a long period of time with patients with chronic cardiovascular disease and chronic kidney disease. Again, convenience becomes extremely important. We know that follow-up in our country is abysmal. I believe Chennai is the best follow-up. In India, the follow-up is the worst globally. In Mumbai, it's only 20%. Only 1/5 of my patients come back to me. 80% are lost to follow-up or are doing doctor shopping. So it's very important that we give therapy, which is very, very convenient because that improves compliance of the patient. So what are the clinically relevant pharmacological characteristics? If you look at just linagliptin, it has a very high DPP4 binding affinity. Half-life is more than 100 hours. The TP4 inhibition has a good 24-hour action. Dosing you can do any time of the day. Again, because there is hardly any renal elimination, there is no accumulation of the drug. So no dosage requirement, which we all know. So when linagliptin came in, it was niched in that bracket of chronic kidney disease. But now we know that there is a lot of emergent risk reductions in patients without chronic kidney disease also. Again, in hepatic impairment. So now we, from last 10 years, diabetologists became diabetocardiologists. SGLT2s made us diabetonephrologists. CGMs made us diabetotechnologists. Now we'll have to become diabetohepatologists because hepatic impairment and non-alcoholic fatty liver disease seems to be the hallmark of metabolic syndrome, and that seems to be the harbinger of type 2 diabetes as such. If you look at this retrospective data from the US and UK, nearly half the patients on DPP4 inhibitors received unlicensed dosage. That's why I'm saying that 80% of our patients, especially in Mumbai, are lost to follow-up. You never know if you need to tweak that dose based on the EGFR. Most of the doctors don't even calculate the EGFR. If you have to base the dose on the EGFR, they are lost to follow-up. So it's very important that we give them a drug which doesn't require any tweaking, whether the creatinine is 1 or the creatinine jumps double. So again, data from developed country where there's good pharmacovigilance and a good structured care for patients with diabetes, 45% and 47% patients on DPP4 inhibitors were on unlicensed drug. Many would say, what happened? Let them be on unlicensed drug. What happens? But this data, real world evidence from South Korea says that this is, they looked at a cohort of 83,000 patients and they saw that inappropriate dosing of individual agents, 2 out of 5 patients on sitagliptin, 1 out of 4 on Vilda, no patients on Lina. But what happened is that the clinical outcomes were different. So patients where the dosages were not adjusted based on their chronic kidney disease or on the renal azotemia had all-cause death was higher, hypoglycemia, and emergency department visits as well. We need a real randomized control here to tell us that inappropriate dosing can cause a lot of problems by itself. If you look at dose adjustments in renal impairment, Lina is one which has very, very well established efficacy and no need of dose adjustment in whatever form of renal impairment. So whether it's stage 3, stage 4, stage 5, or patients on hemodialysis. Again, as I said, we all have turned diabeto-cardiologists in this whole metabolic jargon and metabolic blunders which is happening. Evidence of cardiovascular and heart failure safety. So in terms of DPP-4 inhibitors, all the 4 DPP-4 inhibitors have cardiovascular outcome trial where the 3-point MACE had looked at unity and linearity, and there's no signal towards any kind of cardiac events or cardiac problems. But if you look at heart failure, where obviously the eyebrows were raised with sevotemy, where there was a 27% increase in heart failure hospitalization and almost 19% with allogliptin. TCOS with sitagliptin and Carmelina with linagliptin again showed that they were neutral as far as hospitalization with heart failure goes. This data of Carmelina, which was a cardiovascular outcome trial versus the placebo, again reassured us that there's no increase in the risk of hospitalization of heart failure in patients who also had baseline heart failure. So again, very reassuring after sevotemy that these two studies, TCOS as well as Carmelina, there's no increase in hospitalization due to heart failure. That's why the ESC-EASD guideline 2019 very, very clearly mentions DPP-4 inhibitors, CETA as well as LINA, have a neutral effect on the risk of heart failure hospitalization and may be considered for DM treatment patients with heart failure. Because after sevotemy, there was a huge eyebrow raise where the gliptins and incretin-based therapies can be given in patients with heart failure. If you look at renal safety, so LINA has a proven safety and effectiveness in all stages of chronic kidney disease, right till hemodialysis, and also NODAT, which is new onset diabetes after transplant, and diabetes in renal transplant. And Carmelina, again, was specifically designed and statistically powered to evaluate both cardiovascular and kidney outcomes. Again, these were pre-specified analysis, pre-specified composite renal endpoints of sustained ESRD, sustained reduction in eGFR more than 40%, and renal death. So Carmelina demonstrated long-term kidney safety with linagliptin. So because of the SGLT2s and because of the fairy tale of EMPA-REG and so many other and DAPA-HF and DAPA-CKD, we expect our diabetes drugs to do more than what they're supposed to do. But here in this particular study, and the whole DPP-4 study tells us that there is no side effect, no adverse effects as far as linagliptin and sitagliptin goes. And again, these are pre-specified adjudicated kidney composite outcome, which says they favors linagliptin as compared to placebo. If you look at learnings from, again, Carmelina, there's a pre-specified 14% lower risk of progression of albuminuria and a 15% great likelihood of a significant regression in UACR. This is a post-hoc analysis. The regression is the post-hoc analysis, but the progression of albuminuria is a pre-specified analysis. Again, as I said, we have to become now diabetohepatologists, and the reason being that NAFLD is there staring at all of us, and almost 50 to 70% of our patients have some form of NAFLD, which will progress to chronic liver disease and cirrhosis, and then HCC further. Efficacy in HbA1c is not affected. Though this is a small study of almost 25-30 patients, but it looked at patients in more mild, moderate, and severe hepatic problems compared to healthy adults, and again showed that the increase in exposure relative to normal with linagliptin was the same. So any amount of hepatic impairment doesn't increase the exposure or the plasma exposure of linagliptin, and linagliptin is fairly efficacious in patients with hepatic problems as in healthy adults as such. So again, if you see DPP-4 in chronic liver disease, linagliptin is one which is approved, and Saxa is also approved there. But in hepatic failure, one needs to be on insulin. Now, evidence across a broad range of type 2 diabetes patients is extremely important, because here the two trials of linagliptin, whether it's Carolina or Carmelina, looked at two different sets of patients with cardiovascular and chronic kidney disease. Carolina had a low CV and a kidney risk, and median type 2 duration was 6.3 years, while Carmelina, which was a placebo-controlled trial, looked at a high CV and kidney risk, and median type 2 diabetes duration was almost 15 years. And together, you have a huge group of patients with a lower risk and a higher risk with cardiovascular and chronic kidney disease, which actually drives complications in patients with diabetes. So they provide ample evidence that across the broad spectrum of type 2 diabetes, whether CV and kidney risk, both Carolina and Carmelina put together, and whether in early onset chronic kidney and cardiovascular or advanced disease, it shows a lot of benefit. If you look at if you look at them together, whether it's 3-point MACE, HHF, cardiovascular death, or all-cause mortality in Carmelina or Carolina, again, neutral, again, no signal towards any kind of cardiovascular problems. Again, if you look at linagliptins, has proven CV and renal safety across the spectrum of chronic kidney disease. So whether it's 3-point MACE at various cohorts of EGFR or HHF or end-stage renal death, across EGFR, it seems to be the same. So again, safety is very well established in patients with hepatic, renal, cardiovascular, low risk, high risk, everything put together. Again, this paper again comes from the Carolina sub-analysis, a post-hoc analysis, which got presented at the ADA, looks at a group of patients, which is in the elderly, more than 75, where not many drugs have been used or studied. And here in this elderly population, it shows there's an 83% relative risk reduction in hypoglycemia in elderly patients as compared to younger patients. As again, Carmelina, again, no increased risk of cardiovascular, HF, or renal events. Again, in Asian patients, again, a post-hoc analysis which tells us. So again, so in addition to the RCTs, cardiovascular trials, you also have real-world evidence which actually builds our confidence. 2 real-world evidence from a US database and South Korean database, US database of 150,000 patients and South Korean of 500,000 patients, again telling us that linagliptin has a 23% lower risk of CV events versus the second generation SU and a 26% in the South Korean database. So if I could summarize, I would say 1 dose, independent of timing, I'm finishing, proven effectiveness and safety across a broad range of patients, no need for dosage adjustment in kidney or hepatic impairment, proven CV safety, robust evidence and guideline recommendation for effective and safe use in HF, long half-life, ensuring a 24-hour glycemic control. Thank you everyone for a patient care. Thank you.
Thank you, Rajiv. Yeah. The next CRM spectrum of OHS, I would like to call Dr. Suresh Damodaran from Coimbatore for the role of SGLT2 and metformin fixed dose combination. And he's a consultant diabetologist and endocrinology, Sri Ramakrishna Hospital, Coimbatore, honorary consultant in Dairy Food Hospital. It's yours, Suresh.
Can I have the presentation, please?
Yeah.
Huh? Yeah, it's been planned. So what they say is 2019 to avoid negative people around you. In 2020, it came to say that you have to avoid the positive people around you. In 2021, possibly avoid people around you. So anyway, yeah. So thank you very much, Krishna. And it's a great effort to have a physical meeting in the current situation. It is a company talk and it's a Boehringer one. And the disclosure is honorarium from them. Now, Rajiv has gone through gliptin, linagliptin specifically. Now, the other molecule, which is in the to be having efficacy in glycemic management with multifactorial improvement is SGLT2 with metformin. So we know when it compared with the Indian, with the UK population, so Indian patients had diagnosed at younger age and have central adiposity and HOMA score is high. So this is the priorities of treating type 2 diabetic. Not only the glycemic thing is important, along with that metabolic risk and also cardiorenal risk, with evidence pouring in with SGLT2s and GLP-1s. So we have to address the holistic point of view, not only the glycemic. So history, just a case wise, 52-year-old non-smoker, 9 years moderate activity, he's got the hypertension, is diabetic with poor control, A1C of 8.6. and diabetic dyslipidemia is there, and he's got a treadmill positive indicating a CVD risk is high. So this patient, diabetic, hypertensive, poor control with ASCVD risk, what do you do? And these should be the way to approach the management. And I'll show you the evidence of each area where early control is necessary, and also preventing the micro and macrovascular complication, and then quality of life is very, very important. So we know the drugs that is available in the market, which can address few issues. But if you look at the magic molecules that is present currently is SGLT2. which will address almost glycemia and avoids hypoglycemia. Weight loss is there, and blood pressure and lipid profile improvement is there. So EMPA with metformin has got an excellent evidence as treatment naive patients. For example, the combination drugs produced a significant A1C reduction when compared to given a single molecule. So on progressively, the baseline A1C with the SGLT2 with steeper decline in A1C compared to DPP4. So we know that, I think the evidence is coming out. So the SGLT2 has got much more A1C reduction than the DPP4. So another thing is comparing head to head with sulfonylurea. So EMPA versus glimepiride. So the advantages, it's not only the glycemic improvement, the hypoglycemia risk is less, and also perceived hyper and hypoglycemic state is much better in EMPA arm compared to the glimepiride arm. So EMPA versus glimepiride, that again, just to focus on the weight, there will be a significant weight loss. You can see the graph. It's a huge difference, which is statistically significant, almost 5. And that's what we experience in our clinical practice as well. So just to summarize that, it not only improves the glycemia, it improves the other metabolic things like weight and waist circumference. So, so we have to approach not only the glycemic point of view, but other things, which is the newly diagnosed patient has to have, if you remember the case, it is a high risk treadmill positive patient. So preventing the complications. So we know from UKPDS data, this is on all the diabetic talks. So CV mortality, CV disease and mortality improves with the intensive glycemic control, but that is not much evidence available at that time. But if you look at the EMPA-REG trial that has came out showing a clear difference in the early in the graph, you can see the difference starts early itself. So it produces 38% relative risk reduction. So EMPA consistently improves the CV outcome. You can see the graph coming this side, which is CV death, heart failure improvement, and heart failure admission. And so the whole lot is improved with empagliflozin, significantly reduced total CV events, and also atherosclerotic CVD. So it is significant. It is not like 10 or 12%. It's more than 22% risk reduction. So this is all the SGLT2 trials that is available, declared to me with DAPA and Canvas with CANA. So EMPA-REG has come out with the CV death risk reduction is more with ASCVD patient. That's why it is included in the guidelines to be included for a ASCVD patient to consider a few gliflozin, which is including EMPA and DAPA. So the heterogeneity is also noticed, more than 50% substantial heterogeneities. So it covers almost all the races. So in patients with atherosclerotic CVD and type 2 DM, CVOTs has demonstrated improve in CV outcomes without doubt. So these are the, if you look at the red arrows, it shows clearly significant representation of a significant reduction. So as Rajiv was saying, the real world evidence support the evidence that is as randomized control trial, but the real world evidence is the one which gives for the local population. He showed Korean trial, but I think if you look at the empagliflozin is being studied for a risk of major adverse kidney events with the cohort of almost 3 years follow-up, and it's published in the Diabetes Care in 2020. This is a 3-year duration trial and more than 3 lakh population. So MAKE events rate is much lesser when you do empagliflozin, almost 32% risk of major adverse kidney events with empagliflozin compared to non-SGLT treatments. So when you go for registry, normally Scandinavian registries are much more robust, and also European registries gives you a super duper comparison when you want to compare head to head with other drugs. So Again, just to show that improved kidney outcomes is much better in EMPA compared to the other group of drugs that is being given for the diabetic treatment. So the third half of my talk, which is showing the sustainable care, sustained diabetes management, along with the quality of life, good quality of life, how it works, because the DPP-4 with metformin compared with the SGLT2 with metformin, there is no safety worry in comparing that SGLT2 with metformin. So the genital infections and urinary infections are definitely higher in SGLT2 group, but not compromising the safety as a whole. So the drug events, one or more drug-related adverse events is much better in EMPA when compared to glimepiride as an add-on to metformin in type 2. So that is the data I've showed, the efficacy and weight initially with glimepiride, but now I think the safety-wise also it is much better when compared to sulfonylurea. So this is all well-read studies. Now, therapeutic persistence at 1 year with the first or second line therapies in patients type 2, persistent with therapies at first year, and second line intensification with the SGLT2 and metformin is much better compared to any other combination. So again, as I mentioned, the algorithm shows for ASCVD risk patients to go for SGLT2 inhibitors, especially AMPA, CANA, and DAPA are recommended in patients with type 2 and CVD with high risk of CV events. So if you remember, our case is a high risk patient. So combination of metformin along with the SGLT2 has got a robust evidence. And just to summarize, so what I've done so far is just to explain that SGLT2 has got, especially empagliflozin, had much more evidence in cardiovascular event preventing. So it is included in the guidelines. So when you approach a patient, it's not only the glycemia, but also the whole lot of metabolic improvement should be aimed. And I've also shown the real world evidence to show that the renal adverse events are much better when compared to empagliflozin, is much better compared to other group of drugs from a real world evidence. So just to summarize, effective glycemic control and low risk of hypoglycemia is present with the empagliflozin with metformin combination. So improved time in range also demonstrated in evidence, and then the significant weight loss compared to glimepiride, which has got a weight gain, and then the visceral adiposity also have shown evidence for that. And once the weight loss is there, and with other mechanisms also, with HOMA, IR, insulin sensitivity and glucose disposition is improved, and then the 24-hour BP is improved. We all, whoever we use the SGLT2s ourselves, we know there is a significant improvement in the blood pressure and the reduced risk of MACE that is being proved beyond doubt in EMPA-REG, and also MI and CV deaths with the ASCVD patients has been proved beyond doubt. So reduced risk of heart failure, that's a class effect. Almost all the gliflozins had got the benefit of reducing the heart failure. But kidney outcomes, I've shown you the renal data, but other gliflozins also got RCTs, which is showed CKD-CF. So just ladies and gentlemen, not metformin, not only just to focus on glycemic control alone, but when the patient is high risk ASCVD patient, you can consider intensifying the treatment even initially, so that it is not only the benefit goes with glycemia, but other improvement is there as a whole. I stop there.
Thank you, Suresh. Rajiv was telling that his drug linagliptin can be given by anybody, everybody at any stage of the diabetes.
Did you say that?
Yeah.
Okay.
But I want to know from you, this combination, where you're not going to give, just 4 situations.
4 situations you're not going to give.
Yeah.
Okay. Now, I think personally, if you want to take patients who had previous urinary tract infections, and this is a no-brainer. If you do have history of UTI or genital infections in the past, those are the patients I don't give. And the second thing is the patient, any patients in catabolic state, for example, going for surgeries, any inpatients with fevers and other things. So any catabolic state I won't give. And mainly, if you do have EGFR less than 30, that is another group. But apart from that, cardiac failure or suspected cardiac failure or potential to go into cardiac failure, patients will have a huge benefit. And what they say is ARNI group of drugs and SGLT2s where to give, and what the conclusion is, ARNI group of drugs should be started as inpatient, and then the outpatient should be SGLT2. So these are some of the areas that I can think of. Catabolic state, really elderly people with eGFR of less than 30 and previous history of UTI and genital infections.
Already patients who are on your thing along with the insulin, what are you going to do there?
Your question is whether
you're going to stop that insulin or reduce the dosage.
A patient is on insulin, you want to add on.
Yeah.
Is that right?
Yeah.
Okay. So yes, you need to, but you want to find out why you want to start an SGLT2 in the first place. If you want to do for a cardiometabolic thing, you can do, but insulin dose has to be reduced slightly, but it's entirely depend on the patient's A1C.
Any questions?
Question to
Rajiv, for you.
Yeah. So already diabetic patient whose HbA1c and everything, glycemic control is excellent. And can we stop all those medicines and start linagliptin with metformin? Like, can we stop the previous medications and start with linagliptin and metformin because of the dosage and timing and hypoglycemia?
So it all depends because if the patient is on multi-drug agents, which are secretagogues and has been a long-standing diabetic, no. But if the patient is on non-insulin secretagogues and milder, you can a DPP4 plus metformin combination makes it very, very easy for the patient. One, for preventing long-term complications, and two, in terms of quality of life. So yes. But if the patient, if suppose the patient is on 6, 8, 10 milligrams of glimepiride on 3 or 4 drugs, then you can't. So the golden rule in diabetes is add. Substitution doesn't make a lot of sense. If the patient is on lesser drugs, obviously it can be done. Yes.
So thank you, Suresh. Thank you, Rajiv. Now we'll go move on to the next CRM spectrum OHA by Dr. Krishna Sheshadri. And he's going to talk on the role of SGLT2 and DPP4 as a fixed dose combination. He's a consultant endocrinologist and Chennai Diabetes Forum. And over to you, sir.
Thank you so much. And it's so heartening to see that as we approach to the last 2 talks of this conference, that the support we've had both physically and online. And please note my conflicts of interest for this particular talk. I'm contracted out as a speaker, and I have always, and I've also received speaking honoraria for almost every gliptin that has been produced in this thing. The first thing to remember is to take a step back and look at how diabetes progresses. As those of you who heard Dr. Venkat Narayan talk yesterday and also learned the Nature paper yesterday that was described in great detail, must understand that our conventional ideas of diabetes are very, very, very changing, that we are not dealing with one disease, we're probably dealing with many diseases. And that Asians, of course, are somewhat different than the others. And one of the interesting things that Dr. Venkat Narayan talked about is that both the SGLT2 inhibitors and the DPP4 inhibitors do very, very well in Asians. Interestingly, I don't know how many of you noticed in that particular study, it's something that, I was waiting if Dr. Panikkar were there, I'm sure he would have raised his hands, but he actually showed that thiazolidinediones don't do so well in Asians. And so it's a very interesting piece of information that I'm waiting for Dr. Panikkar to actually talk about. But what we do have is that what causes people to become a greater progression of disease. One is, a higher A1C at the time of diagnosis, but that's also an opportunity for you to bring the glucoses down and reduce the glucotoxicity. In India, you will notice that diabetes is at least a decade earlier, and I'm sorry to see that as we continue to do night shifts, as we continue to work from home, as we continue to do these kind of pandemic-related activity, you're seeing that more and more younger patients And the last 3 or 4 months, I've seen so many in their early 30s who have become diabetic. Higher BMI is not a big Indian phenomenon, or you're seeing it there, but remember that in Asians that that higher BMI is a risk factor. And of course, the others are related to metabolic syndrome. What is important is for every 1% increase in A1C, the beta cell stress increases by 3.8%. What do you mean by beta cell stress? The effect on its mitochondria, the effect on its assembly, the effect on it producing a genuine, full, usable insulin molecule is reduced. But the good news is for every 1% reduction in A1C, there is a risk reduction of MI by 14%. And of course, we've had so many talks on heart failure in the past that the risk on heart failure, at this point of time, while we have dapagliflozin and the others, and the empagliflozin and the others on heart failure, remember for HFpEF, glycemia is still probably the only thing that works. Microvascular complications and macrovascular complications come down with A1C reduction. So when people talk about extra therapeutic, or core or non-core effects, remember the core effect is also important, that glycemia is very important. So this is the DISCOVER study, and you will notice that the proportion of persons, this is looking at the proportion of percentage of patients reaching an A1C of less than 7 was in early versus late. And again, this is taking from the accord, taking this forward from the accord, and you will realize that if you have gotten your glucose controlled within 6 months, right, then the proportion of patients with an A1C in the long-term follow-up is also increased. And that's one of the reasons that you will see these trials now coming and saying that early combinations means greater durability of care. The sooner you get to an A1C. Now the flip of this, as Matthew Riddle sometimes says, is that when you achieve control early, you are selecting out a bunch of people who are relatively healthy, a bunch of people who are easy to achieve, right? And therefore, the ones who don't achieve are people who are at risk for more, are basically a prognostic factor there. And what it's saying is that these are people you need to be extra careful. But the truth is that if you're able to get the glucose well under control in a majority of a patient, then you can actually concentrate on the ones who you're not able to get control and make sure, and these are the persons who are marked for more complications. So here is a 49-year-old man with a blood pressure of 135/80, a body mass index of 28, on metformin, amlodipine, telmisartan, rosuvastatin. On hypertension, diagnosis of diabetes for 2 years, metformin twice daily after 3 months of lifestyle management. Remember that most of us don't agree with this. You would want a metformin on the day that the diagnosis is made. Dose was increased to 2 grams when the A1C was 8.3. Now, the 8.7 fasting glucose is 165, postprandial of 280. The question is, should you add 1 drug? Should you have 2 drugs? Many of us traditionally would add a single drug, isn't it? You switch the metformin to DPP4, metformin FDC, and add SU, or continue metformin and add a FDC, that is SGLT2 plus DPP4. So are you going to add 2 drugs? Or are you going to add more? So the ADA 2021 says the absolute cost effectiveness of most oral medications is rarely 1%. I think this is something we should remember. That the average drug at an A1C of 8 gives you 0.6 to 0.8. That's it. If you need more, you need to have 2 drugs. This is something we want to remember. Exception, an injectable SGLT2, GLP-1 RA, and maybe a very high dose sulfonylurea. That is the second one you want to think about. But most of us think that you need 2 drugs. The one thing you want to remember is 1 plus 1 is not 2. 0.8 plus 0.8 is not 1.6, it's 1.2 or 1.3. Right? So the AACE says that consider dual or triple therapy if the entry A1C is greater than 7.5 to 9. And they did this not just in the 2020, they did this a long time ago. And of course, the RSSDI ESI is saying if it's greater than 1.5, which 5 above the target, start thinking about this thing. And the RSSDI is pretty much based on what the ADA says. So what is the advantage of starting 2 drugs one being an SGLT2 inhibitor, another being a DPP4 inhibitor. One, that these work in some ways complementary. They don't work as much as we thought it would do when we first thought about this concept, but in the gut, it increases the incretin, in the liver, it decreases the glucose, it decreases the glucagon in the pancreas, and there is some amount of counteraction. And they both work, the SGLT2 inhibitors, while there is no receptor for it in the beta cell, by just reducing the amount of glucagon in the alpha cell, the DPP4 inhibitor by reducing the amount of glucagon in the alpha cell, and the SGLT2 inhibitor taking off the glucose load in the body, actually improves the work of the beta cell. Muscles, they increase the glucose uptake, and the kidneys, there is decrease in glucose absorption, and there's an increase in urinary glucose excretion. There's a particular article that was published in 2020, and basically it says, as I started off, that there seems to be a greater benefit for the use of both SGLT2 inhibitors and DPP4 inhibitors in the Asian population. This is EMPA or glimepiride as an add-on to metformin, and you will realize at the end of 4 years, you will notice that empagliflozin is as good as SU, and this occurs over a period of time. And one important thing is that there's a 9 times lower risk of hypoglycemia. We talked yesterday in a communication workshop about, the one thing that I was itching to interrupt and say, but I didn't, is that the moment patients have hyperglycemia, the moment the patients have a bad experience, they do 2 things. They reduce and they skip their doses, and they come and tell you lies. Because you threaten them, they come and tell you, "I'm a doctor," and then one day you will keep on increasing the insulin or the OHAs, and one day you'll get a call from the emergency room that this patient is admitted, and he says that you're his daughter. Right. So this is linagliptin is also similar to glimepiride with a 5 times lower risk of hyperglycemia. And this is lina versus glimepiride in Asians, again showing that the odds ratio of 2.16 in achieving key secondary sustainability endpoints, which means maintain glycemic control, no need for rescue medication, moderate, no hypoglycemia, and no increase in weight gain by 2%. This is very interesting because and something that we have not talked about so much, because if you look at Bo Aaron's work, she actually will tell you that when you add a DPP4 inhibitor, it not just prevents hypoglycemia, it may probably also protect you from hypoglycemia. And that's one of the reasons I use DPP4 inhibitors with insulin a lot, because it gives you that extra kick, because the moment the glucose goes down, it pushes up the glucagon. And the moment the glucose goes up, it pushes up the GLP-1. So how does this impact beta cell function? These are models for insulin resistance and beta cell. We've spent a lot of time in the last 2 days, especially in the evenings of this. I'm going to skip this. But one of the interesting things to understand is when you give empagliflozin, there's a decrease in insulin resistance versus placebo at year 1. And linagliptin, as part of a DPP4, increases pro-insulin-insulin ratios, changes the HOMA-B, and probably these work together. So when you put these 2 together, you know sulfonylureas are on the other hand. The combination seems to be that with SGLT2 and DPP4 inhibitor, you have a lot of benefits, with additionally the off-target benefits of SGLT2 inhibitors. So this is metformin plus sulfonylurea. It's very, very powerful. Don't let anything fuel this. This is metformin plus DPP4 inhibitor. Low risk of hypoglycemia is added to it. And when you have a metformin plus SGLT2 plus DPP4 inhibitor, you probably have all the benefits put together. This particular patient, 49 years old, with type 2 diabetes, metformin, uncontrolled hypoglycemia. The fixed dose combination actually works. This is just telling you the same thing. In addition, I want you to remember that the weight is improved. There is decreased uric acid, and you've had enough CVOTs in the past 10 years to tell you everything else that you needed. So the FDC works in low baseline and in high baseline, and it is quite durable. And a significant percentage of the population will reach an A1C of less than 7, irrespective of whether they've been drug naive, as the ESC now talks about it in many patients, or if they're on metformin background. In addition, there is a modest weight, blood pressure, and serum uric acid reduction. And there is no increase in the hypoglycemia with a combination. One of the interesting things that we've always talked about is that when you combine a SGLT2 inhibitor with a DPP4 inhibitor, there seems to be a lower risk of genital tract infections. There are some crazy hypotheses about this, including receptors for DPP4 in the mycotic colonizers. But irrespective, we know that clinically this makes a difference. So here is this person uncontrolled on glycemia. So achievement of metabolic control is there. This 1.8% is a stretch, but at least you will get close to your target. There's blood pressure reduction, that is good. Now, a lowering of the hyperglycemia, of the hyperglycemia risk, a lowering of the genital infection risk because of the DPP4. And of course, in someone who has not established CAD, we don't know if this contributes in the long run to CAD prevention. If somebody has established not established CAD, we don't know about long-term CAD prevention, but certainly there's improvement in heart failure, certainly improvement in benefit of renal failure. So this is what we have. There's a strength of evidence, there is safety, and clearly these two drugs in combination, except for the initial time when you still want to be vigilant about GU, there is benefit over a period of time. And of course, there are the man who did the real world evidence is lurking somewhere here. Shashank's in the other hall speaking, and we do have very, very good data that looks at the fixed dose combinations doing well. So this is a meta-analysis, a two-part multi-center trial, 83 sites, and you will notice that there is an A1C reduction of minus 0.82 with EMPA with LINA as opposed to EMPA versus placebo. And this is EMPA plus LINA versus EMPA versus placebo, and this is the adjusted mean A1C. Two things: early reduction, sustained reduction, and durable reduction. And this shows that the odds ratio of reaching an A1C less than 7 in the combination is about 29.5. That's really amazing. And this is the percentage of patients who maintain an A1C of less than 7, the 9.9, and this is it. I won't get too much into this. We've spent a lot of time reviewing data. So the safety is there. Of course, this is EMPA-REG outcome, which I won't spend time. Stress-free usage, it's both it is recommended for heart failure. We have renal evidence with Carmelina for the LINA bit. We have hepatic evidence which shows that there is some benefit, at least in terms of reduction of liver fat and AST and ALT. This is the E-LIFT study. There's minimal risk of hyperglycemia we've talked about. It's a once-a-day pill. You fill it, shut it, and forget it. And of course, this is something you've seen before. This is the combinations that are available: EMPA plus LINA, DAPA plus SAXA, and REMO plus VILDA. EMPA has the highest evidence base in this. The DAPA SAXA, there is some issue with the heart failure with the saxagliptin in the heart failure group, but I guess it gets neutralized when they are added together. With REMO, it's very cost effective. The one thing that you want to remember is that the data to support the off-target effects are not present. So I'm going to stop here quickly, that the metabolic cardiorenal continuum that we talk about with diabetes is addressed by the DPP4 SGLT2 combination. And I think a continuance of this patient tells you a lot of information. I won't go into much of this. Just give me a minute. But what we do know is, one second, is this, that there is a benefit of having combinations in treatment, ease of use, and when it comes with the A1C reduction that we need, and when it comes with some benefit, irrespective of the spectrum, whether they have established disease or not, I think it makes a lot of sense. To summarize, this patient is one of those candidates where an FDC can be used. Can other things can be used? Absolutely. Can you use as SU on top of it? Absolutely. Work with the patient, individualize, discuss the events, think about the long-term cost implications, make sure the patient is comfortable with the choice, respect the choice, and don't get upset if the patient doesn't want it, but always work with the patient to improve his or her quality of life. I'm going to stop here and thank you. I don't know if I've ran over time. Thank you so much for your patience.
So
and again,
questions,
thanks
sir.
for being here. Yes.
Two questions, sir. This is I think this you add on drug only you started. Will you start this both DPP4, SGLT2 and metformin in drug naive patients?
Oh, yes. If the A1C is much higher, absolutely.
and two conditions where you are going to use only SGLT2 and DPP4.
Okay, if the patient, I'll tell you something. My respect for metformin is present, but it's not huge. In many ways, metformin is like doing Pilliyar Puja. You don't. If in the olden days, if you went to a conference and you didn't say diet, there'll be 15 people jumping up on you. The same is with metformin. It has a cult status, but we don't know if it deserves its cult status. And especially in some patients, for example, let us say somebody has come to me with a coronary artery disease, established ASCVD, and they found out he has diabetes in the hospital, and he comes to me, let's say a week later. I wouldn't start him on metformin right away. I would get the SGLT2 inhibitor first. This is one. Second, in patients who are intolerant of metformin, I want you to know that so many of our patients undergo endoscopies and then they come back and you stop the metformin and they get better. I would definitely start this. I am so tempted to also tell you that in patients with ASCVD, at least based on two studies, that metformin may actually be antagonistic to the off-target effects of an SGLT2 inhibitor. I'll tell you why. Both of them work by AMPK, but SGLT2 has the additional work on HIF2. When your AMPK is maximally stimulated, any additional SGLT2 inhibitor is not going to give you the effect that it alone is giving. So there are two studies, both subgroup analysis of one of the what is it called, the canagliflozin data, the CANVAS trial, that showed that in patients who were taking metformin, the salutary effects of canagliflozin were lower. So clearly, this is one area where I would, if somebody has established ASCVD, somebody has established heart failure, I would first go. Also in my practice, if I want weight loss first, I would rather start an SGLT2 inhibitor first and maybe add a metformin. This is personal view. Huh? This is not the thing. So I actually think an SGLT2 inhibitor is a earlier, better drug in somebody I want to get good weight loss, because metformin brings weight loss, but it's very low. If I can make a patient get 3-4 kgs down, that gives them the confidence, and I can always add metformin later. It's not that I won't touch the metformin, but why should I do this first? I have these many options.
Thank you, sir.
Thank you. Thank you so much. Appreciate it.
I would like to call the next speaker, Dr. G. Vijaykumar, for the Empowering Cardio-Renal Metabolic Outcomes in Type 2 Diabetes, Foundational Place of SGLT2 Inhibition.
Good afternoon. And thanks, Dr. Krishna. I mean, in fact, I was the opening bat and also the closing bat as well. Mohan was telling me. Thank you again. And then let me tell you, it's very, very difficult to speak after 3 people Doyens have spoken. Rajiv, Krishna, and Suresh, all 3. So let me see if I can do something nice. In fact, Dr. Krishna exactly stopped it where, he said that cardio-renal metabolic outcomes. He just stopped there. And then I'm just continuing after what he has stopped there. So how this foundational place for SGLT2 inhibition, how is it can improve this cardio-renal metabolic outcomes? I would like to also say that there may be a few repeat slides, but it is worth looking into those slides, because I'm going to speak to you how these SGLT inhibitors are going to fit in to especially the Indian population, Indian phenotype. I've always been very fascinated by the Indian phenotype, which is definitely a different phenotype, and our response to the medicines are different. And how these SGLT inhibitors are going to fit in exactly and fantastically to our phenotype is going to be a good discussion. We know that diabetes is not just hyperglycemia. It is interrelated. If you can see here, it is an interrelated disease of metabolism, atherosclerotic CVD, heart failure, CKD. There is a continuum. It starts with insulin resistance, and then it is also said that at the time of detection of diabetes itself, about 100 out of 100 patients would have had some or other endothelial dysfunction, right? It is said that actually 50% of them may be having all the complications like hypertension, dyslipidemia, obesity, something in there. But it is said that endothelial dysfunction would have been started. This is what is called as a ticking clock hypothesis, because the mild hyperglycemia has been there about 10 years earlier than what we have been thinking about actually. So it's a continuation because hyperinsulinemia in the initial stages can be atherosclerosis, microvascular disease, myocardial infarction, stroke, chronic kidney disease, heart failure, and cardiovascular death. And all of us know that in type 2 diabetes, about more than 85% of the people die because of some macrovascular event, either a stroke or myocardial infarction. And our idea should be that we need to reduce that burden. Now, if you look into the clinical priorities in type 2 diabetes, very interesting actually. And this is the priorities and the philosophy of treatment of type 2 diabetes should be like this actually. And you should improve the compliance and also improve the quality of life. You should have intensive control, where we can see that we've spoken about time in range quite some time ago. And then we can see that we have to improve the time in range. And whenever you're trying to use the compliance and quality of life, we should ensure that you achieve the HbA1c goal without hypoglycemia. That's a very important thing. So that improves the time in range again further. And then if we can see that once you have a time in range, you reduce the glycemic variability so that the oxidative stress comes down. And then it's a cardio-renal risk continuum where you can see that there is, especially compared to Caucasian population, Indian phenotype, there is increased risk of rapid decline of renal functions. So this is again a comparatively Indians are more progressive in renal failure, renal disease. Even if they set in, the progress to progression of the disease is faster among Indian phenotype, Indian patients. And then we know that there is a premature CVD risk in amongst the people because one of the things is that it is said that type 2 diabetes happens at least 1 decade earlier in Indian population. And we are a different phenotype, we have a insulin resistance which is 1.5-fold more compared to Caucasian population. And then we also have that the so-called Indian phenotype where we are called as thin fat Indian. BMI may not be very, very high, but you got more visceral obesity, visceral fat is more, abdominal circumference is more, and so that more insulin resistance, and then this increases the possibilities of hypertension, dyslipidemia, and all these things will be there, so that insulin resistance is also more. So first, let me look into that. See, we are a different phenotype, and then first I will look into the metabolic implications of SGLT inhibitors and how they can improve the life, and then later on I will go into cardiovascular and renal outcomes. So we need to look into these aspects, like whether SGLT inhibitors are going to improve the HbA1c as well as time in range, and whether it has got any say in visceral adiposity, because this is one of the most important things, insulin resistance. More adiposity, visceral adiposity, more free fatty acids, and more insulin resistance. If you can reduce the visceral adiposity, if you reduce the waist circumference, automatically the insulin resistance also will come down. And along with that, a milieu of things also can reduce hypertension, dyslipidemia. So that indirectly it can improve the insulin sensitivity. And if it can change hemodynamics, and is it able to reduce inflammation is a big question. And I think we have evidence for everything. And we have got evidence to say that. We know that though the DPP-4 inhibitors are slightly better than white population in reduction of HbA1c, but there is no doubt to say that SGLT inhibitors are more effective in our people compared to Caucasian population. And this is what we have been found. Though the trials say that about reduction of 4 kilos of weight reduction in most of the trials, which is a majority of the patients are in Caucasian population, but in our practice and the data that is available for various centers in our country has clearly shown that the weight reduction is also different from our patients. Like in efficacy in HbA1c reduction. They are more responsive, even with the DPP-4 inhibitor, because they are more effective in Indian phenotype compared to both DPP-4 as well as SGLT seems to be more effective in our population. And then it is quite obvious that, because of the metabolic milieu benefits that we get, we can see that the moment you add empagliflozin to people, you could see that the time in range, this is in green color, you can see that there's an improvement from the first day onwards. You can see here for 55 to 70 at the end of 1 month. 1 month, you can see that 4 weeks, you can see that it is improved from 55 to 81%. It can happen for the first day. And that we find the EMPARAG outcome, we can see that the benefits start within the first few weeks of benefit. Similarly, the time in range is also seeing improvement in the first day itself. And then, so what happens is that compared to glimepiride, you can see that in the background of metformin therapy, based upon the HOMA-IR, if you can see that definitely empagliflozin seems to be having a reduction in insulin resistance far superior even to the other molecules. Now, and if you can see the EMPARAG outcome, this is a study which is being done apart from the cross-section analysis of EMPARAG outcome. What has been found that at the end of the 4 years, you can see that the number of people who required insulin initiation has been reduced to almost 20%. So apart from that, if you can see that the requirement of the dose also comes down by more than 20% once you add empagliflozin. That has been found in EMPARAG. This is something new data that is available. And then more and more evidence to state that this is ELIF study, where you can see that even the hepatic steatosis, NAFLD improves. NAFLD improves. This is again secondary because of it improves the visceral adiposity, reduces visceral adiposity, reduces the waist circumference. The moment the free fatty acid levels comes down, naturally even the ectopic fat that has been found in the liver also will come down. And apart from that, if you can see that there is an improvement in steatosis, lobular inflammation, hepatocellular ballooning, NASH resolution improves, fibrosis improvement, fibrosis resolution, everything will improve. This again probably indirectly, most likely indirectly. So this is how metabolically the SGLT inhibitors, how they can be metabolically improving the situation. Now, how about cardiorenal implications with SGLT inhibitors, where we have to see whether it can reduce the major CV events, if it can reduce CV death, heart failure, hospitalization, and then whether it improves the cardiac structure and function. This is what empagliflozin has done, and kidney outcomes as well. Now, whenever this empagliflozin has been found that, there's always been a criticism or debate saying that probably this is not a molecule that can be used in primary prevention, right? Because in EMPARAG outcome, everybody has got a high-risk population. There is no low-risk population in that. And so what they have done is that they have found some information in about 2,000, close to 3,000 patients from CV safety of empagliflozin meta-analysis of phase 3 studies, where they have found that it is only in that if you can see the empagliflozin group in placebo group, only 13.4% as a coronary artery disease, peripheral artery disease is shown in 2.6%, and cerebrovascular disease in 5.9%. That means low risk population in this group has been found. And then even in this group of people with the low risk population, you could see that 4-point MACE, 3-point MACE, and CV death and hospital heart failure have significantly reduced compared to placebo. So this is where that I always believed in that, that it probably is a class effect, most of the SGLT inhibitors. Now, EMPARAG outcome, if you can see that the meaningful early and sustained reduction in CV death has been found, that is 38% risk reduction has been found. And that you can see that the lines separate very early in starting that, like what we have seen in the TAR, you can see here also actually. Now, and the way it is able to reduce the CV death, empagliflozin consistently reduces CV death, regardless of what is it, whether it is a single vessel disease, multi-vessel disease, or a history of CABG, or you got a prior myocardial infarction or not, in all categories. Similarly, if you can see that whether you have peripheral artery disease, prior stroke, prior heart failure, and history of heart atrial fibrillation, any category, you can see that there is a reduction in CV death. And the way it reduces the CV death, whether it's a fatal MI, fatal stroke, in heart failure related, sudden death, presumed CV death, everything you can see that by empagliflozin is able to reduce the CV death. This is what the empagliflozin claims it's superior over the other molecules. Now, see, there is also one of the interesting thing is that this is a secondary analysis of EMPA outcome study, is that this is able to, empagliflozin is able to reduce myocardial infarction by 20%. See, when we always used to say that the benefits are because of you reduce the, we reduce the morbidity because of you're able to reduce the heart failure, which is equal in all the three molecules. But whereas here, if you can see that in this particular analysis, where they're able to reduce the myocardial infarction by 21%, and it's a very interesting finding that they're able to get it. And if you can see that the various outcome trials that have been seen, that is including ertugliflozin, we can see that. And this is a slide already that Suresh Damodaran has put in. What is most important thing is that those patients with the ASCVD, there may be a reduction in the MACE issues, but whereas MACE risk reduction, but when it is without ASCVD, there seems to be not a benefit in other molecules as well. And if we can see that there seems to be heterogeneity. And even if we can see that even CV death, if you see that, and when there is no ASCVD, there seems to be no benefit except in credence, where renal failure patients have been there, and there seems to be some benefit. So there seems to be small differences between empagliflozin with other molecules. As far as the heart failure reduction, risk reduction is concerned, it is equal with every molecule that we can think about. And if you can see this again, a slide Dr. Suresh has already put in. What is most important is that major adverse events, hospital heart failure may be good, but as far as the CV death is concerned, there seems to be superior to empagliflozin compared to other categories. And as far as the CV risk reduction, the renal benefit is concerned, we are yet to, I think next year, I think we are going to get the results of the EMPA renal study. But we can see that the improvement that has been seen in people with EMPA outcome with various categories of normal or high, mildly decreased eGFR, mildly moderately decreased, severely decreased, and kidney failure. In all categories, there seems to be benefit by using SGLT inhibitor in form of empagliflozin. There seems to be definitely worsening of nephropathy across all risk categories has been reduced with empagliflozin. This is a very important thing that we can. And the same benefit seems to be seen even with non-diabetic population. No doubt why nephrologists say that it's a nephrological drug with a diabetic benefit. It's like cardiologists are saying. So you can see that Emperor R, that is the Emperor is the empagliflozin in reduced ejection fraction, and DAPA CKD, DAPA HF, you can see that even in the non-diabetic people have been found to have benefit in CKD. No doubt why in most of the algorithms, you can see that whenever there is like Dr. Krishna was also telling that if you got ASCVD, I would like to go for a SGLT2 inhibitor like that, and then in ADI standards of care, you can see regularly it says that ASCVD benefit is seen with empagliflozin and canagliflozin, not with the DAPA. And as far as heart failure is concerned, it is neutral between all the three molecules. And then progression of DKD also, it says that all the three molecules are equally good. And then it is also said that ESC says that apart from the reduction of CV events, all the three molecules may be used, but it is empagliflozin is recommended in patients with type CVD to reduce the risk of death. Similarly, liraglutide also has been included in that, not the other GLP-1 receptor analogs in reduction in CV death. And these are the various drugs. And so let me conclude to say that the usefulness of SGLT inhibitors it has definitely revolutionized the management of diabetes and prevention of cardiovascular disease, heart failure reduction, and even CV death. In fact, there is a reduction of MI by 20%. Now, that's a very important thing that we need to think about. If you're able to reduce an MI, if you're able to reduce hypoglycemia, if you're able to reduce hospitalization for hypoglycemia, if you're able to reduce the renal vascular disease, it is going to be a great benefit, because management of diabetes may not be too expensive. It may not be easy. It is quite easy, but managing a complication is going to be expensive, and it is going to, trouble the both family and the patient, as well as the physician who is attending a lot. So prevention is the key, either primary or secondary prevention in the continuum, cardio, metabolic, renal continuum, and where I think we need to utilize these particular molecules without fail. Thank you for your patience.
Yes, sir. One question, sir. Because in your more than 3 decades of practice, you have been using all the first generation sulfonylureas, I think all bicarbonates, everything. But to put it in a single word or something, what will you say about SGLT2? Because diabetes itself is a cardiovascular vascular continuum.
See, what is it we are forgetting is that SGLT inhibitors, apart from being renoprotective and cardiovascular protective, we should also remember that it's a very good anti-hyperglycemic drug. No, especially in combination with metformin and other molecules. We can see that they're very, very effective in reducing the HbA1c, reducing the blood glucose, reducing the BP, reducing the weight, reducing the Indian phenotype of lipids. It reduces triglyceride, increases HDL. The typical Indian phenotype. So I think we should not think about only we have to use it only for cardiovascular disease patient and we can't use it for other patient is a myth. It's a wrong opinion. I think in my practice, if the patient can afford, I would like to put it as along with us, that Krishna was also telling, I would like to put it in every patient SGLT inhibitor, unless you develop some side effects to that. Why not? See, the management of diabetes over the time is changed. The philosophy of management is changed. We are no more trying to treat hyperglycemia. We are trying to treat pathophysiological factors which cause hyperglycemia. And as of now, we have 8 pathophysiological factors. And if you can address as many pathophysiological factors as possible without causing hypoglycemia, without causing weight gain, or if you can reduce the weight gain, that is going to be the most beneficial. So I think definitely, as I said that earlier, that it is revolutionized management of diabetes, and then SGLT inhibitors have got a great role in our armamentarium.
Thank you, sir.
When a patient who has got an established CVD, well controlled, he doesn't have pain, doesn't have restlessness, not anesthesia, with possibly microalbuminuria and hypertension, if he's a non-diabetic, will you use SGLT2? In an IGT patient, will you use? In a well controlled, with other drugs is excellently controlled, would you use SGLT2?
No, you mean to say that you want me to comment on non-diabetic population?
Non-diabetic population with other factors, that IFPIG, well proven
Definitely, yes. Because, suppose you are not on SGLT inhibitors, with all that ASCVD that you have, renal microalbuminuria is there, and definitely I would reduce the other drugs and add on SGLT inhibitor, because it is proved beyond doubt that it reduces the microalbuminuria to normal albuminuria, from macro to micro, and micro to no albuminuria. And then progression of the renal disease is also improved with SGLT inhibitor. And there is definitely difference in cardiovascular benefits as well. In that case, I think probably I would like to reduce other drugs and put in SGLT inhibitor, because you also said that if established ASCVD is there. So I would do that, definitely. Huh? There is no evidence. But IFD and IGT, if they're obese, by putting them on this drug, definitely I feel if you can reduce the weight by about 10 kilos or 12 kilos, it is going to be beneficial, and I am doing it. That is my personal, I am doing it, but there is no evidence to state.
Thank you, Jigma sir, and thank you, Krishna sir.
So before we close, I just wanted to. There's a reason why you are also the player and the Mangalam. When we first started out, debate in Chennai. I reached out to 3 of my friends, Dr. Vijay Kumar, Dr. Venkatraman, and Dr. Anand Moses. 2 of them are ill, and they are blessing us from there. But I want to make a special mention of the man who has never left our side, who has always given us the encouragement, and has always been a person. So I'm going to let him have the last word of this conference. And hopefully next time when we meet, the trio will be here to bless us. But on behalf of them, the last word of this conference and the Mangalam is done by you.
Okay. Thank you, Krishna. I mean, in fact, the journey has been there for almost 7 years now. I always admired my younger brother, Krishna. Can I say that? My younger brother, Krishna? You are.
Call me your older brother.
Oh, no. Even if you don't agree, I will say that. So, I mean, it's always been a fantastic journey together. In fact, I mean, one way, Rajiv, we are blessed with a great teams here, actually. I mean, we may have differences of so many things, but when it comes to matter in medical education, we are all together. That's what we have been blessed with that, actually. And then one of the people who made the difference is one other person like Krishna has been always there. His, in a knowledge and, the way he can say that. He comes with that out of the hat suggestions to me. Out of the hat, whenever, I'm not very happy, in fact, in our 3D meeting, which has been very successful meeting over the years from APDF, he, Dr. Anand Moses and Dr. Venkatraman are the basic scientific advisors, and they prepare the scientific program. And every time, even if he doesn't attend every meeting, suddenly he says, I am coming and I got some topics for you. And then it makes a difference in the whole program. I mean, that's why I said that, last this meeting, out of 3 or 4 meetings, he could not attend 1 or 2 meetings. But he called me and said that I want these topics to be included. So this is how he gets involved. And, it is reciprocation.
The master of all trades.
Yeah, definitely. I mean, history.
Evidence-based medicine, technology, what more do you want?
So, in fact,
The monotony of the conference.
No, and I can't imagine any program that I do without Krishna and also my good brothers here. They're always in part of us, that Mohan, Selapandian, Kannan, and then Rajesh, Gauri Shankar. You can see that all of us work as a team, whether Krishna does and I does, and even when they does, both of them do a lot of programs. We're all part of the program. So we have been with each other, and this is what makes any program very successful. No egos, nothing. We are down to earth. And unfortunately, I was not feeling well yesterday, so that I could not attend. So he said that you are the opening batsman and you are going to be the last batsman as well. I think like India did in the yesterday's match, I think even Krishna has won the hearts of everybody. And then, I mean, you can see the scientific program that he has created and single-handedly has created. And then, he recognizing people like, he said that Dr. Murthy, should be recognized. He's the senior most endocrinologist of our state. He's probably the first second endocrinologist. He's the second endocrinologist of our state, and he's recognized him. This is what Krishna makes a difference. And then he also got one more doctor, which is Dr. Narasimhan from which place? Schollinger, who does lot of service there, and recognizing Dr. Narasimhan and putting his name as a hall, which we usually do, like Banting Hall, West Hall, like that we say that. Instead, recognizing people and and honoring them for what they have done to the community, fraternity, is another innovative thing that he has done. And then 3 months ago, when you told me about this idea that recognizing 2 months ago, recognizing these 2 people, I said, you've done a wonderful thinking. That's what, when you told me about that, I think that's what we need to do that. we need to recognize people when they're still active, and then it's a very good idea to do that. And I think I would also appreciate that what he has said that, and then you can see that I know last week when I was here, he was struggling to make this program a success because in hybrid meeting is not easy. No, we were thinking, oh, we'll do hybrid meeting, and only when he told me, explained to me that how difficult is it to do hybrid meeting, combining things is not, and then he's able to somehow overcome all these difficulties and is able to do this hybrid meeting, which is something innovative again. Is another thing. I think it comes up to you, Krishna, for doing that. and then the organizing team, which includes Rajesh, Gauri, Mohan, and Selapanyan, and Kannan, Ushayagari,
And Sanjay Reddy.
Sanjay Reddy. Sanjay Reddy is primary team. Sanjay Reddy and Dr. Prasanna Kumar and Bhavna and Krishna, they're all together. But local organizing committee, I think hats off to them. They stayed with Krishna for all the last 48 hours or so, and have been very, very useful to successful conduct of the meeting. And definitely, thank you very much.
I just want to thank all the audience who came here in person, and so many of you who took a risk for us, a risk for science. We may not have been a large number, but we were the ones who showed that there is a world beyond the pandemic, and we will rise above this. As I said, there was a time when we started debate, we started in this hotel, and we couldn't have space for people to stand for lunch. Someday we will overcome this and come back. But till this time, I hope this conference has given you a memory. Lastly, I want to thank the pharma friends who stood by and said, no, doctor, it doesn't matter what the numbers are. It doesn't matter anything else. That we are making a break and we are there with you. Thanks for everyone. Again, my greatest thanks to Sanjay and my two mentors, Prasanna and Arvind, and all my teachers and everyone here. Please have lunch again before you go home. Those of you at home, please have lunch thinking of us. We shall come together again and we shall overcome this. Please take your vaccine if you have not. Don't worry about 1 or 2 side effects. Make sure you're there and vaccinated. We need to have a life beyond this. Thank you so much. Variya Sendamil, Varga Natramila, Variya Bharata, Manithirunadu, Vande Mataram. Thank you.